Hi, a very good morning to all. I extend a warm welcome to all the participants, students, and delegates for the Scientific Global Digital Gathering at the 6th EPUCG 2021. I'm Sabine Bukhari, currently working for NHS Scotland as a dentist, and I have done my MPhil in oral pathology from King Edward's Medical University, Pakistan, and MSc in regenerative dentistry from King's College, London. So we are here at the platform of UCGConferences. Utilitarian Conferences Gathering offers a wide range of events, meetings, conferences, workshops, symposium. We have a dedicated team who are aimed at acquiring the technologies, adopting the knowledge of business needs, and accelerate with best ideas and strategies. Utilitarian Conferences Gathering is a pioneer in the area of event management, collaboration, and we are a full-service event provider specializing in the field of medical, clinical, healthcare, life sciences, engineering, pharma, environmental science, engineering, business, agriculture, and food event services for academic and industrial sectors. We stand out distinctively from our competitors for our commitment to quality, round-the-clock service, and unmatched price. We are able to provide you with the best event meeting experience under one roof. We are at Utilitarian Conference Gathering, make sure that you as client choose the most appropriate event. I thank you all for finding time in this busy schedule to be here today. Today marks a major activity in the brief existence of the UCG conference, a moment where we are interacting, sharing experiences, and reflecting on various areas. So UCG 2021 is a remarkable event which brings together professors, researchers, and students in the field of pathology, making the online conference a perfect platform to share experience, foster collaborations across industry and academia, and evaluate emerging technologies across the globe. We cordially welcome you to join us and witness the advances in this field together. The conference has attracted delegates who have come from all over the world across the conferences, and the subject of the conference is surely of global importance. UCG thanks all the individuals and organizations who have worked to make this conference a grand success. EPUCG Program Committee has put in long hours with many creative efforts, and finally, I would like to extend my appreciation to the participants of the conference. We hope you enjoy the conference and that our participation will contribute to our professional development and relationships. Please note, speech timing for speakers will be 30 minutes and speech timing for keynote speakers will be 1 hour. UCG conferences will be awarding the best presentation, best poster, best informative sessions, and best keynote presentation. It will be judged by the committee panel and experts on the basis of research work, presentations, skills, information, and awareness provided. So certification will be provided on February 12, 2021. Award will be provided on February 15, 2021. So now I take the immense pleasure of introducing the keynote speakers at the 6th EPUCG 2021, Dr. David J. Shulkin, 9th Secretary of the U.S. Department of Veterans Affairs, USA, Dr. Zeev Lifa, the Lifa Institute of Molecular and Digital Pathology, USA, Dr. Michael Retzke, USA, and Dr. Andreas Lübke, Head of Orthopedic Pathology and Vice Head of Cytopathology, Germany. So thank you very much all. We will now begin with the speaker presentations. So let's start, and I call upon our first speaker, Dr. Liam Bebo, Australia, to deliver his speech. Thank you.
Thank you very much, everybody. I'm just going to share my screen. Hello, everybody. It is my pleasure to be here today to present to you all. My name is Dr. Liam Bibo, and I am a surgical registrar working in Perth, Western Australia. I have a special interest in surgical anatomical pathology, with my topic today being an overlap between the disciplines of breast surgery and gynecologic oncology. The following presentation is of a case of a patient I looked after during my surgical rotation with the breast surgery team last year at a large tertiary hospital here in Perth, Western Australia. I do hope you find it interesting. Primary breast carcinoma can occur at ectopic sites. Primary breast carcinoma of the vulva is an extremely rare entity. Today, I will present a case of labial ductal carcinoma in situ, DCIS, along with a review of the literature. The incidence of ectopic mammary tissue is 1 to 6% of the general population. The axilla is the most common site of ectopic primary breast carcinoma, comprising 91% of cases, but presentation in the vulva is rare. Ectopic breast tissue in the vulva was first described by Hartung in 1872, with the first case of ectopic breast carcinoma in the vulva reported in 1936. While over 90% of vulvar malignancies are squamous cell carcinomas, other histologic types include melanomas, basal cell carcinomas, sarcomas, extramammary Paget's disease, and Bartholin gland adenocarcinomas. Although rare, breast tissue arising in the vulva can also have malignant potential. To date, there are 36 cases that have been reported in the literature. Today, I present a rare case of an ectopic primary breast cancer in the form of labial DCIS. A 64-year-old female was referred to the breast cancer multidisciplinary team following excision biopsy of a left labial cyst, diagnosed as ductal carcinoma in situ. The patient gave a history of a vaginal cyst that had been present for the past 6 years and had begun increasing in size, which prompted her presentation for review. The lesion did not cause the patient any pain, and there was no history of bleeding or discharge from the lesion. Her medical history was significant for congenital rubella causing unilateral blindness, ischemic heart disease, percutaneous coronary stenting, and a total hip replacement. She had no history of breast cancer or any other malignancy. Her family history was significant for 2 sisters with breast cancer, both diagnosed before the age of 40. Both were managed with bilateral mastectomies, are still alive, and have previously declined genetic testing. Vaginal examination identified a well-healed wound with no evidence of recurrent disease. There was no inguinal lymphadenopathy. Breast examination revealed no significant findings, and there was no axillary lymphadenopathy. Bilateral tomosynthesis of the breasts showed no evidence of breast disease. The patient underwent excisional biopsy of a left labial cyst. So the histopathology, macroscopically, the specimen was a thin-walled cystic lesion, 27 by 20 by 18 millimeters, containing thick brown fluid. Microscopically, the sections showed normal epidermis with an underlying cyst partly lined by a bland double layer of epithelial and myoepithelial cells. In most areas, the epithelium showed varying degrees of stratification with focal intraluminal papillae, with more complex areas with distinct cribriform architecture. There was mild nuclear atypia with scant mitotic activity, and there was no necrosis in the specimen. No normal anogenital mammary-like glands were identified. The immunohistochemical findings were noted with strong estrogen receptor expression by the epithelial cells and a retained myoepithelial layer. This represented low-grade DCIS. The patient then underwent further treatment, a surgical wide local excision of her left vulva, and examination under anesthesia. The histopathology did not identify any residual disease, along with no clinical evidence of residual disease. The patient was discussed at the breast multidisciplinary meeting, which recommended no further treatments. It was recommended for her to undergo annual breast mammogram surveillance and biannual gynecologic follow-up. The patient remains well and has declined referral to a genetic counsellor for consideration of genetic testing for breast cancer. A review of the literature identified 36 reported cases of primary ectopic breast cancer of the vulva. Of the 36 cases, 22 were of ductal histologic subtype. All cases received variable treatment regimes between types of surgery, radiotherapy, and systemic therapy. Surgery ranged from wide local excision to radical vulvectomy, and sentinel lymph node biopsy to bilateral inguinal lymph node dissection. The majority of patients with a primary breast carcinoma in the vulva have a lymph node metastasis at the time of diagnosis. While the treatment varied considerably between cases, all cases with ductal histologic subtype received at least an ipsilateral sentinel lymph node biopsy and a wide local excision of lesion. There are two proposed theories of how mammary type tissue originates in the vulva. It was first considered to be the caudal remnants along the primitive milk line of ectodermal mammary ridges. The primitive embryonic milk line extends from the axilla to the groin, including the vulva. Ectopic accessory breast tissue can develop if the involution of the mammary ridge is incomplete. Ectopic breast tissue can be found along the milk line as extranumerary nipples, extranumerary nipple areolar complexes, and extranumerary breasts. The most common location of ectopic breast tissue is in the axilla, followed by the area immediately inferior to the normal breast. In addition to these areas, its location in the acromial or scapular region, the vulva, and the midline of the thorax and abdomen has also been rarely reported. More recent studies suggest anogenital mammary-like glands represent a normal constituent of the anogenital area. Nonetheless, both ectopic breast tissue and mammary-like glands are susceptible to the physiologic, dysplastic, and malignant changes seen in normal breast parenchyma. Mainly located in the sulcus between the labia minora and majora, Anogenital mammary-like glands are not normally visible, but they are often found in pathological specimens originating from the anogenital area. Their normal histology varies from simple glandular structures with round lumens surrounded by loosely or densely fibrotic stroma to complex lobular units closely imitating breast tissue. The excretory system is likewise variable. The superficial portion of the excretory duct of anogenital mammary-like glands is rarely sampled in histopathological specimens. It is a peripheral myoepithelial cell layer and luminal columnar epithelium, often showing apocrine secretion. Recognition of these glands is important in the context of cutaneous adnexal tumors. The best approach to the diagnosis of lesions of anogenital mammary-like glands is through the eyes of a breast pathologist, inasmuch as these lesions, benign or malignant, typically show a striking homology to their mammary counterparts, or manifest non-specific epithelial or stromal changes, some of which can be likened to similar changes occurring in a range of benign breast disease. In 1872, Hartung reportedly presented the first case of a fully formed mammary gland in the left labia majus of a 30-year-old woman. Ectopic primary breast cancer of the vulva is rare. The first case of ectopic breast carcinoma in the vulva was reported by Green in 1936. Any of the various histological subtypes of breast cancer may occur in the vulva, including infiltrating ductal, lobular, mucinous, and mixed ductal and lobular carcinomas. On the basis of more recent extensive studies of anogenital mammary-like glands, Van der Put proposed that anogenital mammary-like glands are in fact a normal constituent of the anogenital area. Anogenital mammary-type ductal carcinoma have a marked predilection of the labia majus, rarely involving other anogenital sites. Clinically, they appear as a solitary nodule, mostly in the range of 3 to 4 centimeters. Age at diagnosis has ranged from 46 to 82 years, with most being older than 60 years. A majority of the patients are multiparous. Histologically, most cases are invasive ductal carcinomas, sometimes with an identifiable in situ component, DCIS, featuring cribriform, solid, and comedocarcinoma patterns. Both high-grade and low-grade malignancies exist. The neoplasms express estrogen and progesterone receptors, and their immunophenotype is similar to homologous mammary ductal carcinoma, making difficult the distinction from rare cases of breast carcinoma metastatic to the vulva. Recognition of an in situ component is the best clue to establishing the origin in the skin. Rarely, synchronous vulvar and mammary carcinomas, even bilateral mammary neoplasms, have occurred, suggesting that in some cases, there may be a genetic predisposition. To our knowledge, however, no genetic studies, for example, of BRCA gene mutations, have been performed. Primary carcinomas arising from anogenital mammary-like glands must be distinguished from other cutaneous adnexal carcinomas that may rarely involve the vulva, including hidradenocarcinoma, and porocarcinomas, among others. Other mammary type carcinomas. Mammary type lobular carcinoma. This is a very interesting phenomenon, given the well-developed lobular organization seen in the breast is rarely encountered in normal anogenital mammary-like glands. There have been 3 reported cases of invasive lobular carcinoma in the anogenital area. A case depicted cords of relatively uniform neoplastic cells growing in single file, analogous to infiltrating lobular carcinoma of the breast, with areas of ductal differentiation. This case, however, is a likely example of mixed ductal and lobular carcinoma. In the breast, the criteria for the diagnosis of a carcinoma with a mixed ductal and lobular features include an appropriate histological appearance supported by immunostaining for E-cadherin, which is positive in ductal carcinoma, negative in lobular carcinoma. As in the breast, such cases should be distinguished from tubulolobular carcinoma. For a diagnosis of this disease, a thorough metastatic workup should be performed, with attention directed towards detecting a primary breast cancer by the results of the history, physical examination, and radiologic examination of the breasts to confirm that the vulvar lesion is the primary site, as opposed to a metastasis from a primary breast cancer. The possible rare association of these lesions with synchronous or metachronous breast cancers, of which there are 16 cases in the literature, makes the exclusion of breast lesions an important part of management. Irvin et al. Defined the criteria for diagnosing this disease. When an in situ component is not present, in the absence of concurrent breast carcinoma, the following should be sufficient to categorize the lesion of primary vulvar origin. Firstly, a morphologic pattern consistent with breast carcinoma. 2, the presence of estrogen and progesterone receptors. And or 3, positivity for common breast cancer markers such as epithelial membrane antigen, carcinoembryonic antigen, and glandular keratins. Primary breast cancer arising from either embryonic mammary remnants or anogenital mammary-like glands is an extremely rare histologic subtype of vulvar cancer. Diagnosis rests on the pathologic findings with recognition of the characteristic histological features and the presence of estrogen and or progesterone receptors after the possibility of metastatic disease from the breast primary cancer has been ruled out. Therapy should consist of an individualized combination of surgery, radiotherapy, chemotherapy, anti-estrogen therapy, and monoclonal antibody therapy, similar to cancer of the orthotopic breast of similar stage. Lymph node pathologic status is the most important prognostic factor in vulvar cancer. Owing to the rarity of these lesions, clinical trials to determine optimum treatment are not available, and management guidelines rely on small case series or case studies. So the learning points that I've taken away from this case, in most cases, surgical treatment of primary ectopic breast carcinoma of the vulva includes surgical excision with inguinal lymph node dissection. Vulvar cancer is ideally suited for sentinel lymph node mapping secondary to the predictable lymphatic drainage of the vulva, the low false positive rate, and the substantially reduced morbidity compared to a full groin lymph node dissection. Sentinel lymph node dissection could be considered an effective alternative to lymph node dissection. Because of the rarity of the diagnosis and the lack of definitive treatment guidelines, this type of cancer is currently staged and treated according to the tumor node metastases, TNM based classification applicable to primary breast cancer. Patient shared care between breast surgery and gynecological oncology is recommended. In this case presented, the patient was first managed with an excisional biopsy. Following the pathological diagnosis of vulvar DCIS, the patient then underwent a vulvar wide local excision, which showed no evidence of recurrent disease. Future treatment with endocrine therapy remains an option if there is recurrence of her disease, given the strong estrogen receptor expression of her cancer. This case report highlights the rarity of vulvar ductal carcinoma in situ. Thank you very much. I would now welcome any questions.
So first of all, thank you, Dr. Liam Bibo, for your valuable contribution and comprehensive speech. Are there any questions from the audience? Well, I think you covered all questionable points.
Thank you very much for having me.
Yes, thanks for your contribution. Well, that happens sometimes, that the quality of the presentations is that well that everybody understands what you would try to conduct to us. So, by the way, a very good morning to everyone. I will continue with sharing this session. My name is Andreas Lübke from the University Medical Center Hamburg-Eppendorf in Germany. And yeah, I had some technical problems, so I'm joining some minutes. I joined some minutes late. So, well, I'm asking again, maybe are there one or two questions for Dr. Liam Bibo, who kindly joined us far away from Australia? So, well then, maybe you can keep your questions in mind, because well, this is an interactive session, and of course, this is an interactive Congress. And if some question comes to your mind, for example, and not at the right time, you can keep this in mind, and maybe later on there will be an opportunity to discuss any issues. So I think Dr. Liam will be present for a while, so I can think if any questions are there, we can surely answer them. So I will go forward in the agenda, and I would like to announce the next speaker, which will be Dr. Swati Zahai from India. Dr. Swati, are you prepared to deliver your speech?
Yes, sir. Good morning, sir. So, good morning, everyone. This is Dr. Swati Sahai, speaking from India. And today I'm very thankful to everyone for giving me this opportunity to present my presentation in your conference. So, my presentation is about histomorphological study of pre-malignant lesions of prostate in TERP samples. So before I start my presentation, I would like to brief about the prostate gland. The prostate gland is present at the base of the bladder, which is weighs about 30 to 40 milligram in adult male. It has anterior, fibromuscular, central, periurethral part, and the transition zone. Hello. Hello.
So, well, at least I can hear you.
Yeah.
Yes, I think you can go on. So I hear you clear with no problems.
Hello. Am I visible?
Yes.
Is my PPT visible to everyone?
Yes.
Yeah, well, we can hear you and we'll see your screen.
Okay.
Now the presentation is up again and please continue.
So coming to the content part, the first we have introduction, objective of the study, scope of the objective, material and method, result and analysis, discussion and conclusion. So this prostate, we have two biopsies. That is transurethral resection of prostate and needle biopsies. So my study is includes transurethral resection of prostate. So these are the very apart from needle biopsies and these malignancy. So therefore these specimens have to be thoroughly examined to avoid any false negative diagnosis of adenocarcinoma prostate. There are many non-neoplastic lesions and they are very mimickers of the adenocarcinoma prostate, including pin lesions, which are adenomatous hyperplasia, crowded benign glands, cribriform hyperplasia, sclerosing adenosis, and radiation atypia in benign glands. The first person to describe this pin lesion in prostate was the Ortel, but the term which was coined by the pin is Bostwick in 1989. Ortel is in 1926 gave the first description of pre-malignant change in prostate. This pre-malignant change in prostate includes other lesions as well, such as atypical adenomatous hyperplasia, and there is also new lesion added, that is PIA, pre-malignant proliferative inflammatory atrophy. But the most commonest lesion we find is high-grade pin and low-grade pin. Coming to the descriptive nature of this high-grade pin and low-grade pin, these are architectural benign glands with cytological atypia. So cytological atypia comprises of this nuclear hyperenlargement, nuclear crowding, overlapping, and this prominent of nuclei. The key feature which distinguishes between this high-grade pin and low-grade pin is the presence of prominent nucleoli in high-grade pin and focal descriptive disruption of basal cell layer. And these two can be with the discriminated, defined by IC marker, that is Amaker, and P63, which is a basal cell layer marker. P63 is focally disrupted in high-grade pin, but it is positive in low-grade pin, and it is totally disrupted in adenocarcinoma prostate. Coming to the demographic study of adenocarcinoma prostate and pin lesions worldwide, every day new cases, 1.4 million cases are reported, and the mortality rate is 3,75,000, and the new incidence rate is 6.3 to 83.4 per 1 lakh men across the region. This is according to the Global Cancer Statistics 2020. The objective of my study was to study morphological features of pre-malignant lesions of prostate, that is high-grade pain and low-grade pain, and to apply Gleason's criteria to the adenocarcinoma prostate which are present in the pre-malignant lesion. The scope of the objective was to study morphological features of HNE stain and by using immunohistochemistry by using T3 and Amakar high grade and low grade pain, then studying association based on Gleason scoring applying to the carcinoma component. So in material methods, initially the 70 sample size was selected, but based upon availability, 100 sample size were collected. And it was done in the period from December 2016 to 2018 in my institute. Inclusion criteria was all top specimen, and then all top specimen diagnosed as prostatic intraepithelial neoplasia and atypical adenomatous hyperplasia and proliferative inflammatory atrophy. That is all the pin lesions. And the exclusion criteria such as unpreserved sample, and there's a benign mimics of malignancy such as central zone histology of prostate in the central zone, then clear cell cribriform hyperplasia, then atrophic lesions. All those were excluded from the study, and also the invasive carcinoma which are not associated with the pin. So a total of 100 cases were studied, and all specimens were top samples, not the needle biopsies. And then written consent was taken from all the patients. And these all top samples are fixed in for 10% buffered formalin and then processed routinely as per the SOP. In my results and analysis for these 100 cases, we see that the most number of cases are present in 50 to 60 and 60 to 70 years of age. That is 33% and 37%. Then histopathological diagnosis observed in TERP is the most number of cases obviously was BPH, and then only 4 cases of high grade pain and 10 cases of low grade pain were studied. And 4 cases of incidental carcinoma were observed with high grade pain. This is the age-wise distribution of prostatic lesions. As you see, the most number of cases were present in 60 to 70 and 70 to 80, and also in the 50 to 60 years of age. And also we have found 2 lesions of BPH in 80 to 90 years of age. This was the clinical presentation in benign and malignant lesion. So in the prostate, we see frequency of increased maturation, retention, urgency, filling of residual urine, and painful initiation of urine. So the most common was increased frequency of maturation because of the increased size of the prostate, and also the filling of residual urine, and then painful initiation of urine. So we have divided the malignant lesions in 3 different categories. So the category 1 is nodular hyperplasia with pin lesion. Then category 2 is adenocarcinoma with pin lesion. And category 3 is BPH with adenocarcinoma and pin lesions. So in category 1, the total number of cases were 10. And in category 2, that is the pin with adenocarcinoma, constitute only 4% of cases in the top biopsies. There are the various architecture of high-grade pin were also observed. That is tufting, cribriform, macropapillary, and flat pattern. Tufting was only 14.2% and cribriform also was at 14.2% in my study. Macropapillary and flat pattern was not observed in my study. This is the Gleason scoring criteria. which was applied to the incidental adenocarcinoma prostate and which was associated with the pin lesions. So we see here the Gleason scoring of 7 and 8 constitute about 14.28% respectively. Then this is the IHC marker which I have used for my study, that is AMACAR and P63, which is a basocellular marker in pin lesion and adenocarcinoma. So this P63 was focally present in high-grade pin but totally absent in adenocarcinoma prostate. And this AMACAR is present in adenocarcinoma prostate but was absent in BPH lesions and also in the high-grade pin. So this is the slide I'm showing you. Here the 10x power with well-differentiated tumor gland on the right side. And the left side, you see the high-grade pin. You see the crowded nucleus overlapping is there. And also the basophilic cytoplasm with amorphous cytoplasm. And the nucleus has there is a loss of polarity. And the key feature in this high-grade pin is the presence of nucleoli in the high-grade pin. And there is a focal description of the basocellular also in the high-grade pin, but it is present in the low-grade pin. And this is the pattern showing a cribriform pattern. This is the low-grade pin gland. There is a minimal crowding, minimal overlapping. There is no nucleomegaly, and the basocellular is intact. And it is almost similar to the benign glands of prostate. This is the high-grade pin in tufting pattern, where you see the nucleus overlapping and crowding in a tufting pattern, which are going towards the luminous structure with the, and having a clear cytoplasm here. This is showing the tumor gland which was seen in the pin structure beside the pin glands. And this was the AMACAR positive in high-grade pin, cytoplasmic positivity. And this is the P63 positive in the pin gland, which was present in the high-grade pin and the low-grade pin structure. Coming to the review of literature, this term pin was, as I told you earlier, it was coined by Bostwick in 1987. But the pre-malignant lesion was first discovered by this McNeil in 1926. Initially, there was 3 grade. Then later on, it was merged into low-grade pin and high-grade pin. In a study conducted by Reiki et al., there was 29.9% of pin in BPH in prostatectomy specimen. And in their discussion, they have supported the evidence for pin much greater than atypical adenomatous hyperplasia, with high-grade pin the most likely precursor of the adenocarcinoma prostate arising from the peripheral zone in the prostate. So in this study, we had 4 cases of coincidental carcinoma amounting to 4% as against the observation of Frederick S. J. Jordan et al., which is of 58.27. Why there was so much of 58.27% in the Jordan case? Because they had considered 731 turf specimen, in which pin 1 and pin 2 was 29% and 21%. So after we combine all these 3, pin 1 is 8%, but pin 3 is 50% in Jordan cases. In our study, we have used P63 as a basal cell marker and AMACAR for pin lesion at adenocarcinoma prostate, and it revealed that P63 was focally present in high-grade pin, totally absent in adenocarcinoma prostate. So the study conducted by Anand et al., 40 suspicious cases were resolved by using this basal cell marker P63 and high molecular weight cytokeratin marker. Their study correlated with another study in which it is said that P63 is superior marker than high molecular weight cytoveight keratin. That is why in our study we have used P63 marker and AMACAR for differentiating between high-grade pin, low-grade pin, and adenocarcinoma prostate. So, conclusion, the gold standard of this is diagnosis. From the above study, it is concluded that BPH remains the most common lesion in the TERP, and histopathology remains the gold standard for diagnosis of pre-malignant lesion. Only then we go for the IHC study after diagnosing in the slide. And the most common lesion and the pre-malignant lesion on the prostate is high-grade pin, because low-grade pin is not usually reported in the BPH cases. Why? Because the low-grade pin is similar to the normal nodular hyperplastic glands of the prostate. But because high-grade pin has focally disrupted gland, presence of nuclei, nuclear enlargement, nuclear physiological atypia is there, and the presence of this IHC marker, which correlates with this adenocarcinoma prostate. That is why high-grade pin is the only lesion which is considered as the pre-malignant lesion of the prostate. Thank you.
So thank you, Dr. Swati, for this very comprehensive and informative presentation. Are there any questions from the audience? Well, I've got a question. How many tissue blocks do you embed usually if you analyze the TERP material?
Usually we submit all the TERP chips for the diagnosing cases. Okay, to avoid so any. Yeah, we embed all the tissue chips.
Okay, that's very good. So what's your approximate number of tissue blocks you have in your TERP specimen?
8. Mostly 8. Hello.
Hello. Yes, we hear you. We hear you.
Yes, mostly 8 number of TERP chips have been embedded for the study.
Okay. Thank you. Any more questions?
Thank you.
Well, if there are no further actual questions, please remember that if any question comes to your mind, just keep it there and we will see whether we can discuss this later on. So I call upon the next speaker. This will be Dr. Manuel Atwan from the UK. Dr. Manuel, please, we look forward for you to deliver your speech.
Good morning. So can you see my screen or not yet?
Yes, we do see your screen and we can hear you clear.
Thank you. Good morning. Thank you, first of all, for giving me this chance to share this rather exciting development that we have come across during what has been a year of doom and gloom during the pandemic.
I received a missed call from your number. That is why.
Firstly, I would like to thank my team, Dr. Futandaip and Mark Chapman, for their hard work. Sorry, can you hear me?
Yes, we can hear you very well. Just a note for the other participants: please be sure that your microphones are muted to prevent any communication problems. Thank you. Well, Dr. Manuel, please continue.
Thank you so much. So I share with you the plan for this talk. I'll give you a minute to have a look at it. And when you're ready, brace yourselves and let's hit the ground running. So we know that COVID-19 has become a worldwide pandemic, sadly, since the beginning of 2020, and it is still carrying on till 2021. So far, 95 million confirmed cases infected by COVID-19 internationally, out of which 2 million sadly have succumbed to the coronavirus infection. We also know that despite the tremendous effort and the rapid development in the symptomatic control in patients with COVID-19, we're still to see a really effective treatment for this beast. And we cannot undermine the global effort for the vaccines that has come together internationally to approve vaccines for COVID-19 in such a short period of time, which have been rolled nationally, thankfully, and internationally. However, with the emergence of new variants of the coronavirus, there are question marks about the coverage of these vaccines and the new variants. And the question that us as a team would like to ask is whether there are any viable alternatives for treatment for COVID-19. A bit about the COVID-19 epidemiology. I'm pretty sure we're all sick with it so far, hearing the COVID-19. But we know that COVID-19 infects a broad spectrum of the population. And through the research during the pandemic period, we are aware now that we have identified an at-risk group for COVID-19 infection. There is a long list, amongst which I would like to highlight men being at increased risk, those from minor ethnic back groups being Black, Asians, and the other minor ethnic back groups, those who are obese, with diabetes and cardiovascular disease. So that is just to highlight the most important at high risk groups, although there is a long, extensive list present at the WHO websites. But what we also know as well is that the majority of people, once they are infected with COVID-19, they are either asymptomatic or they develop mild symptoms, but yet they are still infective. 15% of those infected develop severe disease, and a further 5% become critically ill with the coronavirus, and the majority of those succumb to the disease, although we have seen few success stories of recovery from being on an ICU bed due to COVID. And the presenting symptoms of COVID are quite a wide range of manifestations. And this, in fact, reflects that the coronavirus actually infects multiple organ systems, the most common being the respiratory system. But there are other systems involved, such as cardiovascular, such as the GI system, liver, kidney, and even skin manifestations are emerging. And nowadays, there is a new kid on the block called oxytocin. So what do we know about the relationship of oxytocin and COVID-19? We know that research has proven so far that in the cohort which is labeled as high risk group for developing COVID-19 infection, those individuals have a low oxytocin plasma level when compared to the general population, which are healthy and do not have the high risk factors for developing the coronavirus. Furthermore, we know that once infected by COVID-19, the function of oxytocin is reduced, and the research so far has proven 2 pathways for such a hypothesis. The first being that there is a downregulation of the oxytocin receptors once the human body is infected by COVID-19. And the second being that oxytocin is normally produced by the hypothalamus, and the theory is that the virus infects the neurons within the hypothalamus and therefore leads to reduced production of oxytocin, the so-called viral cytopathic effects within the neurons in the hypothalamus. And there are radiology papers highlighting the effect of COVID-19 on the hypothalamus during COVID-19 infection. But is oxytocin really a new kid on the block, or have we known about oxytocin before? So oxytocin was discovered in the early 1900s by Henry Dale. So it is not a new kid on the block. It is a peptide hormone and a neuropeptide. And as I have mentioned, oxytocin tends to be produced by the hypothalamus, and it is released by the posterior pituitary gland. It was initially thought in the early 1900s, when it was discovered, that its role is in social bonding, in reproduction, and in childbirth. And once it gets released into the bloodstream, it is usually triggered by love and labor. So that is the knowledge that we have acquired in the early 1900s. But why would an oxytocin, which has been labeled historically as a love hormone, play a role in the COVID-19 infection? And is that possible at all? We now know through the emerging published research that oxytocin has an anti-inflammatory and a pro-immune function against the COVID-19 infection. And I share a very recent paper highlighting this. So we know now, contrary to the beliefs in the early 1900s, that oxytocin receptors are found throughout the body. We also know that it has a wide range of effects. So that's new knowledge, new evidence acquired through the research during the period of the coronavirus pandemic. So oxytocin has an immune modulator function. It also works as an immunological defense. It maintains homeostasis, and it suppresses neutrophilic infiltration and inflammatory cytokine release, as well as modulating T lymphocytes and antagonizing negative effects on angiotensin II. And I would really as we tried to take the GI system as a microcosm in the body and see those who have developed severe COVID-19 GI symptoms and ask the questions, could we explain those severe COVID-related GI symptoms by the oxytocin dysfunction? So nowadays, we know through the research that the GI tract is a potential route of COVID-19 infection. And let me stop here and say that as a GI pathologist, During the pandemic, all our protocols have changed due to this fact. Nowadays, all of our colorectal resections, whether cancer or non-cancer related, are left in formalin at least for 48 hours even before opening, purely because of the impact of this finding. We know that there is a significant proportion of the initial and even long-term symptoms of the COVID-19 infection are accompanied by GI symptoms. Luckily, I didn't have, I was lucky not to catch coronavirus, but those who have been unlucky will tell you about the diarrhea, the nausea, the vomiting that they have experienced purely due to the coronavirus infection. And now we know that oxytocin receptors are found throughout the GI tract. Mainly, they are found within the surface epithelium and again in neurons, similar to what originally was thought to be only the hypothalamus. And nowadays we're talking about oxytocin dysfunction and its effects on the GI tract. So we know that due to oxytocin dysfunction, there is an increased stool mass, increased water content, and increased transit time, as well as increase in the permeability of the intestinal wall to macromolecules, all of which presenting in COVID-positive patients as the diarrhea. We also know that the lack of adequate levels of oxytocin lead to decreased GI mucosal cell proliferation, decreased villus height and crypt length ratio. And I'll stop here and just alert reporting pathologists that nowadays when we're receiving GI biopsies, especially from the small intestine duodenum, query celiac disease, which is not an infrequent occurrence on a GI pathologist's desk, bear in mind that COVID-19 leads to decrease in the villus height and crypt length ratio. So entertain this in your differential diagnosis and check the past medical history. And the last but not least, low levels of oxytocin lead to decreased protection against inflammation and hence all of the manifestations, GI manifestations of the COVID-19. And there is a decrease in mucosal defense against toxins, hence the vomiting, the nausea, and again, the diarrhea. So how can we reflect this in reality? I'm just going to share with you a case that came across my desk yesterday for a second opinion. These are GI biopsies that I'm going to share from a 64-year-old female. Of significance is the presence of a past medical history of COVID-19 in December 2020, and the patient now presenting with acute diarrhea, so nearly not quite 6 weeks history of diarrhea and a positive fecal occult blood test. She underwent a colonoscopy and she has, colonoscopy was normal, no findings. So random biopsies as per protocol were obtained. The process of thinking being, let's exclude and let's see if there is any drug effect, and the list goes on and on. So low power review shows, I'm just going to share one biopsy with you because the morphological features are similar in all of the biopsies. This is a right-sided large intestinal mucosal biopsy, which shows that there is a preserved crypt architecture. Just bear in mind that this is a right-sided biopsy, so the chronic inflammation and the gradient, you're allowed a bit more leeway on the right side. But still, despite all of that, the lamina propria looks quite busy. So let's see what's happening. So crypt architecture quite maintained, and what we're seeing is there are polymorph neutrophils within crypts, not yet crypt abscess formation, and there is quite abundant polymorph neutrophils within the lamina propria. So a picture of acute colitis for which the differential diagnosis top of the list is infectious colitis. And the question to be asked in this situation is this really an acute colitis occurring secondary to the COVID-19 infection? I would like to tell you that the stool cultures were negative, but they haven't yet been tested for COVID-19. So that's something still remaining to be confirmed in this case. But the take-home message from this case is, A, look at the past medical history, ask your clinicians to supply a past medical history, because it can be quite relevant in situations like this. So what are we hypothesizing and where are we going with this? It's a lot of science, but what do we want to do with it? So far, we know that oxytocin dysfunction contributes to the GI symptoms that are produced in the COVID-19 infection. And what we are hoping to achieve is, if we have normal plasma oxytocin levels, to protect against these GI symptoms that are produced during a COVID-19 infection. The good news are that oxytocin is available, it is cheap, and it is safe. And once administered, it can alleviate the GI symptoms produced during the COVID-19 infections. This oxytocin is available on the market. It could be through intranasal spray, it could be through intravenous infusion. And what I would like to share with you is a recent paper that has been published, where they have used an intravenous oxytocin infusion to try and counteract all of the hyperinflammation that's seen in a COVID-19 infection. And what we are hoping to achieve is, by getting the approval to administer oxytocin, with that being exogenous, as we have explained, through intranasal sprays, through intravenous injections, through capsules, that we will be able to raise the serum levels for oxytocin, and therefore act as, hopefully, a prophylactic protective mechanism against developing GI symptoms. For now, we're talking about COVID-19, but who knows at the end of the path what we will be able to protect against. And so far, what we have found is that COVID-19 is being recognized to exert its effect through a multi-organ involvement. That ties in nicely with the presence of oxytocin receptors throughout the body and its healing and protective effects in the COVID-19 pandemic. I also like to share with you a hot off the press paper that has been published about the cardiovascular protective properties of oxytocin against COVID-19 infection. So we're here moving towards prophylaxis and prevention of even cardiovascular disease. I mentioned that oxytocin can be administered exogenously. However, why bother when it is present endogenously within the body through exercising, meditation, listening to your favorite music, massages, touch? All of this facilitates the release of oxytocin, and therefore increases the plasma oxytocin serum levels and acts as a protective mechanism. So get on your running boots and get those oxytocin levels up. Our recommendations is to get an approval for a randomized controlled trials in COVID-19 patients to prove the effects of the administration of oxytocin. We would like to map the oxytocin receptors presence along the colorectal cancer pathway and see, hopefully, if in the future we can integrate oxytocin treatment within the personalized medicine cancer treatments that are being delivered. And I would like to share that a few days ago, a paper has been published about using oxytocin in the treatment of cancers, and different types of cancers have been patients that are terminally ill have received oxytocin and their survival levels have improved. So I think that's the light at the end of the tunnel. And before I finish, I would like to ask anyone who's interested in such a research or would like to take part in such an exciting development to please contact me and contact my team, and let's get those efforts internationally to spread the word. Thank you, and I'd like to take your questions.
Yes, thank you, Dr. Manel, for this.
Sorry, you're muted.
Okay. Well, thank you. Thank you, Dr. Manel, for this very actual and comprehensive presentation. We do not get tired hearing about COVID-19 because it will become to our usual clinical routine. And the more we know and the more we can do, the better it is. So are there any questions from the audience? So I got a question. As oxytocin is a normal medication in our daily practice, how long do you think would it take to get an approval in this medication?
So within the UK, we have tried the moment we found this exciting knowledge to spread it and ask for approval. So far, we haven't gained that, but we're ready to fight the battle till the end. I think what's exciting is that elsewhere in Europe, this has been trialed and proven safe. So I'm hoping that this will surface sooner rather than later within the end of the year. I'm hoping that because it's safe, it's cheap, it's easy to administer. You don't need any intravenous access for it. It can be just administered as an intranasal spray. So the knowledge is there. I think a controlled, multi-centric, randomized trial is needed before this is approved, and hence I'm spreading the knowledge, hopefully to get some team efforts for this to launch. So I'm afraid I can't give you an answer to that, and hence the frustration and the reason for spreading this knowledge to get a team effort to progress it.
Well, thank you. Any more questions?
Hi, I would like to ask one question, please. Are there any cases that are found allergic to oxytocin IV or orally, please?
Good question. From the paper that has been published, they haven't highlighted this as an issue, but I'm pretty sure, as with other medications, you never say never.
Okay, that's great. Thank you for your reply. Thank you.
Thank you. Thank you.
Any more questions? All right, so thank you again for this actual topic. And I would like to call on to the next speaker, which will be Dr. Mono Trisol from India. Dr. Mono. Are you ready to deliver your speech? Okay. I see that the next speaker just left the meeting, so I will just continue. The next.
Yes, I'm going to call upon our next keynote speaker, Dr. Andreas M. Luca from Germany, to deliver his keynote speech, please. Thank you.
Thank you for this kind introduction. So first of all, we need to I need to share my screen.
Yes, please.
So, and now because my screen is very busy, so let's see what we can do. There it is. And well, like this. So no, not like this.
So we are asked a question by Sudipta Naskar. What are the adverse effects of oxytocin therapy? So it's still under progress, as mentioned by Dr. Manal Atwan. So they haven't found any side effects till now. The research is under progress. I hope I have settled your question. Thank you.
So now you should be able to see my screen. Do you see my? Oh,
yes, please. Let's read now.
Okay, very well. So let's see if the pointer works. Yes, very well. Okay, so good morning again, everyone. My name is Andreas Lübke. I'm head of orthopedic pathology and vice head of cytopathology at the University Medical Center Hamburg-Eppendorf in Hamburg, Germany. My speech is called An Exotic Souvenir, which is a case report in bone pathology. So, however, this is a mixed audience. So some of you, I hope a lot of you, are pathologists, which is pretty cool. Some of you might be residents in pathology, which is also pretty cool. And some of you are students, and some of you might be non-pathologists. So what I'm trying to do, I try to pick you up and keep you and bring you to the same level so that you are able to follow the story of this case report. And another thing is that there are two basic approaches to transfer some information. One is a very practical view, so that you can follow this case report like a hands-on story. The other way would be very comprehensive, very detailed review to prove to you that I'm capable of my topic and I clear every detail, but then you won't take anything away from this. So therefore, I will try to share my knowledge with you, and I want you to take this knowledge. And therefore, I will keep it in a very practical way. So I will begin with the basic principles of bone pathology, that you get just some basic facts. So the basic principles of bone pathology are those two. First, specific lesions of bone appear in a reproducible clinical context. And the next important thing is that the close correlation between clinical features, radiology, and histology lead to a reliable diagnosis. If you just take this away from this talk, you'll learn a lot. So, how do bone tumors become apparent? This is also very basic, but it's a very general knowledge. So pain is a very important symptom, especially in malignant bone tumors. Pathologic fracture, and not very infrequent, bone tumors are an incidental finding. So classic case is that an individual falls down, has pain in the extremities or somewhere, and conventional X-ray is made. And before that, the patient did not have a bone tumor. But after that, there is a bone tumor, although nobody looked for it. So pain, pathologic fracture, and incidental finding. Of course, when the tumor grows or is at a very prominent position, you can see a swelling or a palpable tumor. But this is to the cases that grew very large and are a very prominent position. So if we talk about bone pathology, it's very important to have some basic knowledge in bone tumors, because we know we've got simple fractures or osteomyelitis. And then another important issue, which especially bone pathologists have a lot to deal with, are bone tumors. So what are the most frequent benign bone tumors? This is a short list. You can make this list even longer, but you have to know these 4 tumors. So first of all, the osteochondroma. This is just a cartilage cap with a stalk of bone, which is continuously fused to the underlying bone. And the osteochondromas we find in the first 2 decades of life. After the skeletal maturation is finished, the osteochondroma stops to grow. The osteoma is another important benign bone tumor in the thirds, and interestingly, it's sensitive to NSARs. So, and it causes a prominent sclerotic reaction in the surrounding tissue. The giant cell tumor of bone is an important bone in the younger adults and middle-aged adults, which is a destructive lesion, basically in the metaphysis of the bones, with the potential in a very rare event to metastasize, but those metastases, especially to the lungs, behave clinically indolent. And of course, you might know the enchondromas, which are frequent incidental finding, but have a very low risk to progress into chondrosarcoma. Now we go to the malignant tumors, and especially in children, you have to know the 2 most frequent malignant bone tumors. Namely, this is osteosarcoma and this is Ewing sarcoma. Well, osteosarcoma is defined as a malignant mesenchymal tumor producing bone matrix. And Ewing sarcoma is a small blue round cell tumor that behaves very aggressive and has a specific EWSR1 translocation. And now the group of the small blue round cell sarcoma is continuously growing as we see tumors from the same family with other translocations like the SIGDUX and the B-core round cell sarcomas, and also some Ewing sarcomas where it's not possible to detect a specific translocation. So if we go to the adult people, it's a completely different story because the spectrum of bone tumors is completely different. The most frequent malignant tumors in the bone in adults are metastases. So namely tumors from the lung, thyroid, breast, kidney, and from the prostate, followed by multiple myeloma. And on 3rd place comes the chondrosarcoma, the most frequent primary malignant bone tumor in adults. So, so this is a basic diagnostic algorithm for bone tumors, which you have to go through regardless whether you are a radiologist or a pathologist or oncologist or an orthopedic surgeon. And one thing I'd like to point out is that the diagnostic of bone tumors is always an interdisciplinary approach. Of course, it's possible if you're very skilled in your own discipline, like pathology or radiology. You have a very high probability to make a correct and definite diagnosis. But it's very difficult, and it's even more dangerous to do a diagnosis only with your own diagnostic discipline. The final diagnosis should also always include an interdisciplinary approach. And the best thing to perform this is, for example, in a tumor board or in an expert panel. So, and if you do this, you have to follow some basic steps. And well, this is the quite, I hope, well-known basic diagnostic algorithm for bone tumors. First of all, we need to know the age of the patient and the gender. Then we have to know the location of the bone tumor, which bone is affected and where in the bone. Are there multiple lesions, or is this a solitary lesion? What kind of pattern has this particular lesion? Well, this is the most complex, the most difficult, but quite a specific point, because most of the bone tumors always behave in a similar way, of course, with a little variety. But the radiographs and the histology of some lesions can be very, very specific. So, and those are basically features that can also be entered by radiology. And here you see the point number 5. This is the reaction of the periosteum. This gives us a lot of information about how aggressive the lesion is. For example, if we get a very long-growing lesion like an osteoblastoma, there's a good chance that we've got a very prominent sclerotic rim next to the nidus of the osteoblastoma. And if we've got a very aggressive tumor, like an osteosarcoma or Ewing sarcoma, there's a possibility that we can see the Codman triangle, which I will explain later on. So the simplest thing is the point number 6, the intralesional matrix. And so we've got osteoid calcifications or even no matrix. So I will go through this list and give you some examples. So first, age is very important because, as I said, the spectrum of tumors is variable with age. So if you draw a line, I think about age 30, you can separate 2 major groups. The group of the tumors of the young adults and children. And there you have to know, as I said before, malignant bone tumors at the young age is the Ewing sarcoma and the osteosarcoma. And then there are a lot of benign tumors, but the variety is quite high, like simple bone cysts or chondroblastoma, the non-ossifying fibroma, osteochondroma, fibrous dysplasia, the osteoblastoma, which is a very painful lesion, the aneurysmal bone cyst, which is an expansile lesion, or the Langerhans cell histiocytosis that makes sharp demarcated osteolysis. So when we go to the older individuals, first there's a giant cell tumor of bone, which is a very destructive lesion. And when we go to the older individuals, we see metastasis, 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 followed by multiple myeloma, multiple myeloma, multiple myeloma. And then we encounter the chondrosarcoma and the periosteal osteosarcoma, and of course, the chordoma. The benign tumors are in the older individuals a little bit more rare. So we find osteoma and enchondroma. And if you just stick to this simple algorithm of age, you've got a good baseline. Of course, the variety of bone tumors is much more higher. But those are just the most frequent known bone tumors. So this is just a radiograph example. For example, you got a woman. She is 72 years old. And this is a AP conventional radiograph. And if you do not know anything about radiology, you can help yourself with one simple trick. You just take a look at the image, and if it's a symmetrical image, you just go through the image and make for example, a midline, and then you compare the structures on the right with the structures on the left. Right, left, acetabulum, femoral head, trochanter, metaphysis, diaphysis. And then you easily see whether there's something going on or something wrong. And another thing is that you can go along the surface of the bone. Then you see if there's a continuity. And here it's easy to spot that there's a crack. This is a easy to spot fracture. And on the other side, you see that the surface of the bone is a continuous line. So this is a very simple approach. And of course, this is a very easy image because you see the fracture. But it's not always that easy. So here we got a fracture in a woman that is 72 years old. This hurts. So we've got pain. We've got a pathologic fracture. It's an old woman. And we can see that there are some lytic areas. So in summary, this is suspicious of malignancy. And if it's a lesion that is suspicious for malignancy, of course, the most likely diagnosis is a metastasis. So again, kidney, lung, thyroid, and breast. And in this case, it's just a metastasis of a known breast cancer with a pathological fracture of the femoral head. So the next example is a 64 years old man. And we see at this CT image again, that if you compare the both sides, we see that here is an osteolytic lesion in the metaphyseal region of the femur. There seems to be some matrix, but it's basically a destructive lesion that also is protruding the extraosseous soft tissues and in the marrow space. So again, here's pain. It's an older individual, and this is the metastasis of a urothelial carcinoma. Image after the osteosynthesis of the lesion, just to show you a conventional radiograph. It's quite easy to see the osteolytic areas in this case. So age is a very important factor. Then the location. Here you can see image drawing of a human skeleton, which shows you some bone tumors. Of course, this list is not complete because there are many more bone tumors. However, this is just to give you an example what you can expect if you encounter a lesion in a specific bone. For example, in the skull, you can expect Langerhans cell histiocytosis. At the skull base, you can expect chordoma. In the jaws, you can expect odontogenic tumors. And even if you go down in all metaphyses of long bones or the central axial skeleton parts, like the pelvis, you can expect malignant bone tumors. They are very frequent at the metaphysis of the long bones and the pelvis. In the sacrum and the lower regions of the spine, you can find chordoma. And a tumor that is almost always in the same location is, for example, the adamantinoma, which is almost I say almost because there are some manifestations in other regions. But this is the adamantinoma, which is always in the interior parts of the tibia, and is to be noticed as an osteolytic lesion with a sclerotic periphery. In the lower extremity, you find non-ossifying fibromas, and more than half of all enchondromas you'll find in the tubular bones of the hands. Osteoblastoma is frequently located in the region of the spine, and again, metastasis and multiple myeloma can be found anywhere in the skeleton. So location is important. And the second point of location is the location in the bone. So we've got tumors that are almost exclusively appear in the epiphysis, like the chondroblastoma. In the metaphysis, you find osteosarcoma, aneurysmal bone cyst, and the giant cell tumor. In the diaphysis, you can expect periosteal osteosarcoma and the adamantinoma. And the periosteal location is classic for a parosteal osteosarcoma. The tumor that is often located eccentric is a non-ossifying fibroma. And again, metastasis and multiple myeloma can be found anywhere. Next thing is solitary or multiple lesions. Of course, if it's a solitary lesion, it could be anything. But if you got multiple lesions, this is also a very important piece of information. If it's multiple, again, it can be metastasis, it can be multiple myeloma, but there are other lesions that also can be multifocal, like the epithelioid hemangioma of bone, the non-ossifying fibroma, and of course enchondromas, especially when you've got enchondromatosis, namely Olliers disease, or if you've got hereditary multiple osteochondromas, the osteochondromas can be multifocal, and they have an elevated probability to turn into malignant bone tumors. And of course, if you've got a general disorder like a hyperparathyroidism, there can be multiple brown tumors. So it matters whether it's a solitary lesions or if there are multiple lesions. So the pattern of lesional changes is very complex because every bone tumor has its own characteristics. I give you one characteristic example. So those are the conventional X-rays of a skeletal immature patient. So here you see the growth plates still open. And in the dorsal regions of the tibia, there's a lesion. It is osteolytic. It has got a sclerotic rim. And this was an incidental finding with no pain. So no pain, skeletal immature, and osteolytic lesion, sclerotic rim, and an eccentric location in the lower extremity. This is quite characteristic for a non-ossifying fibroma. If you watch those lesions, you will see that they will become sclerotic during the time. And basically, those are lesions that can be spotted and identified on radiology. It's basically a lesion that can be just surveyed and do not need to have a biopsy done. The point number 5 is the reaction of the periost. And this is of great importance, especially when we have a malignant bone tumor. This is a very good drawing. This is taken from McDonald and Denotta. Just a brief description of the Codman triangle, and the image is done by Dr. Yunji. And here we see this bone, and there is a malignant tumor in the metaphyseal region. And usually the periost is lying on the bone. And when there is a tumor that expands the bone or destroys the bone, the periost is lifted. And if you do this at a very, very slow level, the periost has the chance to mineralize. But in the Codman triangle, this is an incomplete mineralization because the mineralization is stopped where the causing lesion lifts the periosteum so fast that this cannot be completely mineralized. So a Codman triangle is always an incomplete triangle. And especially when you see this Codman triangle, this is a red flag for a malignant tumor of bone. I'll show you one example. This is a young patient, about 19, 20 years old. And here we see an osteolytic lesion in the metaphyseal region of the distal femur. And you can see that the periosteum is lifted here. This is even better. You see a small lift, and here the periosteum is lifted and the reactive bone is mineralized, but here the mineralization stops, and here's the tumor. So this tiny incomplete triangle is a Codman triangle, and this is a Ewing sarcoma of the distal femur. So the last point is intralesional matrix, which can give us a lot of information. And we do find it in benign as well as in malignant bone tumors. In cartilaginous tumors, we usually got calcification. And in bone-forming tumors, we've got osteoid and true compact bone formation. As easy as that. So I show you some examples. So this is an osteochondroma, this is an enchondroma, sorry, with calcifications. You can see that those calcifications are quite dense. They are even as dense as the cortical bone, like here. And it's characteristically that they are lobulated and with a little bit of popcorn aspect. So this is quite characteristic for dystrophic calcifications in enchondroma. Of course, this could also be chondrosarcoma. The matrix doesn't tell us anything about the dignity of the lesion. The next example is a low-grade central osteosarcoma with neoplastic bone formation. Here, you can see that this tumor at the skull base expands the bone and causes some mineralization. The image is inhomogeneous and it's not sharply demarcated, especially when you take a look at the borders of the tumor. This is very inhomogeneous and not sharply demarcated. And this sclerotic impression is due to the tumor osteoid production. And here is an OFD-like adamantinoma. And you can see that this tumor doesn't like any matrix. So the absence of matrix is also diagnostic because the OFD-like adamantinoma doesn't create bone or cartilage or show some prominent dystrophic calcifications. You see the demarcation is relatively sharp, but the adjacent bone becomes sclerotic. And this is also an important feature. Sometimes the lesion induces a reactive bone and sclerosis in the periphery. So those were basically those 6 basic rules. And we've seen a lot of radiology right now, but we haven't seen some histology. And you may ask why, because well, I'm a pathologist and you should expect that I show you some histology. I'll do that. But the basic question is, as a pathologist, I can see every single cell of the lesion. Why should I be familiar with the radiology? Well, you win the information of a whole additional diagnostic discipline. And some lesions cannot be discriminated by histology alone. This is important to know. You can make a lot of diagnoses with your microscope and your tissue, but you cannot solve all the cases with your microscope. So you should use this additional information because bone pathology is hard enough. So don't make it harder for yourself. So, and to illustrate this, I will give you some examples. So this is a case example of a 24-year-old woman. She has got an osteolytic lesion in the left lower jaw, and the clinical information was suspicion of central giant cell granuloma, CGCG. So there it is. Here we got a quite classic example of a giant cell granuloma. Well, it's located in the jaws, here in the posterior region. It expands the bone and has got an inhomogeneous, predominantly osteolytic image, sharply demarcated at the periphery and in an unilocal formation. This is the histology. We see this is an older histology, so the color is not perfect, but we will improve during the speech. So, but we see a spindle cell stroma. Those are spindle or ovoid cells with intermingled multinucleated giant cells. No atypia, and this is also very characteristic for a CGCG. Here, a higher magnification, again, no atypia, and spindle cell stroma, cell-rich and intermingled multinucleated giant cells. So this is it. You might spot some delicate vessels and hemosiderin deposits, and the therapy is a curettage. So the next case is 6-year-old boy, a tumor on the left lower jaw, clinical information, dignity. That was all. And here again, you see a stroma that is composed of spindle cells with intermingled multinucleated osteoclast-like giant cells. So the same histology than before. So this would fit to a giant cell granuloma. So when I encountered this case, I almost made this diagnosis. But then I thought maybe I should take a look at the radiology. So, and I did that. And this was the digital volume tomogram. And you can see here a symmetrical extension of the jaw on both sides. That's interesting. And here you see that this is a huge deformity of the skeleton. And again, if you go to the front view, there seem to be lesions that expand the bone on both sides. Again, you can see this even more. So this is symmetrical lesions involving the jaws and also the maxilla bone. So what might that be? This is cherubism. The histology of the cherubism is identical to the giant cell granuloma. It's indistinguishable on histology alone. And therefore, every bone pathologist has to know at least some basic facts of the radiology, because otherwise you will miss this lesion completely. So just a little excursion to the cherubism. You see this, this is a Sistine Madonna. It's an old painting by the Italian artist Raphael and one of his last pictures. You can see this in Germany at the Gemäldegalerie Alter Meister in Dresden. and it's from 1513 to 1514 painted. And of course, this is a very beautiful painting. You see Maria with a Jesus child, for example. And then the lower part, you see those guys here, those little angels. And they became even more famous because they look so nice, they look so cute. And they are called, in strictly terms, those are no cherubims. Those are merely seraphims because they've got wings and they look like humans. And the angels of the higher hierarchy are named cherubims, and they do not interact with humans. So basically, those are seraphims. But whatever the name of cherubism comes from those Renaissance paintings, because the look of the faces was like in the patients with this genetic order. So cherubism is an autosomal dominant hereditary disease. There are some spontaneous cases. It manifests in early age, and about 75% are associated with a specific mutation, or they are associated with other genetic disorders like Noonan syndrome, Raman syndrome, and Fragile X syndrome. The therapy is only functional and under aesthetic considerations. So I took you some nice image from the literature where we can see the similarity between the Raphael painting and a real-life human quite well. This is from this publication. It's a very good clinical image. And again, the cherubism is indistinguishable from the giant cell, central giant cell granuloma. So now I hope I told you some basic skills on bone pathology and evaluating radiographs. You've seen some histology, and I think now you are ready for the case report. This was a 30-year-old woman who lives and works in northern Germany. She noticed pain in the distal femur when she was doing some exercise, when she was running. And the pain lasted, and she had light intermittent fever. She travels a lot, and this is her travel history of the last 12 months. Canary Islands, oh, not so exotic, not that special. New York, well, it's an intercontinental trip, but New York is an urban circumstance. This is today also not very special. Then we've got Goa in India, which is truly exotic in terms of northern Germany. And we've got one trip to Costa Rica. This is also a very unusual location to travel to. So the history lasted on, and 6 months later, the pain and the fever were still present, so she went to the doctor. There were no other findings in the history or at physical examination. So diagnostic workup was done with focus on infections. So extensive microbiology was done. There was no detection of a disease-causing germ. And histology was taken, which revealed osteomyelitis, but no pathogen. So given the fact that we had osteomyelitis on histology, more extensive microbiology, including local and national reference centers, was done, but there's still no disease-causing organism. So the diagnostic workup went on, and a second biopsy from the joint space was taken to gain material with infectious organisms to provide a therapeutic regimen. So, and repeated extensive microbiology was done because this was what the biopsy was for. Again, including local and national reference centers, and there was still no disease-causing organism detected. So this all happened not at our institution, so I do not have any histological images or further material. This is just provided from the clinical records. So just a brief excursion to osteomyelitis. So what we can expect in a chronic osteomyelitis, this is defined as a progressive inflammatory process with variable periods of quiescence. The diagnostic gold standard would be a positive bone culture and positive bone histology. Common pathogens in adult osteomyelitis are Staphylococcus, MRSA, Staphylococcus epidermidis, Pseudomonas aeruginosa, Serratia morcescens, and E. coli. And mycobacteria and fungal infections are generally uncommon, and they are often associated with immunodeficiency. One exception might the tuberculosis might be, because we do not see this so infrequently. So I show you some pictures of a usual chronic osteomyelitis. You see here woven bone, immature woven bone lined by osteoblasts. You see a fibrous stroma with a sparse chronic inflammatory infiltrate consisting of lymphocytes and plasma cells. And I'm going to show you some lamellar bone, which is normal bone. There you have the lamellar structure. And here you see some plasma cells with some lymphocytes. And if you do polarization optics, which I do in every bone specimen, you can see the lamellar structure. So this is normal, healthy bone. And here again, this is woven bone. This is a woven image. This is reactive bone. So this is a pathologic condition. Again, you see osteoblasts on the surface, and you see multinucleated osteoclasts doing some resorption. So in this bone, there's something going on. But the infiltrate is chronic and mixed inflammatory. You see again a lot of lymphocytes scattered. You see fibrous tissue. You see again woven bone. Here's a high identification of the chronic infiltrate. And again, you see a lot of lymphocytes and some plasma cells. In a fibrous stroma, there are some hemosiderin deposits. So now you know what osteomyelitis looks like under the microscope. Then the patient came to our clinic, and we did a third biopsy because the clinical information was known osteomyelitis, suspicion of rare mycosis or other rare infection. And therefore, this third biopsy was done. And here you can see the plain radiograph of this distal femur that is painful. There are some defects due to the previous biopsies. For example, here, well, the pointer is not that quick as I want it to be. So maybe I disconnect the camera because this can sometimes slow down. Again, let's see. Okay, not even better, so I'm just using the arrow. I think you can deal with this. Here we see a defect due to a previous biopsy. This was the other biopsy, and this was our biopsy. So if we focus on the bone that's far away from biopsy, like here and here and here, you easily can spot that this has got a sclerotic impression. So compared to the tibia, this is very sclerotic and inhomogeneous. You see some lytic areas here, also here and here and here and here and here and here. And the bone is expanded a little bit. This becomes even more transparent here. You see sclerotic, more lytic, sclerotic. So an inhomogeneous appearance, but no well-formed and impressive tumor. So just an intraoperative image. We see that we went deep into the bone. So there it's from. And here we see a CT imaging, here from the first biopsy, here from the second biopsy. And the CT images highlights the inhomogeneous structure. You see little lysis, sclerosis, lysis, sclerosis. So an inhomogeneous architecture. At this point, of course, an osteomyelitis is likely. But we also know that the major and most important differential diagnosis to osteomyelitis is a bone tumor. So if you've got osteomyelitis and you've got pain and you have an inhomogeneous radiology, always exclude malignancy. So here we go. Some more imaging, inhomogeneous, lytic. And again here. So now we take a look at the histology, and I will share with you my screen. So you so you will be able to follow this live microscopy. You should now be able to see my screen, I hope. So I'll turn on the light. So it's a little bit feasible sometimes. So I just connect and disconnect. Yes. Okay, there you see my actual screen. That should be visible quite well, I hope. So this is an overview of this lesion. It was a curettage specimen. You see a lot of bone, like this. So just the arrow, it is. So a little bit darker. So the arrow becomes more visible. Yeah. So you see bone trabecular anywhere and some intratrabecular tissue. So we go to a higher magnification, like this. And what is easily to notice that this is like that, yeah. But this is no normal intratrabecular matrix. So usually we are fat or maybe some small vessels, but this needs to be further investigated. It's quite sensitive. Just alter it a little bit. Oh. Yeah, I think they are, yes. This might fit. Okay, there you see some proliferations of cells which do not belong there, and they are hyperchromatic. And atypical. This is a spindle cell, which should not be in the bone. Of course, there are some inflammation, but it's dense, and they are polymorphic and spindle cells. And here you can see some mitosis, like here. This is a mitosis. And they are quite adjacent to the bone. And you can see here that there's initial production of some matrix. If we go up here, you again see some bone matrix. So here are the spindle cells, atypical. Those are cells that belong to the same group, but they lay down some matrix. So this is osteoid. And this is a malignant tumor. So I will go back to the presentation. So here again, you see again those atypical polymorphic spindle cells, mitotically active. Here again, dense infiltrates of atypical cells. Here you see hyperchromatic cells, very different shapes. Again, here, spindle cells. Here is a mitotic figure. Again, mitotic figures and highly atypical cells. Again, mitotic figures, hyperchromatic cells. Here, mitotic figures and remarkable polymorphism. And here, what you've seen before, this is matrix. So this is osteoid. This diagnosis is not compatible with chronic osteomyelitis. This is a malignant tumor. And this is a malignant mesenchymal tumor that's producing osteoid. So this is osteosarcoma. Of course, this was not expected. So I sent this case for consultation because we've got two diagnoses, osteomyelitis before. And then if you say osteosarcoma, it's better to have a second opinion because, of course, you will have to discuss this diagnosis. So, but in the meantime, we got more histology because we embed it in a decalcified way, and we also do some embedding in, let's say, plastics, so methyl methacrylate. So we can even investigate cortical bone in a reasonable time window. And when we investigated the cortical bone, those objects became visible. Again here, round, round, round objects that do not match with anything we know in bone can appear. So those little tiny circles with some material. I did some further stains like the PAS stain, and those granules lighted up. I also did some Grocott stain, and those structures became black. So what is this? So this looks like a spherule. So a tiny capsule with some organisms in the central part of it. So given the fact that the initial diagnosis was osteomyelitis, I need to do some investigations to see what it's all about. And it was very difficult to find out because these objects are quite rare in northern Germany. So this is a spherule, this is a spherule, this is a spherule, and this is a spherule. And if you are familiar with those organisms, it's quite an easy diagnosis. So this is coccidioidomycosis. And this image is taken from this publication in the Journal of Medicine, which illustrates the similarity between those objects. And I found also a very good information resource. This is the kerncountyvalleyfever.com homepage. Because this is a fungus that lives in the soil in areas of North America, Middle America, and South America. And it produces some aerosols, and if the patient inhales those aerosols, the organism multiplies in form of these little spherules, predominantly in the lungs of immunocompromised patients. And that's what those large spherules look like when they blow up. And then they reproduce again in the human body. Also, from the home page, a very good resource. And this disease is also called the valley fever, because it's quite frequent in some endemic regions in America. And of course, we're not used to this diagnosis. So in Northern Germany, you won't find this. And it's very difficult to guess if you do not know that a certain individual has traveled to these endemic regions. So, but if you compare it, the diagnosis is quite easy. So this is the Broca stain of a spherule with organisms in it. And here you see the image from this valley fever homepage. So, and now the diagnosis of the coccidioidomycosis is quite easy. So the final diagnosis was high-grade osteosarcoma with coincident fungal infection with coccidioidomycosis immitis. The patient was treated, unfortunately not in our hospital, but I was again very happy that the diagnosis was established. So the tumor was dissected and followed by chemotherapy. So this is the prosthesis and a control radiograph 1 year after therapy. And fortunately, I received the pathology report of the resection specimen, and which confirmed the spindle cell and pleomorphic sarcoma of bone, but didn't detect any formation of neoplastic bone. And also the coccidioidomycosis was not mentioned. So, but there are ways to explain this. First of all, the osteoid formation can be quite sparse. So you can embed 5, 10, 6 tissue blocks. You have a high-grade pleomorphic and spindle cell sarcoma, and you do not see the osteoid. So therefore, it might be that it was just focal, and I was very lucky that I've seen it on the small biopsy specimen. However, in this case, it's not of clinical relevance because the therapy regimen for osteosarcoma and spindle cell pleomorphic sarcoma of bone is completely similar. The other thing is that the organism can also be inhomogeneously distributed, and we have seen that the cortical bone was affected in our cases. In the biopsy specimen of the curettage material, I did not spot any infectious germ. So it might be just not sampled because the resection specimen is basically sampled for malignancy and resection margins. So therefore, this might happen. Anyway, we stick to the diagnosis of a high-grade osteosarcoma with coincident fungal infection with coccidioidomycosis immitis. And the teaching point of this case shall be that you always should expect the unexpected. The second issue, that you should take the radiology into consideration, and that you always keep in mind the differential diagnosis of a malignant bone tumor when you are dealing with an osteomyelitis. Yeah, well, so I come to the end of my presentation. I thank you for your attention, and I'm very happy to ask to answer your questions. Thank you for your attention.
You are very welcome. Thank you for sharing your wealth of knowledge with us, and it was very informative presentation, and it has made our concepts more clear. Thank you very much for your time and this presentation. Any questions, please? Anyone would like to ask any question? As the presentation was very clear and very vivid for everyone. Okay, I think there is no questions as everybody's concepts are clear now, but still if you have any questions, you can ask at the end. Thank you.
Okay, very well then. So we go on to our next speaker. And I would like to call on Dr. Sabine Bukhari from the UK to deliver her speech.
Thank you very much, Doctor. So now I'm going to commence with my presentation. Let me share my screen, please. Unfortunately, it's not showing. Try again, please. Share screen.
Okay, so we do a little alteration so we can go further on in our agenda. I would like to announce the next speaker, which will be Dr. Monal. So, Dr. Monal, please deliver your speech.
Good morning, sir. Good morning, everyone. Good morning, all the organizers of EPGO's 6th conference. And I'll start my screen share here. So, hello, everyone. I am Dr. Monal Drisel. I'm a pathologist from India. I am currently working as a senior resident in Hamdard Institute of Medical Science and Research, New Delhi, India. My today's presentation will be on spindle cell lesions of the breast A diagnostic dilemma. Why spindle cell lesions of the breast? Spindle cell lesions of the breast encompasses a wide, I'll minimize. Spindle cell lesions of the breast encompasses a wide array of lesions ranging from reactive, say some scar lesion, to neoplastic, highly malignant processes, most of which are uncommon and very distinctly rare. All the spindle cell lesions occurring in soft tissue can be encountered in the breast. Diagnosis of bland-looking spindle cell lesions of the breast are often challenging, especially on the core needle biopsy, and a close morphological and IHC overlap among the different entities can be seen. Most of these lesions can be appreciated on routine H&E stains. However, certain proportion require ancillary techniques, that is IHC, to arrive at a correct diagnosis. Aims and objective of our study was to study the histological characteristic of breast lesion, almost exclusively composed of spindle cells, with emphasis on pathological differential diagnosis. So it was a retrospective study done over a period of 2 years on breast masses presenting in surgical OPD of our hospital. Patients diagnosed with benign or malignant tumors having predominantly spindle cell component on HPE, which were posing a diagnostic challenge on core biopsy versus a resected specimen, were included in our study. An algorithmic approach was employed for diagnosing the spindle cell lesions of the breast based on cellular composition, presence and grade of atypia, growth pattern, mitotic activity in conjunction with IHC features wherever applicable, along with clinical radiological features. And 2090 WHO classification of breast lesions were used in reaching to a conclusive diagnosis. So I'll be presenting 5 interesting cases here. I'll be telling about 5 interesting cases here, which we encountered on core biopsy versus a resected specimen in the last 2 years. So coming to case 1, we had a 31-year-old female who presented with right breast lump since 2 years. Patient had a history of surgery at the same site 1 year ago. On physical examination, a hard, painless swelling was seen in medial quadrant of the right breast, and there were no clinically palpable axillary lymph nodes. On USG, on ultrasonography, we saw it showed a hypoechoic, irregular bordered soft tissue mass with speculations at 2 o'clock position, measuring nearly 4 into 1.4 centimeter. A score of BIRADS 4B was given. Based on clinical radiological findings, a diagnosis of carcinoma breast was made. We got a core biopsy was done, which revealed only bland-looking cells, only bland-looking spindly cells with no ducts, no acini. A diagnosis of spindle cell lesion of breast, negative for malignancy, was given. So this is a core biopsy, which only showed bland spindly cells, and there were no duct and acini, only bland-looking spindly cell with no pleomorphism, minimal pleomorphism, no mitotic activity, and a diagnosis of spindle cell lesion, negative for malignancy, was given. When we received the excision specimen, grossly, a lumpectomy specimen, consisted of a globular tissue piece measuring 3.3 into 3.4 into 3 into 3 centimeter. Outer surface was gray-brown with yellowish fatty areas. On cut surface, there were irregular whitish areas with yellowish areas in the periphery. Microscopic findings were, we saw ill-defined proliferation of spindly cells with sweeping in form of sweeping fascicles, haphazardly arranged. The spindly cell had ill-defined cytoplasmic borders. Nuclei were bland and elongated to mildly pleomorphic. Focal irregular infiltration was seen in the surrounding fatty tissue with inconspicuous mitosis. We saw a few entrapped spindly cells in fascicles going into the mammary duct and acini. They were in a collagenized stroma with keloidal-like spaces. So to the gross findings, to the histological findings from the core biopsy, it was unusually, we saw proliferation of spindly cell in sweeping fascicles arranged haphazardly. There were aggregates of mature adipocytes and going into the muscle bundle, entrapped within the muscle bundles here. we could see the entrapment of these fascicles into the skeletal muscle bundles. We saw they were the entrapment in the mammary ducts by the collagenized colloidal-like stroma. The spindly cell had ill-defined cytoplasmic borders, predominantly bland, elongated to mildly pleomorphic cells. In the high power, it can be appreciated here. A histological diagnosis of spindle cell lesion of the breast was given, and two possibilities were made: fibromatosis and low-grade fibromatosis like metaplastic carcinoma. IHC was seen to be positive for SMA and Vimentin, whereas it was negative for ERPR, CK, and P63. A final diagnosis of mammary fibromatosis was given. So the case was interesting, as in core biopsy, we just saw bland spindly cells, and in the histological specimen, we saw the bland in the cells were infiltrating into the skeletal muscle, into the deeper tissue, into the adipose tissue. A final diagnosis of mammary fibromatosis was given. Mammary fibromatosis is a rare benign entity characterized by spindle cell proliferation of fibroblast and myofibroblast, as well as varying amounts of collagen. It has no malignant potential. It can recur locally. Radiologically and grossly appears as a mass lesion. Histologically shows low-grade myofibroblastic proliferation. Treatment is by wide local excision, though it recurs. The most important differential diagnoses to be kept in mind are from scar to low-grade fibromatosis like metaplastic carcinoma and less likely sarcoma, especially causing a diagnostic dilemma on core biopsy. A recently described variant, fibromatosis like variant of metaplastic carcinoma, are very rare breast carcinoma comprising less than 0.5% of all breast carcinoma. These have better prognosis, prone to local recurrence, but is of low malignant potential. So a differential diagnosis when it comes to mammary fibromatosis, a close differential diagnosis of fibromatosis like variant of metaplastic carcinoma should be kept in mind. How to differentiate between a primary mammary fibromatosis and fibromatosis like metaplastic carcinoma? Mammary fibromatosis are rare benign entity ranging in less than 0.2% of primary breast tumors. They are seen in age of women of childbearing age with associated trauma, whereas fibromatosis like metaplastic carcinoma has a propensity for local recurrence. Mean age is 65 years. Microscopically, mammary fibromatosis shows non-encapsulated proliferation of spindle cells forming interlacing fascicles with variable collagen deposition and cellularity. However, no or rare mitotic activity is seen, no epithelial component is seen. In case of fibromatosis like metaplastic carcinoma, infiltrative fibromatosis like or myofibromatosis like growth pattern of bland spindle cell is seen in prominent collagenous stroma, infiltrative borders, usually inflammatory infiltrate. Low mitotic activity can be noted, and carcinoma or epithelial elements can be noted in case of fibromatosis like metaplastic carcinoma. IHC to differentiate Vimentin positive, SMA positive, and focal desmin positivity seen in mammary fibromatosis. ERPR CD34 is seen in mammary fibromatosis. It's negative. CK positivity, pan-CK positivity seen in fibromatosis like metaplastic carcinoma. P63 SMA positivity only in the keratin negative cells, usually only in keratin negative cells, and there is negative negativity for ERPR and HER2/neu. Coming to case 2, a brief clinical history of 30-year-old female presented with large recurrent right breast mass since 1 year, which was increasing in size. Patient had past history of cesarean section 6 years back, open gallbladder removal 2 years back. History of core biopsy and lumpectomy was done 1 year back in a different institution. The report said core biopsy report was reported as fibroadenoma, whereas on histopathology, the lump showed the features of benign phylloid tumor. Patient underwent mastectomy for recurrent tumor in our institution, and the gross findings of the mastectomy specimen were We received a mastectomy specimen measuring 28 into 19 into 12 centimeter. Overlying skin was ulcerating and showed large skin defect measuring 11.2 into 6.5 into 6 centimeter. A large bosselated tumor was seen occupying the whole breast, measuring 26 into 18 into 11 centimeter, 1 centimeter away from the resected margins. Cut surface showed grayish-white areas with hemorrhagic areas and focal areas of necrosis. It was the tumor was occupying whole of the breast with just less than 1 centimeter, 1 mm less than the resected margins were free. Microscopically, we saw biphasic tumor with predominant stromal component and few interspersed glandular structures. Interspersed leaf-like fronds projecting into the cleft-like spaces lined by double-layer epithelium. Moderate stromal hypercellularity was noted, and the cells were plump nuclei, irregular nuclear membrane, coarsely granular chromatin, and occasional conspicuous nuclei. So this is the photomicrograph showing predominant stromal component. In some of the areas, we couldn't see any duct and acini. We just saw stromal hypercellularity in many high power fields and low power. This is leaf-like fronds projecting into cleft-like spaces and stromal hypercellularity. Spindly shaped cells with plump nuclei, irregular nuclear membrane, and prominent nuclei were seen in some of the cells. This is an atypical mitotic figure, pleomorphic spindly cells and prominent nuclei here. And in many of the cells, we could see prominent nuclei. Necrosis, a focus of necrosis seen, stromal hypercellularity. So few of the areas showed around 5 to 9 mitotic figures per 10 high power field. Focal stromal overgrowth was seen. Large areas of hemorrhage, necrosis, focal myxoid areas were seen. Based on above histological features, a diagnosis of borderline phylloids tumor was rendered. So the diagnostic dilemma here was that in core biopsy, it was reported as fibroadenoma. On the resected specimen done outside, it was benign phylloids tumor. And in 1 year, the growth was, the lump was seen to be recurring, and we could see the diagnosis of a borderline phylloids tumor was given. According to the mitotic figures, stromal overgrowth, areas of hemorrhage necrosis. So a final diagnosis of borderline phylloids tumor was given. For phylloids tumor, rare biphasic tumor, uncommon than fibroadenoma. It is characterized by variable degree of stromal proliferation, resulting in distortion of the architecture, giving a characteristic leaf-like pattern, also known as cystosarcoma phylloids. Phylloids tumor usually pose a diagnostic difficulty in differentiating it from more common stromal tumor, that is fibroadenoma, especially on the core needle biopsy. It poses a diagnostic challenge. The cytological diagnosis of phylloids is mainly suggested by presence of hypercellular stroma and stromal elements on smears being more numerous than the epithelial ones. So the distinction between benign phylloids and borderline phylloids and fibroadenoma is difficult on a core biopsy, or sometimes a diagnosis of fibroepithelial lesion may be sufficient in such cases when there is a diagnostic difficulty, with a note suggesting complete surgical excision. Here is a table showing differences between benign, borderline, and malignant phylloids tumor. Stromal hypercellularity is minimal in benign. Stromal overgrowth is minimal in benign phylloids. Mitosis is 0 to 4, and tumor margins well circumscribed with pushing tumor margins. In case of borderline phylloids tumors, stromal cellularity and ATP is moderate. Stromal overgrowth is moderate. Mitotic activity is 5 to 9 per 10 high power field. Tumor necrosis, tumor margins, zone of microscopic invasion around the tumor margins can be seen. So these 4 of the features were seen in our histological slides in the case of the borderline phylloids. And in malignant, there's marked hypercellularity, marked stromal overgrowth, and more than 10 mitosis per 10 high power field. Tumor margins are usually infiltrated by the tumor. Coming to case number 3, a patient, a 42-year-old lady, complained of recurrent large red right breast mass in inner quadrant measuring approximately 10 into 8 into 6 centimeter. MRI revealed an irregular speculated mass measuring 11.5 into 9 into 7 centimeter with decreased T1 signal intensity and increased T2 signal intensity. Core biopsy was done, which the features were suggestive of a benign stromal tumor. So here's a core biopsy, which we received of the same patient, showing a benign stromal tumor because we could only see bland-looking spindly cells in a collagenized stroma, in a loose stroma, and no other atypical cells, anything was appreciated on this biopsy. We could see no mitosis, no epithelial, no epithelium, no SNI ducts. We could only see bland-looking epithelium. So diagnosis of benign stromal tumor was rendered. And we received a gross specimen of, we got a lump, we received a lumpectomy specimen, which was capsulated, globular, gray tan, measuring 12 into 10.5 into 8 centimeter. External surface was irregular, nodular, and congested. Cut section showed a tumor with multinodular solid areas, gray-white in color with foci of hemorrhage. Tumors was seen encroaching the capsular area with slit-like areas at the periphery. Focal areas of necrosis was seen. So according to the core biopsy, which was benign stromal tumor, we received a lump. On the microscopic finding, an unusual tumor was found. It was a heterogeneous tumor composed of mixture of mesenchymal and epithelial components, with predominant areas showing fascicles and bundles of spindly to ovoid-shaped cells exhibiting marked pleomorphism, coarse vesicular chromatin, and moderate cytoplasm. We could see brisk atypical mitosis. We could see large areas of necrosis, areas of myxoid degeneration, and focal osteoclastic-like giant cell. Proliferation of bland cell was seen in fascicular and storiform pattern. Also, we could see DCS component along adjacent to the spindly areas. So unusually from the core biopsy on the histological lumpectomy specimen, we could see an unusual heterogeneous tumor composed of atypical epithelial and mesenchymal components, which we couldn't appreciate, we couldn't see on the core, which was missed on core biopsy because the lesion the needle the biopsy must have been taken from some other site of the lump. So this is a heterogeneous tumor composed of mesenchymal and epithelial components. There were brisk atypical mitosis in each field. We could appreciate 8 to 10 mitosis, even more in some fields. So these are atypical mitosis here. These are the atypical mitosis. We could see nuclear pleomorphism, coarse vesicular chromatin, moderate cytoplasm, and prominent nuclei. The fascicles and bundles of spindly cells exhibiting marked pleomorphism, coarse vesicular chromatin, and moderate cytoplasm. IHC was seen to be positive for pan-CK and P63. We couldn't procure slide for P63 as in such short time. So final diagnosis of metaplastic spindle cell carcinoma of breast was given. So from core biopsy and to such unusual diagnosis we found on lumpectomy specimen. Later on for the same patient, mastectomy was done for residual tumor, if any, but it was negative for any tumor. So metaplastic spindle cell carcinoma is a group of uncommon malignancy of breast, usually is biphasic, has mixed carcinomatous and sarcomatoid component, which is monophasic, and with sarcomatoid component alone. At the malignant end of the spectrum, metaplastic spindle cell carcinoma is the commonest diagnosis. A malignant diagnosis can be made if there is definite epithelial differentiation on morphology on core biopsy. Focal epithelial differentiation based purely on core biopsy should be cautiously interpreted. In challenging cases, full differential diagnosis including malignant phylloids, tumors, sarcoma, metastasis needs to be considered. Clinical history, IHC enables the differential diagnosis. Occasionally, features are clearly malignant, but definite diagnosis is not possible. A definite diagnosis should only be attempted on surgical specimen. So coming to case number 4, with a clinical history of a 60-year-old female presenting with mobile left in a quadrant breast lump since few years. On ultrasonography, we found a mass which appeared homogeneous, well circumscribed, hypoechoic, and avascular solid mass measuring 2.5 into 2 centimeter. Patient underwent core needle biopsy. Core needle biopsy was suggestive of fibroadenoma. On core needle biopsy, we could only see a pericanaliculaire pattern, TDLUs, and periclinicular pattern of the lesion. So a diagnosis of fibroadenoma was given. When we received the excision specimen grossly, it was a skin-covered gray white soft tissue piece measuring 2 into 1 centimeter. Cut section was homogeneous gray white with foci of hemorrhage. Microscopically, the sections showed epidermis and dermis. Dermis showed presence of nodules of spindle-shaped cells and fibrocollagenous tissue interspersed with variably sized slit-like spaces. These individual spindle-shaped cells had bipolar cytoplasmic processes, spindle-shaped to oval nuclei with bland chromatin. So this is a dermis. This is epidermis and dermis. We could see spindle-shaped cells and fibrocollagenous tissue interspersed by variable slit-like spaces lined by endothelial-like cells. But these are myofibroblast-like cells. These are simulated like a vascular lesion. A final diagnosis of PASH was given, pseudo-angiomatous stromal hyperplasia on the excision specimen. PASH, pseudo-angiomatous stromal hyperplasia. It's a histological benign proliferative lesion composed characteristic interconnected slit-like pseudovascular space lined by spindle cells, that is myofibroblast, on a background of stromal hyperplasia that resemble endothelial cells in a background with keloid fibrosis. Clinically, PASH presents as a painless, palpable breast mass in 44 to 54% of women. PASH can also occur in nodular form with or without in association with other breast lesions. It can be seen in breast carcinoma and hematomas. It can be associated with breast carcinoma also. Preoperative diagnosis on clinical and radiological assessments alone is very difficult. FNAC is not useful. Thus, in a core needle biopsy with bland spindle cells lining apparent vascular spaces, PASH should be borne in mind. So case number 5, a 33-year female who presented with complaint of large retroareolar left breast mass since an year growing in size. USG showed large multilobulated hypoechoic solid mass with moderately heterogeneous internal ecotexture, occasional internal microcystic areas, approximately measuring 9 into 7 centimeter in 12 o'clock position in left breast. Core biopsy revealed fibroadenoma. On core biopsy, we could see a intraclinicular pattern of fibroadenoma. Gross finding resected specimen mass, it was an encapsulated irregular lobulated gray-white mass measuring 8 into 5 into 3 centimeter. On cut sections, slit-like areas were seen along with myxoid areas. Microscopically, section showed circumscribed biphasic lesion with pushing borders and stromal hypercellularity. Benign glandular elements were seen with cleft-like spaces. Myxoid degeneration and hyalinized stroma was present. However, there was no atypia and mitotic figures. So these are benign glandular elements with cleft-like spaces and stromal hypercellularity. So a diagnosis of benign phylloid tumor was given in the excision specimen. So just briefly summarizing all the 5 cases which had a diagnostic difficulty, which we faced a diagnostic difficulty on the core biopsy versus a resection diagnosis. Pre-operative core biopsy for the case 1, which we diagnosed as negative for malignancy. On resection specimen, we diagnosed it as a DD of fibromatosis or low-grade fibromatosis like metaplastic carcinoma. IHC was positive for vimentin, actin, and focally for desmin. However, it was negative for CK, P63, and ER-PR. A final diagnosis of mammary fibromatosis was rendered. In case of case 2, benign core biopsy, which showed benign phylloid tumor. On resection, it showed borderline phylloid tumor. IHC was not applicable for this as the diagnosis was clear. Case 3 was benign stromal lesion, which was given a diagnosis of benign stromal lesion was given on core biopsy, possibly phylloid tumor. It came out to be metaplastic spindle cell carcinoma of the breast. PAN-CK and PAN-63 was positive. P63 was positive, and a diagnosis of metaplastic spindle cell carcinoma was given. Case 4, which suggested of fibroadenoma on core biopsy, turned out to be PASH on resected specimen. Case 5, which suggested of fibroadenoma on core biopsy, turned out to be benign phyllodes tumor on the resection diagnosis. So discussing the spindle cell lesions of the breast, although most spindle cell lesions of the breast are rare, they constitute a wide spectrum of disease ranging from reactive process to aggressive malignant tumors. Despite their varied histogenesis and behavior, they show some overlap of morphological features, making accurate diagnosis a challenging task, particularly on the core needle biopsy. So diagnosing spindle cell lesions on core needle biopsy is based on awareness of clinical setting, careful examination of H&E stain slides, and IHC. Clinical history and IHC can help make a correct diagnosis in morphological challenging cases. To make an accurate diagnosis, it is important to maintain a wide differential diagnosis and be familiar with diverse morphological appearance of these different entities. So a simplified approach is, in the simplified approach, spindle cell lesions can be divided into 4 groups. Biphasic lesions with predominance of spindle cells with benign epithelial, biphasic lesions with predominance of spindle cells with malignant epithelial component, monophasic lesions with pure pleomorphic spindle cell only, monophasic lesions with pure bland spindle cells only. So biphasic lesions with predominance of spindle cells with benign epithelial component are most commonly our fibroepithelial lesions, that is fibroadenoma and phyllodes tumor. Other lesions include PASH, hematomas, and adenomyopitheliomas. Biphasic lesions with predominance of spindle cell with malignant epithelial component includes metaplastic carcinoma as a main lesion in this category. Where thirdly, monophasic lesions with pure pleomorphic spindle cells, the monophasic type of metaplastic carcinoma is common. Other lesions to consider include sarcomas like malignant fibrous histiocytoma, angiosarcoma, and high-grade sarcomas and other high-grade sarcomas. Lastly, monophasic lesions with pure bland spindle cells only. The possible lesions include fibromatosis like metaplastic carcinoma, other unusual conditions like DFSP, dermatofibrosarcoma protuberance. So case lessons learned here while dealing with core biopsy and resected specimen were, highlights the challenge of rendering a definite diagnosis of malignant spindle cell neoplasm on core needle biopsy, emphasizes the potential diagnostic pitfall of IHC interpretation on core needle biopsy, diagnostic difficulties in spindle cell lesions on core needle biopsy, limited sample of larger lesion, definite feature may not be present, such as conventional invasive carcinoma or leaf-like architecture can be missed, morphological overlap between spindle cell lesions, immunophenotypic overlap between lesions. So take-home messages can be, the pathologist should be aware of spindle cell lesions of breast, including rare entities, to achieve correct diagnosis, facilitating a correct prognostic information and therapy. Extreme caution needs to be exercised when dealing with spindle cell lesion on core biopsy, as benign spindle cell lesions can look malignant and malignant can look benign. Definite characterization may be impossible on core needle biopsy. The role of IHC cannot be overemphasized in diagnostically challenging spindle cell lesion of the breast in conjunction with precise clinical radiological information. So these are my references. Thank you. Thank you, everyone.
Yes, thank you, Dr. Mono, for this very illustrating presentation. I especially like the macroscopic photos because we know all in pathology that when we do the macro on our own or see the macro, we got lots of information. And this is another important element in our evaluation. So thank you especially for the correlation of histology and the macroscopic pictures. And of course, yes, and of course, thank you for pointing out the dangerous points. For example, spindle cell lesions. Be careful on biopsy. especially for residents or pathologists in training. These are highly valuable information, and it's very important to point this out.
Thank you, sir. Thanks a lot, sir.
So are there any more questions from the audience? Yes. Any more questions from the audience? Oh, well, I've got a brief question. What kind of immunohistochemical markers do you use to exclude or confirm epithelial origin in the spindle cell lesions where you want to know something about whether it's a sarcomatoid carcinoma or not?
So cytokeratins, high molecular weight cytokeratins, P63 if there is any squamous differentiation, for myoepithelial differentiation, and mainly these.
Okay. Was this a question?
Hello, can I ask a question?
Yes, of course, you're welcome.
Okay. Hello, doctor. Thank you for your good, useful lecture.
Thank you, ma'am.
Okay, I want to ask something. If I have a benign spindle cell lesion on core biopsy of breast, it looks,
Yes.
I mean, it looks benign, no atypia, no mitosis detected, but only I saw in a core biopsy of breast blonde spindle cell. I mean the stromal cellularity without breast duct inside. So what marker should I ask before I say benign fibroepithelial lesion in favor of fibroadenoma? Because I saw, as I say to you, one fragment showing only blonde spindle cell, and the other fragment show the lesion suspecting fibroadenoma. So in this fragment, what immune stain I should ask for?
You can, for a broad, first confirming a spindle cell lesion, a Vimentin can be done to start with. You can, for further, you can do ER-PR negativity seen also in spindle cell lesions. If you are suspecting fibromatosis, you can do SMA. It depends on how broad the diagnosis is. If you have a narrow diagnosis of say fibromatosis or fibromatosis like metaplastic, or you have MFH, BFH, or nodular fasciitis, you can do a CD34, SMA. It depends on what the diagnosis you are suspecting. If it is
and the CD34, it is also positive in phylloid. If it is positive, I can suspect phylloid, also benign phylloid tumor.
CD34 in phylloids, it will be seen in stronger positivity. Will be seen in a fibromatosis like nodular fasciitis. It will be stronger positivity, where it will be a weaker positivity in a benign phylloids or a phylloids tumor. The intensity.
If it is focal positive and this is spindle cell lesion, so it will be benign phylloid. If it's strong positive, it will be other.
If you see any leaf-like, if you see other characteristic features of phylloids like leaf-like patterns, stromal hypercellularity like a stroma of breast, not stroma of any soft tissue tumor.
No,
then you can suspect.
I only saw, as I say, I only saw one fragment of a stroma over cellularity only, no leaf-like, no other pattern of phylloid.
So you can just make a diagnosis of a spindle cell lesion, and a note can be given for excision, for more biopsy, representative biopsy, or an excision biopsy. Excision biopsy if it is a smaller lesion. If there's no, if you don't suspect any malignancy, clinical radiological features will help you.
Radiological. It is BIRAD 4. The lesion is BIRAD 4.
BIRAD 4. So clinical radiology.
Thank you, doctor. Thank you.
Thank you, ma'am.
Any more questions? Okay, if no, thank you again, Dr. Moll, for your very impressive presentation. And now I would like If not so, thank you again for your presentation. And I call upon the next speaker, which will be Dr. Mina Verma.
Yes. Can you hear me?
Yes, we can hear you.
Good
And
evening,
now,
all of you. Very good evening, all of you. Thank you for giving me this opportunity on speaking on an international platform. I would be presenting my thesis work or research work which I did in the MD pathology, and I was working as a demonstrator in the Department of Pathology, PJMS Rohtak, till 4th of Feb. Then I got admission in NEET super specialty in a clinical hematology, and now I joined the Dr. BL Kapoor Hospital in Delhi, India. And this is the presentation which I did in the MD pathology in a PJMS Rohtak. I'm going to present my thesis work. Kindly, now I want to share my content. Just a minute. Can you see my presentation?
yes, perfect.
Okay. So my topic of my research was immunophenotyping of non-Hodgkin's lymphoma on fine needle aspiration by flow cytometry. This research was done in the Department of Pathology. First of all, I would like to give some brief introduction. Lymphoma represents one of the major health problems all over the world. And we all know the non-Hodgkin's lymphoma are a heterogeneous group of malignancies that arising from the lymphoid tissue with a varied clinical and biological features. According to the WHO, non-Hodgkin's lymphomas are distinct clinico-pathological entities defined through a comprehensive evaluation of morphological, immunophenotypic, genetic features, and clinical data, not only the morphology alone. So, in fact, in different types of NHL, similar morphology may be there, but a different cell origin, different immunophenotypic, and different biological behavior. First of all, whenever a patient present with the lymphadenopathy, the first investigation is done is the fine needle aspiration cytology, which is done for the diagnosis of NHL, but it only tells about the morphological features, which are not sufficient to diagnose and classify the NHL. That's why we require some ancillary techniques which can classify the NHL. Among the ancillary techniques, we have ISC and flow cytometry and moleculars. And this thesis was done for on flow cytometry, which is a basic lymph node ancillary technique for the diagnosis and classification of NHL. Flow cytometry works on the evaluation of lymphoid B and T cell antigens. Then there is a clonality assessment of light chains in case of B NHL. There are different methods which can be used for the clonality assessment and antigen expression of lymphoid cell population, but flow cytometry is the most effective one. So aim and objective of our work was to assess the utility of flow cytometry immunophenotyping in diagnosis and differentiation of reactive lymph node and non-Hodgkin's lymphoma on a fine needle aspirates. And second one was to correlate the results of FNAC and flow cytometry with the histopathology and IC wherever it was possible. Inclusion criteria taken for the research was only suspected and confirmed cases of NHL on FNAC were taken for this research. Material method used for this thesis was this prospective study was carried out on 50 patients in the Department of Pathology, Pandit B.D. Sharma, PGIMS, Rohtak. There were 25 cases of reactive hyperplasia and 25 cases of NHL. Reactive lymph node was taken as a control for this study, and exclusion criteria were non-Hodgkin's lymphoma patients which were on chemotherapy, metastatic non-lymphoid malignant disease, and Hodgkin's lymphoma. Specimen preparation was done by 0.5 ml of RPMI 1640, that is the tissue culture media, was taken in 2 Eppendorf tubes for each patient. FNAC was done by standard technique using 23 gauge needle and a 10 ml syringe. FNAC smears were prepared using the Leishman stain. Another pass of needle was done and material was collected in RPMI 1640 tissue culture media for flow cytometric analysis. After that, suspension was divided into multiple tubes depending on adequacy of the cells. Flow cytometric analysis was done on Becton-Dickinson flow cytometer by dual color analysis technique. This is the table showing the panel of antibodies that is used in our research. These are the 7 tubes. First tube is a lymphoma screening tube in which CD8, CD4, CD3, CD19, CD56, CD45 antibodies were added. In the next tube, lambda, kappa, and CD20 were added. In a third tube, that is B1, CD79B, CD10, CD5, CD19, CD20, and CD45 were added. In the B2 tube, FMC7, CD200, CD38, CD19, CD23, CD45 is added in all the tubes. Then there is the T tubes, that is for the T cell NHL, T cell alpha beta, TCR gamma delta, CD5, CD3, CD7 were added. For hairy cell leukemia or lymphoma, we have a CD103 marker, CD123, CD19, CD25. For NK cell lymphomas, we added CD2, CD30, CD16, CD3, and CD57. So this was the antibody panel we used in the research work. Data interpretation was done by list mode data on FACS Canto 2 flow cytometer BD biosynthesis and analyzed by FACS Diva software. More than 30% expression of any gated events on site scatter versus CD45 plots were considered as positive. These are the results of our observation of our work. This table is showing the distribution of cases according to the age in case of reactive hyperplasia on flow cytometry. Most of the cases, that is the 16 out of 25 cases, were in the age group of less than 30. That is 60 and constitute this 64% of the total cases. This graph is showing again, this showing the more than Less than 30 years of the age group constitute the 16 cases in case of reactive hyperplasia. This table is showing distribution of the cases according to the age which were suspicious on lymphoma on FNAC. In this, in 16 out of 25 cases, 16 cases were in the age group were more than 50 years of the age and constitute 64% of the total cases. Again, this is again the same. There were male predominance in our thesis. This table is showing distribution of cases according to the site in the suspicious lymphoma cases. In our study, we find the cervical lymph node is the common site for the NHL cases. That is, the 17 out of 25 cases were presented with the cervical lymphadenopathy. 4 were with the axillary lymph node and 4 with the inguinal lymph nodes. This table is showing the distribution of cases which were suspicious of lymphoma on FNAC and showed monoclonality pattern. Kappa restriction was seen in 6 cases, lambda was seen in 9 cases, and there was no restriction in 2 of the cases. But still, they were made the diagnosis. They were made the diagnosis of BNHL because of high intensity of CD19 and CD20 positivity. This again graph showing the kappa restriction and lambda restriction. Lambda was more in thesis. This is the table showing the subtyping of BNHL on flow cytometry. In our work, we find the most of the cases were in the group of small lymphocytic lymphoma. 1 case was diagnosed as mantle cell lymphoma and 1 was follicular lymphoma. Another 9 were diagnosed as BNHL, not otherwise specified. The mantle cell lymphoma case was confirmed on histopathology by applying the cyclin Day-1, and follicular lymphoma case was also confirmed on the histopathology by applying the BCL2 and BCL6. This is the table showing the distribution of the cases which show the concurrence between flow cytometry, FNAC, and histology. Out of 22 cases, we were able to follow only 9 cases on histopathology. 6 out of 6 of SLL cases, 2 were followed for the histopathology. 1 was follicular and 1 for mantle lymphoma was also confirmed on the histopathology. 9 cases which were suspicious of FNAC and diagnosed on the flow cytometry as BNHL, not otherwise specified. On histology, BNHL peripheral type was diagnosis of peripheral B type was given. And this table is showing which we use as a criteria for diagnosis of BNHL for the flow cytometric analysis. In case of SLL cases, there was a light chain restriction and they were positive for CD19, CD20, CD5, CD23, CD10 negative cases. 1 case which was mantle cell lymphoma was positive for CD19, CD20, CD5 and negative for CD23 as well as CD10. With the case which was diagnosed as a follicular lymphoma was positive for CD10, and this case was confirmed on histopathology by applying the BCL1, BCL6. These are some photographs. This photograph is showing the case of reactive hyperplasia with CD19 and CD3 positivity in B and T cells. Figure B is showing both the ratio of kappa and lambda in equal amount. This is the case which was suspicious of lymphoma on flow cytometry and for the diagnosis of this case, we applied flow cytometry panel, and there was a kappa restriction in that case. Further, this case was positive for CD5, CD19, CD79B, and CD23, CD38, and CD200. And the diagnosis of SLL was made on flow cytometry. This table is showing the FNSC and flow cytometry discordant cases. There were 4 cases, 3 cases which were suggestive of chronic lymphoproliferative disorder on FNSC, and they were reactive or polyclonal on flow cytometry. Unfortunately, we could not follow these cases for further histology, and this was a limitation of our study also. And one case which was suggestive of chronic lymphoproliferative disorder was reactive on flow cytometry and came Hodgkin's lymphoma on histology. This table is showing the comparison of some of the studies, like Day et al. In case of the they conducted a study in 2006 in which they found that SLL is the most common subtyping, and Ansani et al. Also found that SLL is the most common NHL. And in our study, we also found out of 17 cases, 6 cases were of SLL. To conclude, we conclude that flow cytometry enhances the diagnostic ability of FNSC cytology, and the combined approach has a high diagnostic value that allows a reliable subclassification of low-grade B-cell non-Hodgkin's lymphoma. But there were some limitations of our study. One, which we did not, because we did not find any T-cell lymphoma. It could be due to small sample size of the study, and 3 cases which were discordant on FNSC and flow cytometry. We could not follow these cases for the histopathology, and 4 cases which were suspicious on FNSC, and in these cases we could not aspirate the sufficient amount of material for the flow cytometric analysis. These are the references which I used in my study. Thank you all for listening me. Thank you.
Well, thank you, Dr. Mina, for this very comprehensive contribution. Are there any questions from the audience?
Yes, sir. Sir, I am not able to on video.
There you're back.
Yes, sir. Yes, sir. Thank you, sir.
Are there any remarks or comments to the presentation of Dr. Mina? Well, if there are no spontaneous questions, keep your questions in mind. There will be surely an opportunity to comment on that, or you can write it in the chat, for example. So as far as I see from the schedule, we are through the series of presentation of today, well, at least through the first session. And so what I would like you and ask you for,
yes, sir.
We would like to take the opportunity maybe to take a group photo of the Congress. And if you would like to turn on your cameras, only if you like, for a short snapshot. So UCG conference, take a short image of all the participants that are now online, which would be very nice.
Sorry, sir.
So we see. Oh, so at least 6 people are not only watching. Whoa, there are lots of people. So take your time. See if your technology works.
Okay. So should I present again?
Come again, please.
I don't need to present again. It's just to call everyone to turn on their camera so we could have the group photograph of everyone who is the participant, please. We want you all to turn on your cameras, please. At the moment, we have 33 participants and we could see very few on the screen. If any of you like to share your cameras with us, please, just for a group photograph. Thank you. I can see one more person, Manar Ahmed. Anyone else, please? Would you like to turn on your cameras, please? We have still 33 participants.
So this looks pretty well. I think about half of the participants are visible, which is cool. Nice to see you.
Thank you.
Thank you.
Okay, so thank you very much for turning on your cameras. This looks very good and comprehensive. So then we go to the next very important point of our schedule, lunch break. So, and as far as I know, we will resume. Let me see, we are a little ahead of schedule. So, so we will, if you stick to the schedule, we will meet at 3 p.m. London time, as far as I know. Please correct me if I get this wrong. So we will have a break of about an hour.
Yeah.
Very well. So yes, thank you for your contributions. Especially thank you to all the speakers. This has been very interesting, enlightening, and well illustrated presentation. And I hope we will continue like this after the lunch break. So see you soon and have a nice day.
Thank you so much.
Thank you, sir.
Thank you.
Thank you very much.
Hello? Hello?
Yes.
The break will be for 1 hour?
Yes, exactly.
Okay, thank you. Thank you very much. Okay, bye-bye.
Hi, welcome back, everyone. So let's commence with the next speaker, please. I call upon our next speaker, Dr. Priyam Vada Yadav from India, to deliver her speech. Thank you.
Hello, good afternoon, everyone. Am I audible?
Yes, please.
Yeah,
Hi.
okay, that's good. Yeah, so greetings from India. First of all, I'd like to thank all the hosts for giving me this wonderful opportunity to present on an international platform. And it will be really wonderful to interact with all of you. So just a brief introduction. I'm Dr. Priyam Vada Yadav from India. I have done my MBBS and MS ophthalmology from India only. And after that, I did a fellowship in comprehensive ophthalmology. Currently, I'm working at Regional Institute of Ophthalmology, Postgraduate Institute of Medical Sciences, Haryana, India. So I would like to share my screen. Is my screen visible?
Yes, it's visible. Yes.
Yeah,
Thank
okay.
you.
Yeah. So I would like to acknowledge my co-authors, Dr. Urmil Chawla, who is professor at PGIMS Rohtak, India, Dr. Virendra Singh, who is head and senior professor, Department of Oral and Maxillofacial Surgery, Postgraduate Institute of Dental Sciences, and Dr. Mina from Department of Pathology, PGIMS, Haryana, India. So I hope my slides are visible and I'm audible. Yeah, okay. Today I'd like to discuss the case of mucormycosis in an immunocompetent child, and that too with an atypical presentation. Any suggestions or questions at the end of the presentation are highly welcome. So a brief introduction. Mucormycosis is an acute or subacute, rapidly progressive infection by angioinvasive fungus of the order Mucorales. It's a deadly, it can prove to be a deadly disease in patients who have poorly controlled diabetes mellitus or the patients who are immunocompromised. It has a very rare incidence in patients who are immunocompetent. So mucorales are the second most common organisms after Aspergillus in hematological malignancies, hematopoietic stem cell transplantation, and solid organ transplantation. Besides, its occurrence has also been noted after trauma or iatrogenic injury in patients with uncontrolled diabetes and after natural disasters. The common species that infect humans are Rhizopus, Lectemia, Apophycomyces, Mucor, and Rhizomucor. The human infections are less commonly caused by Cunningham and Saxenia. The fungus thrives on decaying plant debris and soil. Now, the type of mucormycosis that has been seen in humans, the most common type is rhino-orbitocerebral that usually starts with the paranasal sinuses, then spreads to the orbit, and from there it can spread to the brain. Second common type is the cutaneous that usually occurs following inoculation of the fungus inside the skin following any form of trauma. The fungus is ubiquitous in nature. Pulmonary type can occur following inhalation of spores. The gastrointestinal type can occur following ingestion. Disseminated variety is little less common, and the term is given to the infection when it affects two or more than two organs that are non-contiguous. Isolated involvement has also been noted, like isolated involvement of lymph nodes, liver, kidney, urinary bladder, uterus. These can also occur, but these are rarer. Now, the most common type is the rhino-orbitocerebral mucormycosis. It's commonly due to Rhizopus oryzae, and almost always it is seen in immunocompromised patients. That is, the patients who have uncontrolled diabetes mellitus, the patients who have been on chronic steroid therapy, and patients with hematological malignancies. Besides, it can occur in hematopoietic stem cell or solid organ transplant, patients having retroviral disease, malnourishment, and particularly in patients who have an iron overload state. Now, because the fungus is ubiquitous in nature, so that means we can find it anywhere. So how do we normally avoid this? So the course in immunocompetent host usually follows like the spores are inhaled, and through the cilia in the nose, they are directed to the pharynx. This is then eliminated by the gastrointestinal tract. So the phagocytosis in an immunocompetent host effectively contains the infection. In patients who are immunocompromised, the condition becomes little different. These patients have impaired phagocytosis. In these patients, the spores of the fungus get a chance to germinate. And then these hyphae, these spores which germinate into hyphae, they go for angioinvasion. Now they happen to destroy the internal elastic lamina of the arteries. And once this angioinvasion has occurred by these hyphae, they incite an inflammatory reaction. And all this combined lead to thrombosis of the vessels. Now this thrombosis of the vessels leads to tissue necrosis because of infarction. And that leads to the characteristic eschar formation that is seen with this infection. That is the hallmark of this condition. Now, in case of rhino-orbitocerebral mucormycosis, the path usually followed by the fungus is the initial site is nasal turbinates, where it goes through the environment by inhalation, and the spores get deposited there. Now, this is followed by sinusitis, and this sinusitis can further progress into pansinusitis. Now, once all the sinuses have been invaded and there occurs angioinvasion, there is infarction, there can be bone erosion. So then from the sinuses, there can be involvement of the palate, there can be involvement of the orbit, and there can be involvement of the brain. Now, brain can be involved either from the orbit. Once the sinuses, the infection has gone from the sinuses to the orbit, this can go from the orbit to the brain, or sometimes the infection can directly go through the sinuses themselves to the brain. There also, the pathogenesis remains same. Because of angioinvasion, there is tissue ischemia and necrosis. So the spread, as we have discussed, is usually there is angioinvasion and bone erosion that is followed by orbital involvement, and subsequently there is involvement of brain. Sometimes directly the infection spreads from the ethmoidal sinuses to the frontal lobes, or the infection can also spread from the sphenoid sinuses and lead to cavernous sinus thrombosis. Now, the histopathological examination. The smears used are wet KOH preparation. The scraped smears are of hematoxylin and eosin and papanicula. Air-dried smears of periodic acid skiff and May Grunwald chimsa. The surgical sections are processed in paraffin and examined under these stains. Now, once, as we know, mucormycosis, debridement of the infected tissue is one of the bases in the management, is one of the management protocols. So the debrided tissue, again, we look for the histopathology, and what we look for there are elongated, broad, ribbon-like hyphae that are irregularly branching at right or obtuse angles, and they have no or scanty septations. We can also see thrombosed blood vessels with significant necrotic areas and giant cell inflammatory reaction. There can be widespread infiltration with lymphocytes, eosinophils, and occasional plasma cells. Now, these can be seen by some special stains also, like calcopro white or Grocott Gomery methenamine silver staining, and they demonstrate twisted septate hyphae. Coming to the case report. So the case report is of a 2-year-old female child who presented to our ophthalmology OPD, and the parents gave the history. They complained of a swelling in the kid's right upper and lower lid since 3 weeks. The swelling, as per history, was gradually increasing in size, and it increased in size after sleep. There was history of some nasal discharge few days before the swelling started. There was no history of any significant trauma. There was history of consultation for these symptoms with some local practitioner, but no relief in symptoms was noted. There was history of no other systemic illness. On clinical examination, on general examination, the child was little irritable. The body weight, this was a 2-year-old female child, and she had a body weight of 8 kilograms, and the child was anemic. Local examination regarding the vision, the child followed objects with both the eyes. On palpation, there was a woody hard swelling with erythema in the right lower and upper lid. Both globes appeared normal. There was no proptosis, conjunctival congestion, or chemosis. The pupils of both the eyes were round, 3 millimeter in size, reacting to light with no relative afferent pupillary defect. The ocular movements were also grossly full, and the fundus showed a good glow. Now, this was the condition of the child at presentation. And as per the history, this was the swelling which was gradually increasing in size, and it was noted to increase following sleep. So this was, the child was having swelling more in the lower lid compared to right. And as we can see here, it was more tense, it was woody hard, and it was giving a tense feel, more so nasally towards the medial canthus. Now, we admitted the child and investigated. So the HP of the child was 9.1 gram% at presentation. Excuse me. Now this HP dropped down further to 7.8 gram% during follow-ups. So blood transfusions were also given, and following transfusion, it stepped up to 12 gram%. The total leukocyte count at the time of admission was 18,000. The peripheral blood film showed few microcytic hypochromic cells. The rest blood investigations were found to be within normal limits. Initial blood cultures were normal, and ultrasound abdomen was also found to be within normal limits. Now, looking at the condition and suspecting it to be a cellulitis, we started the patient on intravenous broad spectrum antibiotics that covered gram-positive, gram-negative, and anaerobic organisms. But no response was noted even after 3 days of initiation of the treatment. We got an ENT consult, and in the ENT review, there were no significant findings noted. The endoscopic examination was also found to be within normal limits, and only decongestants were given from the ENT side. Pediatric opinion was sought in view of low weight and anemia. From there also, conservative treatment was started. Now, when the child didn't respond to it and nasally, the swelling tended to become more tense. So we did an incision and drainage from the dependent portion, but that revealed no pus and only blood was noted. Now, this put us into a diagnostic dilemma. The child was not responding to any antibiotics, broad spectrum antibiotics, and on incision and drainage also, there was no pus, only blood was there. So what was the thing? We got the child imaged. So CT scan of the orbits and paranasal sinuses was performed, and that showed mild maxillary sinus roof thickening on the same side, that is the right side, along with an ill-defined soft tissue attenuating lesion in the region of medial canthus of right orbit, adjacent to the nasolacrimal duct, indenting the right globe from inferonasal side, with a likely infective or inflammatory etiology. So as we can see here in the right globe, so adjacent to the medial canthus, here was some mass that is indenting the globe from this side. So this was indentation from the inferonasal side, adjacent to the nasolacrimal duct. An ultrasound of the local area, this area was performed, and this was suggestive of diffuse subcutaneous thickening with intense vascularity in the preseptal region of the site, extending to the infraorbital compartment. Again, with a query of it being an infective or inflammatory lesion. So none of the investigations were actually coming to help. Following this, we performed a contrast-enhanced MRI brain with orbits. Now, this was suggestive of a large lobulated enhancing mass, in a heterogeneously enhancing mass in the subcutaneous tissue of the right maxillary region, which was infiltrating into the lower lid and further into the inferomedial extraconal compartment of the right eye, with a suspicion of neoplastic process with the query of rhabdomyosarcoma. So now to the diagnosis basket, one more differential was added, and that was of rhabdomyosarcoma in a child in which the swelling was not resolving despite broad spectrum antibiotics. No pus was there, and we got a heterogeneously enhancing mass which was compressing the globe from one side. And now we had a suspicion of it being either an infective lesion or inflammatory, and then contrast enhanced MRI came up with another DD that was rhabdomyosarcoma. So we can have a look at the MRI pictures of the child. If we come to these pictures, so this is the right side, and here we can see this mass was progressively increasing. So at the time of presentation, when we saw the child, it was there in the right upper and lower lid only, more so in the lower lid. But during the course, we saw it to be increasing, and it had increased to involve the maxillary region. It was involving mainly the subcutaneous region in the maxillary region. So we can see here, this involvement has increased up to this area on the right side. And if we come here on these sections, we can see here, it has come up to the jawline here. Now, because now there was, we had 3 DDs, we went for an incisional biopsy on day 7. And this was sent for histopathological examination and fungal culture. Now, the biopsy report was suggestive of fibrocollagenous tissue with infiltration by inflammatory cells. There was intense inflammatory response, inflammatory exudates, and fungal colonies with closest resemblance to mucormycosis. So we did get a frank diagnosis of mucormycosis. This was just a closest resemblance. Now, because there has to be a high index of suspicion for fungal infections, so we started the child, excuse me, on intravenous liposomal amphotericin B. The condition remained static initially, and a few days later, it again started to increase. So it further increased down the maxillary region and involved the upper lip on the same side. Now, once this had increased to this much level, now debulking had to be performed. The DDs in mind from till this time were, one was rhabdomyosarcoma, and second was fungal infection, mucormycosis. So debulking had to be done in any case, suspecting it to be a rhabdomyosarcoma. In that case also, if we perform debulking, that was going to reduce the dose of chemotherapy or radiotherapy that had to be given subsequently. And if it was fungal mucormycosis, as the biopsy was revealing the closest resemblance, in that case, this is one of the modalities, rather one of the key points that has to be done. Debulking surgical debridement is very important. So in collaboration with the maxillofacial surgeon from the institute, we did debulking in our ophthalmology OT. Meanwhile, antibiotics were also systemic antibiotics that were again added for super-added Pseudomonas infection. Despite debulking, the mass again continued to increase and it progressed with deviation of the nasal bridge to the left side, the other side. Now, after debulking, when this tissue was sent for examination, the findings of biopsy revealed a soft to firm gray-white mass with fibrocollagenous and muscular tissue that was infiltrated by inflammatory cells and colonies of fungus. Special stains like GMS, they revealed broad aseptate hyphae that was suggestive of mucormycosis with severe necrosis. So we can have a look at the gross appearance of the tissue. So this was from the maxillary region, and we removed multiple pieces with this appearance from this area, from the intraorbital compartment as well. So this was soft, creamish, white to creamish, firm to rubbery consistency mass. Now the GMS stain, you can see here, it revealed broad aseptate hyphae, ribbon-like broad aseptate hyphae branching at 45 to 90 degree or sometimes obtuse, at obtuse angles also. So here again, we can see there is a focus of necrosis with giant cell reaction. Now, once we had debrided, we had put a drain there. So at the time of suture removal from the site, we noted some pus at the site of drain. Now that pus was sent for culture sensitivity. The condition again remains static for many days after this debulking, but again there was increase, and this time it extended to the upper lip and forehead globular region. Now, because it had been quite some time that we had started in liposomal amphotericin B and the child was not responding much, so syrup posaconazole was also added in appropriate dose and followed by substitution with injection voriconazole. This was done in view of certain reports. There have been few reports of mucormycosis in immunocompetent patients, and these reports say that immunocompromised patients respond better to amphotericin B, whereas patients who are immunocompetent and have mucormycosis, they respond better to injection voriconazole. In view of that, this was substituted by injection voriconazole. Now, here we can see how it serially progressed. So initially the swelling was there only in the upper and lower lid, more in the lower lid. Then it further progressed to the maxillary region, then to the upper lip area, and then from here to the opposite side also, causing the deviation. And then the nose was also, nasal bridge was also deviated to other side. We can pay particular attention to the color of the skin. Initially, the color of the skin was, it was erythematous only. But with time, we can see here that the color was, it had little bit of erythema here, but here nowhere was there sign of any blackening. But with time, this child developed. So this was almost 1.5 months following the child presented for the first time that she developed this kind of skin discoloration. When we are seeing a patient of mucormycosis, at the first instance, we are usually expecting angioinvasion. Because of angioinvasion, we happen to find an eschar that is usually seen. But here, this discoloration was noted after almost 1.5 months following the initial presentation. Now, a dental examination was done. So they noted an erythematous area in the buccal mucosa of the right side. So this swelling kept on progressing. This time it involved the post-septal compartment of the orbit also. So some proptosis developed and that led to corneal exposure. So again, a debridement was planned and it was done. Now, this biopsy again revealed fibrocellular connective tissue with multiple granulomas, necrosis, and non-septate fungal hyphae. Now, this was the picture of the child following the second debridement. So, if we notice here, now the picture here is the child seems to be drowsy. This was because an imaging was planned, an MRI was planned, and for that the child was sedated. So that is why this look. So this is following the third debridement. So the child had developed some proptosis, and because of that there was corneal exposure. So we had put a moist chamber over there along with conservative management, and plus then followed by a debulking was there, and then it went to, so this is following debridement. When it has gone to its normal position, there is no proptosis seen at this point. Now, when the child was admitted during the hospital stay, the child developed many systemic co-infections, like urine culture revealed Acinetobacter species. Then a repeat urine culture was done that revealed Citrobacter. The blood cultures that was initially sterile when the child was admitted, that showed wet time Staph aureus. A repeat culture showed Acinetobacter. Now, for all these, the child had been on appropriate antibiotics time and again. So now, in this particular case, as we noted, rhino-orbitocerebral mucormycosis, we know it is usually seen in immunocompromised patients, in patients who have iron overload, and the usual path taken is there is first involvement of the paranasal sinuses. From there, there is involvement of the orbits, and through the orbits, there is involvement of the brain. The brain can directly be involved following infection of the paranasal sinuses also. But here, as we saw, though the child was malnourished, was little underweight, but apart from, like, she was advised high protein diet, and no specific thing was done by the pediatrics department. This much is okay, this will do. And even the HP that was 9 gram% at presentation, and it further dropped to 7 gram% during the course, and she had to receive certain blood transfusions also. So the child was anemic. So this was not a state of iron overload. The child was not immunocompromised. There was no history of trauma. There was no involvement of the paranasal sinuses from the very beginning. So this was something that started from the orbit, and so it gave us, like, one of the DDs was bacterial cellulitis. So it started from the orbit, but then slowly and progressively it involved the maxillary region, the subcutaneous region. Till date, the child has still been on follow-up with us, and there has been no involvement of the brain and the paranasal sinuses. So it has been primarily the orbital involvement along with the subcutaneous region of the maxillary area. So this is the usual path is paranasal sinuses to orbits to brain, and it is seen in immunocompromised patients, patients with iron overload. Isolated orbital and cutaneous involvement can occur, as we have seen in this child, and an immunocompetent host may also be affected. This child has no particular problem with the immune system. There was no immunocompromised state. So as for any other case, our management goals here, they remain high index of suspicion. Like here, we had imaging studies revealing something else. Our clinical diagnosis was something else. So this is something that may give, as we saw in this child, the particular the specific discoloration that develops because of the angioinvasion that developed so late. So from initial presentation till almost 1.5 months, we had a skin, the color skin that was only there was some erythema. That was a sign of inflammation. We didn't see any blackening. There was no involvement of the sinuses, and even the skin didn't show any blackening till 1.5 months following the affection. So a high index of suspicion is must. So even immunocompetent patients may be affected, and patients who are anemic also. So iron overload is not a necessary factor. So a high index of suspicion has always to be maintained to diagnose it early. Appropriate tests have to be done, and very important is timely antifungal agents along with surgical debridement of the tissue for tissue and life salvage. It has to be done. So suspicion, that is the key point. Even if the patient is immunocompetent and we don't see any risk factor, even then it should be suspected. Now, during the COVID era also, one special thing I'd like to mention. Now, during these COVID pandemic also, we have come across many patients of mucormycosis. Can't say what has been the exact cause behind that, but most of these patients had history of COVID occurring, and they were given methylprednisolone for that. But such a short thing like short course of methylprednisolone and that leading to development of mucormycosis in patients who are otherwise okay, otherwise who had no immunocompromised state, that still needs to be studied what were the exact causes. But yes, there has been a certain rise in cases of mucormycosis during this COVID pandemic. And this child also presented to us during the pandemic also, but there was no frank history of COVID in the child or in the child's, any of the child's family members. So the key points are high index of suspicion and timely antifungals with surgical debridement for tissue and life salvage. So suspicion in any patient, that is a must. So these are a few of the references. And thank you so much for your time, and any questions or suggestions or discussion, highly welcome.
Thank you very much, Dr. Yadav, for this informative session. And I would just like to ask if anyone or any of the participants has got any questions to ask from Dr. Yadav, please. Anyone? So if you would like to ask any question, you can drop it in chat box, please. And well, I have one question, please. What would be the most appropriate test you mentioned? So can you name a few which to determine mucormycosis, please?
Yeah. So as we have seen, biopsy is one thing that would tell us, because culture also we can't rely, because sometimes there can be mucor can be a contaminant also. So just getting mucor on culture can't be, we can't appropriately label it as having mucormycosis. So I think biopsy and this histopathological examination, that is the most important test.
More specific as compared to that. Right. Thank you very much for your time. Okay. Take care. Thank you.
Thank you.
So now we are going to invite and call upon our next speaker, Ms. Ayka Nur Demir from Turkey, to deliver her speech, please. Hi. Could you please come with it, please? Thank you.
Hello. Can you hear me?
Yes, please.
Okay. I can share my screen.
Perfect.
Can you see my screen?
Yes. Yes, we can see it now.
Okay. I'm starting. Hello, dear professors and dear friends. My name is Ayka Nur Demir. I'm from Turkey. I'm studying in Afyonkarahisar Health Sciences University, Faculty of Medicine, Genetic Department, 5th grade students. Today, I will tell you about coronavirus pathogenesis and treatment methods. During the presentation, I will first talk about the history of the coronavirus, briefly its molecular structure and pathogenesis. Next, I will touch on the COVID-19 disease, a coronavirus replicate and toxicity, its symptoms, and the laboratory techniques used. Then, I will talk about the current COVID-19 data, the measures taken in the world, and the latest vaccination studies, I will give information about a few important vaccines. Firstly, I will tell you about coronavirus history, effects, and pathogenesis. The reports of a coronavirus infection in animals occurred in the late 1920s when an acute respiratory infection of chickens emerged in North America. The virus was then known as infectious bronchitis virus. After human coronaviruses were discovered in the 1960s, using two different methods in the United Kingdom and the United States. Dr. Kendall, Dr. Bino, and Dr. Tyra, working at the Common Cold Unit of the British Medical Research Council, collect a unique common cold virus designed B814 in 1961. Then, Dr. Dorothy Hammer and John Prochnow discovered another virus in kidney tissue culture in 1962 and identified it as 229E. Scottish virologist Dr. June Almeida is at St. Thomas Hospital in London. Collaborating with Dr. Tyrrell, compared the structures of IBV, B814 and 229E in 1967. They using electron microscopy, the three viruses were shown to be phonologically related. A research group at the National Institute of Health the same year was able to isolate another member of this new group of viruses using organ culture and named one of the samples OC43. Like B814, 229E and IBV, the novel cold virus OC43 had distinctive club-like spikes when observed through microscope. Other human coronaviruses have since been identified, including SARS-CoV in 2003, HCoV 2003, HCoV HQ-U1 in 2004, MERS-CoV in 2013, and SARS-CoV-2 or other name COVID-19 in 2019. This picture is SARS-CoV-2. And now, coronavirus are enveloped viruses with a positive sense single-stranded RNA genome and a nucleocapsid of helical symmetry. The genome size of coronaviruses range from approximately 26 to 32 kilobases, one of the largest among RNA viruses. They have cup-shaped spikes that project from their surface, which in electron micrographs create an image reminiscent of the solar corona, from which their name derives. In humans and birds or other animals, they cause respiratory tract infections that can range from mild to lethal. Mild illnesses in humans include some cases of the common cold, also caused by other viruses, rhinoviruses, while more lethal varieties can cause SARS, MERS, and COVID-19. And now I want to tell you about COVID-19 disease definition, effects, and pathogenesis. So, coronavirus disease 2019, or other name COVID-19, started as an epidemic in Wuhan in 2019 and has since become in the world. Groups from China identified and sequenced the virus responsible for COVID-19, named SARS-CoV-2, and determined that it was a novel coronavirus that shared high sequence identity with bat and pangolin-derived SARS-like cause, suggesting a zoonotic origin in this disease. Coronavirus disease is caused by severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, a member of the human coronavirus family, the lower part of the neck, and causes severe acute respiratory syndrome, or SARS. Now, I want to talk about COVID-19 and coronavirus replication without going into too much detail. Where does the virus replicate? Following replication and subgenomic RNA synthesis, the viral structure proteins are translated and inserted into the endoplasmic reticulum in the cell. These proteins move along the secretory pathway into the array or to Golgi intermediate compartment. In infected cells, the co-RNA synthesing machinery associates with modified array membranes that are transformed into the viral replication organelle. Double membrane vesicles appear to be the central hub for viral RNA synthesis. In this picture, you can see the life cycle of the coronavirus and the replication it has undergone. Viral protein in the cell or endoplasmic go to endoplasmic reticulum to Golgi apparatus. Now, mechanisms of virus-induced toxicity. The virus or the coronavirus may be toxic during the first days. In biopsy or autopsy studies, pulmonary pathology for COVID-19, patients show diffuse alveolar damage with the formation of healing membranes, mononuclear cells, and macrophage infiltrating airspace or other cells, and a diffuse thickening of the alveolar wall. The lungs from patients with COVID-19 also showed severe endothelial injury associated with the presence of intracellular virus and disrupted cell membrane. Viral particles were observed in the epithelial cells by electron microscopy, suggesting that these lesions might be partly caused by a direct cytotoxicity. Now, where we look symptoms of COVID-19. COVID-19 caused by a member of the coronaviruses shares common symptoms with other coronavirus infections and other viruses infections. The major symptoms of these diseases include fever, dry cough, fatigue, and mostly appear after approximately 5 or 6 days after contracting the disease. It has been reported that raunch or rough breathing sounds, as well as coughing fever coming from the lungs. Actually, patients' lungs are the main symptoms of severe COVID-19. Phlegm production, headache, fever, hemoptysis, diarrhea, dyspnea, and lymphocytopenia could also be observed. Then, it has been reported diarrhea to be a major gastrointestinal symptom developed in COVID-19 patients. However, fluctuations in the incidence of gastrointestinal symptoms have also been recorded. Development of various diagnostic methods to detect the virus transmitted through several means is urgently required to minimize the viral transmission. Also, a comprehensive epidemiological investigation together with modern diagnostic methods could help in the early detection of asymptomatic carriers. Now, diagnostic tools for COVID-19. What is the diagnostic tools? Methods for the detection of viral nucleic acid, natural samples tested, and serologic testing. These tests are nucleic acid, serological, antigen, and ancillary tests, all of which play distinct roles in hospital or large-scale population testing. Firstly, methods for the detection of viral nucleic acid. PCR tests for SARS-CoV-2 have been available since January 2020. RT-qPCR-based assays performed on respiratory specimens has emerged as the cornerstone of COVID-19 diagnostic testing. The USA Centers for Disease Control and Prevention has developed a widely used SARS-CoV-2 RT-qPCR. The kit contains PCR primary probe sets for 2 regions of the viral nucleocapsid gene, N1 and N2, and for the human RNase P gene to ensure the RNA extraction was successful, to avoid potential cross-reaction with other endemic hosts, as well as potential genetic drift, as leads to molecular targets should be included in the assay. Theoretical specificity of most RT-qPCR assays is 100%. Why this method's 100%? Because the primary design is specific to the SARS-CoV-2 genome. Occasional false positive results may occur due to technological errors or rigid contamination. A rigorous assessment of the diagnostic accuracy of the manually introduced SARS-CoV-2 assays is hampered. The sensitivity of viral RNA testing varies with timing of testing relative to exposure. A false positive result erroneously labels a person infected with consequences including unnecessary quarantine and contact tracing. False negative results are more consequential because infected persons may not be isolated and can infect other persons. Second, nature of samples tested. The current diagnostic strategy to identify patients with COVID-19 is to test samples taken from the respiratory tract to assess for the presence of SARS-CoV-2 specific nucleic acid targets. An nasopharyngeal specimen is the preferred choice for testing, but oropharyngeal, mid-turbinate, or anterior nail samples are also acceptable. A pharyngeal virus shedding was shown to be very high during the first week of symptoms, or 10 or 14 days during the first symptoms. The viral load in nasopharyngeal samples peaks between the first few days after symptom onset before declining. For nasopharyngeal specimen, samples should be obtained by using float swab to enhance the collection and release of cellular material. Samples taken from sputum and tracheal aspirates and bronchoalveolar may have greater sensitivity to upper respiratory tract specimens. In a decayed sample collection may result in a false negative test. Bronchoalveolar lavage, whose specimens had the highest positive rates of SARS-CoV-2 RT-qPCR assay. A single nasopharyngeal swab has become the preferred swab as it is well tolerated and safe. Saliva may also be an alternative specimen source that requires less personal protective equipment and fewer swabs, but requires further validation. And third, serologic testing. Serologic immunoassays have repeatedly emerged. Serologic tests that identify antibodies to SARS-CoV-2 from clinical specimens may be less complex than molecular tests. As antibody responses to infection take days to weeks to be reliably detected, their utility for diagnosing acute infection is limited. Serologic assays might be more relevant if serving for asymptomatic infection or scenarios in which patients present to medical care with late complication of disease, when RT-qPCR may be falsely negative. Negative result will not exclude COVID-19 infection, particularly among those with recent exposure to the virus. The viral spike protein is perceived as the clear candidate for inclusion in an immunoassay that detects whether antibodies are present. And now, the other protein that appears to be important antigen for the development of serological assays is the N protein, or structural component of the nucleocapsid. Indeed, antibodies to the protein are frequently detected in COVID-19 patients, suggesting that M protein may be one of the immunodominant antigens in the early diagnosis of COVID-19. Actually, it is now established that SARS-CoV-2 pre-existing immune reactivity can exist in the general population. Serum samples from patients with COVID-19 showed some cross-reactivity for the SARS-CoV-1 nucleocapsid and antigens. A recent study detected SARS-CoV-2 reactive CD4 plus T cells in 50% unexposed individuals, suggesting cross-reactive T cell recognition between circulating or common cold coronaviruses and SARS-CoV-2. Where we look as we continue to examine serological tests, we see that ELISA and CLI are common laboratory applications that can measure antibody titers. A variation of these tests can use magnetic protein-coated microparticles known as a microparticle immunoassay. Being able to quantify antibodies built for identifying convalescent plasma donors with titers and studying how the immune system responds to the virus. Neutralizing antibodies play important roles in the virus clearance and have been considered as a key immune product for protection or treatment against viral disease. In COVID-19, transfusion of convalescent plasma or serum from recovered patients was also considered as a promising therapy. The last slide for serologic testing. Apart from this test, neutralization test is also used. The neutralization assay is a laboratory-based that uses virus and cell culture methods to determine if patient antibodies can prevent viral infection in vitro. Because immunofluorescence assay is a labor-intensive method, a substantial number of the new commercial COVID-19 antibody tests developed as screening tests are not ELISA-based. They are lateral flow immunoassays, or LFEIE, which provide no quantitative information. These qualitative LFEIE represent typically small, portable rapid diagnostic tests, or RDT, and can be used at point of care. Now, I want to tell you about recent situations and number of cases of COVID-19 every day in the world. When we look at the number of cases for COVID-19, the total number of cases exists 100 million, while the number of people who recovered approached 80 million, but the number of those who lost their lives exists 2 million. And these data continue to be updated every day. When we look at the latest cases, the country that is currently the first in the number of cases is the USA. After that, India and Brazil come in order. Now, this topic is important for me and for other people. Measures taken for COVID-19 in the world. With the spread of COVID-19 around the world, countries resort to measures to prevent the epidemic, from closing their borders to stopping international flights, from domestic transportation restriction to curfews. European countries, especially when the epidemic increased in Europe, took drastic measures. As a result of the measures, people were prohibited from going out except for basic needs. The necessary police barricades were set up. Governments have tried to alleviate the burden of the pandemic on the economy, support for employees and business. Border closures, travel and transport restrictions, and curfews have grouped countries in daily life and business activities. Under these conditions, public authorities took supportive measures for employees and business to eliminate the negative effects of the epidemic on the economy and the world. Now, this topic is for me and for health workers. With the increase in the number of cases in the countries affected by the epidemic, there was a great burden on health systems, and there were problems in the stocks of sanitary materials, drugs, and medical equipment. Problems were incurred in the prospect of the most basic protective materials, such as masks and gloves, as well as in testing and treatment services. Since the beginning of the epidemic, in the mask stock in my country, Turkey, was not a problem. Training continued all over the world through in the online system for a year. Now, Russian studies for COVID-19. Normally, vaccines can be applied to quite difficult and long stage in the past. However, the COVID-19 outbreak is a different process, and it is seen that the clinical research part is switched in a few months. One of the most important reasons for this is that there are priori studies on SARS and MERS which are members of the coronavirus family. Now, I want to a few version about information. This is Moderna. This vaccine developed in the United States uses the genetic material of the virus, unlike previous other vaccines. According to the intermediate results of phase 3 studies published in November 2020, the candidate vaccine is more than 94% effective. Then BioNTech Pfizer, as a result of the phase 1 and 2 trials initiated in May, it was observed that the vaccine produced antibodies. According to the statement made by Pfizer on November 9, it was announced that the candidate vaccine was more than 19% effective. AstraZeneca British Oxford University, AstraZeneca's 1 and 2, as a result of the past studies, vaccine developers did not detect any serious side effects. Global trials of the vaccine were stopped on September 6 as the inflammation developed in one volunteer. So, on September 12, it was decided to continue trials partly. According to the research result published on November 23 in 2020, the candidate vaccine has developed 70% protection against coronavirus. Then CoronaVac, it is a potential COVID-19 vaccine by the Chinese pharmaceutical company Sinovac. It can be stored in the refrigerator between 2 and 8 degrees. Turkey has received approval to use emergency vaccination in Brazil and Indonesia. The vaccine is a chemically inactivated whole virus vaccine for COVID-19. Sputnik 5, for Russia, on August 11, yet 3rd, announced that it has approved a new coronavirus vaccine, which has now started fast trials. Sputnik 5 phases 1 and 2 were completed on 1 August. It has been said the current clinical trials show that not a single participant was infected with COVID-19 after the vaccine was administered. Phase 3 studies are ongoing. Was 92% effective against COVID-19. And other vaccines, Imperial College London and Angus Oxford University. Imperial College London, researchers developed a self-replicated RNA vaccine to stimulate the immune system. Researchers expect to find out if the vaccine is effective by the end of the year. In animal experiments, vaccine is safe and produces an effective immune response. Also, Angus and Takarabio, phase 1 and 2 trials of the DNA-based vaccine continue together. Candidate vaccine has been tested on volunteers since August. And now results. In brief, COVID-19 is a serious respiratory disease. Drug treatments were also applied before vaccination studies. However, the common view of scientists has been that a solution to this pandemic can be found with the vaccine. For this reason, vaccination studies have yielded faster results than in the past, and promising results have emerged within a year. A new mutated virus is now spreading, but it has been reported that the effectiveness of vaccines is also valid for AIDS. All over the world, until vaccination is complete, we must maintain the necessary distance, wear a mask, and stay away from closed and crowded environments when necessary. This is my references. Thank you very much. And I would like to thank the Congress team for their assistance. And in addition, the public of Turkey's founder, Mustafa Kemal Atatürk, I offer my eternal gratitude. Thanks to him, we are advancing and developing. Thank you very much for listening to me.
Thank you very much, Ms. Aykan Nur Demir, for such an informative presentation, and it has, opened our eyes about new symptoms that you have explained. So, has anyone got any questions? Thank you. Any questions, please? So, well, I would like to ask you one question. Is there any possibility that this virus is affecting the respiratory centers in the brain also? Is there any effect of this virus on the respiratory centers in the brain, the control centers?
Yes. I read I read about COVID-19 in the brain center, and but I'm researching about. I have not more information about this brain center.
That's great. Thank you for letting us know. So now I'm going to invite our next speaker, Dr. Sudipta Naskar from India, to deliver his speech, please. Dr. Sudipta Naskar. Thank you.
Hello, am I audible?
Yes, please. Yes, we can hear you.
Okay.
Please share your screen with us and your presentation.
Okay, is it visible?
Yes, please.
Okay. Okay. So very good afternoon, everyone, and good evening from India. Pardon. I'd like to thank UCG for this great opportunity and for arranging this digital conference and providing a wonderful platform during this COVID pandemic. So now, I'll present our work entitled A Comparison of Nuclear and Cytoplasmic Immunoexpression of P16 in Breast Neoplasm. So a brief review of P16. So P16 is a protein molecule having 4 ankyrin repeats and also called helix-turn helix repeats. And so this is the principal protein of INK4 family, and it contributes to regulation of cell cycle progression by inhibition of S phase, and it binds to cyclin-dependent kinase 4 or cyclin-dependent kinase 6, and it inhibits the complex formation, that complex cyclin D CDK4/6 complex, and thus inhibits cell cycle progression. It is considered as a surrogate marker for human papillomavirus infection and also considered as a marker of cellular senescence. So this is a very beautiful diagram from a wonderful review article by Romagosa et al. So here you can see P16 and P14 both are synthesized from a common locus INK4A ARF. So from ARF P14 is synthesized, and from INK4A P16 is synthesized. So here we can see that retinoblastoma protein, it is attached to E2F molecule, and whenever this cyclin dependent kinase 4, this cyclin D1, it binds to cyclin dependent kinase 4, then this complex activates phosphorylates this retinoblastoma protein, and this phosphorylation subsequently helps releasing this E2F molecule, and this E2F molecule is the key for the progression of G1 to S phase. So whenever this CDK4, this P16 is bound to CDK4, this complex formation cannot occur, and so there is E2F is then E2F is bound to a retinoblastoma protein, and the cell is arrested at G1 phase. So there is no G1 to S progression. So in that way, P16 acts as a inhibitor of cell cycle. So regulation of P16 expression. P16 is regulated by 2 E-box elements present at the promoter region. So talking about the promoter region, so currently many research activities are going on this alteration of this promoter region in many tumors. So P16 mRNA expression is positively regulated by ETS1 and ETS2 binding at that promoter region. Post-transcriptionally, P16 mRNA synthesis is mostly regulated by the elements located at P16 promoter region. For example, this protein like BMIL CBX7, this when this bounds to promoter region, there is histone changes, and this subsequently leads to down regulation of P16 gene expression. So this in this picture, so this is the locus for P16 and P14. So this is the downstream of P16 gene. So in downstream, as I told, there are many regions where these molecules binds, and this leads to either down regulation or overexpression of P16 gene expression. This plus signs denotes they helps to overexpress the P16, and this negative signs this denotes down regulation of P16 gene expression. So many tumors gain immortality by targeting this P16 retinoblastoma pathway. For example, in benign neoplasm like melanocytic nevi or benign nerve sheath tumor, there is overexpression of P16 protein. So this leads to arrest those tumor cells at G0 phase, and subsequently those tumor cells undergo senescence, and there is no further malignant transformation. Whereas in their counterpart, like melanoma and malignant peripheral nerve sheath tumor, we observe that there is these tumors cells are immunohistochemically negative for P16. So, but there are many other tumors like neuroblastoma, ovarian carcinoma, breast carcinoma, prostatic carcinoma, and esophageal SCC. So there we can see that P16 is actually overexpressed, and this also denotes the poor prognosis. So this become more complicated, that in spite of being a cell cycle inhibitor in malignant tumors like this, P16 become overexpressed. So there there is some hypothesis that in those tumors there is other defect in other pathway. Like if there is defect in retinoblast mutation of, for example, if there is defect in this retinoblastoma protein or retinoblastoma mutated, so there will be less retinoblastoma protein, and this subsequently give a negative feedback to release more P16. So this is one hypothesis which is responsible for overexpression of P16 in those malignant conditions. So, okay. So initially the cytoplasmic localization of P16 by immunohistochemistry, it was considered as artifactual, but subsequently their studies have been done, and now it is considered not as artifactual. So being a cell cycle regulatory protein, the main site of action of P16 is inside the nucleus, where it binds with cyclin-dependent kinase 4 and stop the progress from G1 to S phase. So after translation and post-translational modifications, P16 protein is transported inside the nucleus by a nuclear transport system, but this transportation can be hindered by interaction with other molecules present in the cytoplasm. So this leads to macromolecule formation and subsequently leads to intracytoplasmic accumulation of P16. So in this study, this done by Mendez et al., they have showed that there are 16 cytoplasmic interactors present in this for P16 in cytoplasm. I have mentioned a few like CDK4, type 1 angiotensin 2 receptor associated protein ACAP8, THO complex subunit 4, polyadenylate binding protein 2, ATP dependent RNA helicase DDX24. So we were inspired by this study done by Hu et al. So they showed that aberrant expression of P16, that is expression of P16 in cytoplasm, that is responsible for in some ways that is responsible for malignant transformation of pleomorphic adenoma, that is carcinoma x pleomorphic adenoma. So, and only one comparative study was done on intracellular localization of P16 in carcinoma and fibroadenoma cases, and on Indian population, no such studies have been done till now before our study. So this study was done at Department of Pathology and Department of Surgery of UCMS and GTB Hospital, Delhi. And time frame was from November 2008 to April 2020. We took total 64 cases who underwent either lumpectomy or modified radical mastectomy or simple mastectomy. And this consists of 30 cases of carcinoma and 30 cases of fibroadenoma and 4 benign phyllodes cases. And we divide these fibroadenoma and carcinoma cases into three subgroups. Each subgroups consists 10 cases. So 10, 10, 10. So fibroadenoma cases, we divided in less than 25 years, 25 to 30 years, and more than 35 years, more than 30 years. And carcinoma cases, we divided less than equals to 35 years, 36 to 50 years, and more than 50 years. We did this to avoid this age bias. So we use P16 monoclonal mouse monoclonal antibody from Thermo Fisher Scientific. This 5A8A4 clone was used, and for positive control, we used known P16 positive uterine cervical carcinoma cases, as well as the normal breast TDLUs, which were present at the advancing front of our carcinoma cases. So standard immunohistochemistry protocol was followed. And for P16, antigen retrieval was done using a citrate buffer of pH 6 at 95 degrees Celsius in an electric pressure cooker. And after after peroxidase blocking, we incubated overnight at 1:200 dilution. And excuse me. And on next day, we used a detection kit to detect that antibody antigen reaction. For hormone receptors, ERPR and HER2, we use the same protocol, but for antigen retrieval, we use TRI-CDTA at pH 9, and for SP1 clone for ER, SP2 clone for PR, SP3 clone for HER2 was used. All were rabbit monoclonal antibody and pre-diluted from Thermo Fisher. All cases were histologically confirmed, and clinicopathological data were recorded from histological forms, and each case was evaluated for staining intensity and percentage of tumor cells showing positivity. So we adopted this scoring system from this article cited later. So for intensity, we scored 1, 0 to 3, negative, weak, moderate, and intense. And we give score of 0 if less than 1% or no cell showed P16 positivity. We scored 1 if 1 to 10% cells showed positivity, or 2 for 10, 11 to 50%, 3 for 51 to 90%, and if more than cells are showing P16 positivity, then we gave a score of 4. Then we multiplied this percentage of positivity to this intensity, and score ranging from 0 to 12 were obtained. And this score 6, 9, 8, and 12, this were considered as strong expression. 3 and 4 were considered as moderate expression, 1 and 2 as weak, and 0 negative. So now I'll show some picture of P16 expression in our cases. So this green arrow indicates that advancing front of the tumor, and this is the tumor part, and this red arrow indicates that normal TDLUs present at the advancing front. So this is the high power view of that red arrow area. So you can see this normal TDLU cells also showing moderate to strong P16 nuclear positivity. And this is from that high power view of that green arrow pointed area. And here we can see that nucleus, the tumor cells showing nuclear positivity. We scored it as a score of 4, that is 2 into 2. And there is no such cytoplasmic P16 positivity. And this is another case at advancing front. Here we can see a nerve bundle. This red arrow pointing to the nucleus of normal Schwann cells, and this is also showing a moderate P16 positivity, whereas this tumor part is showing a weak P16 positivity. This is a grade 1 invasive ductal carcinoma, which is showing moderate, strong nuclear P16 expression as well as moderate cytoplasmic P16 expression. This is also a grade 1 invasive ductal carcinoma, which we can see that it's showing strong nuclear cytoplasm, nuclear P16 positivity as well as weak to moderate P16 expression in the cytoplasm. This is a case of grade 2 invasive ductal carcinoma, where we can see it's showing strong nuclear positivity along with moderate to weak cytoplasmic P16 expression. This is a grade 3 invasive ductal carcinoma, invasive ductal carcinoma with medullary-like features. So where you can see it's also showing a strong nuclear P16 expression along with very nice cytoplasmic P16 expression. This was an interesting case of coexisting carcinoma and fibroadenoma at the advancing age, pointed by red arrow. So both were showing a strong P16 expression. And in this case, there were no cytoplasmic P16 expression, and nucleus P16 expression was strong in both carcinoma and fibroadenoma part. So this is a fibroadenoma with moderate P16 expression. We scored it as 4. And this is one case which is also showing apocrine changes pointed by green arrow. So interestingly, we found that in the apocrine change area, there was P16 expression was decreased in comparison to normal, in comparison to classical fibroadenoma part, which showed strong P16 nuclear P16 expression. And you can also see that here the stromal cells are also showing nuclear P16 expression. So this is one case which showing strong P16 expression in both epithelial and stromal component. We scored it as 6. This is another case. We scored it as 9. We showed is showing also stromal as well as epithelial P16 expression. And this is another case. We scored it as 12, and it's also showing strong P16 expression both in epithelial and stromal component, but not cytoplasmic P16 expression. So these are 2 cases from phyllodes. Here we can see that almost 50% cells showing P16 expression and 50% cells are not showing P16 expression. So we scored it as 4. And here we can see weak P16 expression. We scored it as 2. And epithelial component, there is strong P16 expression here in the epithelial component and moderate P16 expression here at epithelial component. Okay, so for carcinoma cases, as there is unavailability of a few immunohistochemical markers, so we simplified this molecular classification. So hormone receptor positive cases were considered as luminal, hormone receptors negative and HER2 3+ cases were considered HER2 enriched, hormone receptors negative and HER2 0 or 1 were considered as triple negative. So this is the clinico-pathological data of invasive carcinoma cases. Here we can see we had 15 cases of grade 2 and 11 cases of grade 3 carcinomas. And most of the carcinoma were invasive ductal carcinoma, no special type. And we had one carcinoma with medullary-like feature and one tubulolobular carcinoma. And among them, 8 were triple negative, 14 were luminal subtype, and 8 were HER2 enriched. In this image, we can in this graph we can see that most of the triple negative cases marked by this triangle, red triangle, were below or equals to 45 years of age. Okay, so here we can see 4 of the luminal cases were completely P16 negative. 4 of the cases were carcinoma cases completely P16 negative. For nuclear, they didn't show any nuclear P16 expression, and all of them were luminal subtype. Among triple negative carcinoma cases, 7 showed a strong nuclear P16 expression, and 6 also among them 6 also showed cytoplasmic P16 expression as well. In patients with less than equals to 35 years age, we can see 6 showed strong nuclear P16 expression, and also 8 also showed cytoplasmic P16 expression also. So in fibroadenoma cases, where there 12 showed weak P16 expression, and 5 showed moderate P16 expression, and 13 showed strong P16 expression. And when you compare P16 expression in epithelial component with stromal component, we can see that among the cases which showed strong P16 expression in epithelial component, there among them 8 also showed strong P16 expression in stromal component also. Okay, now coming to the size of the tumor. So size of the fibroadenoma. So the fibroadenoma cases which were less than 3 centimeter in greatest dimension, among them 9 showed strong stromal nuclear positivity, and 9 also showed strong nuclear P16 positivity in epithelial component. When coming to comparison of between carcinoma and fibroadenoma cases, we can see that only 11 cases of the carcinoma showed 11 cases of carcinoma showed cytoplasmic P16 expression, whereas only 2 cases of fibroadenoma had cytoplasmic P16 expression. And among the Phyllodes cases, all showed either weak or moderate stromal P16 expression, and in epithelial component, they showed strong 3 showed strong P16 expression, and 4 showed weak P16 expression. So so there is a considerable difference in opinion of localization of P16, that whether cytoplasmic localization will be considered positive in tumor or nuclear, or both cytoplasmic in nuclear. In cervical carcinoma, uterine carcinoma uterine cervix, we can see that both cytoplasmic and nuclear are considered positive, but there are no such data available for breast carcinoma cases. So in our study, we can see that all the carcinoma cases with weak to moderate and to strong cytoplasmic expression of P16 also had strong to moderate nuclear P16 immunopositivity, but none of the cases showed only cytoplasmic P16 expression. That cytoplasmic immuno expression in all of the cases were accompanied by nuclear P16 expression. And for fibroadenoma cases, the P16 was restricted mostly to the nucleus, apart from those 2 cases which also showed cytoplasmic expression. So based on our study, it can be said that P16 acts as a tumor suppressor gene in benign neoplasm like fibroadenoma. And this is also supported by another finding, that the fibroadenoma cases which had a size of less than 3 centimeters showed strong nuclear P16 positivity. That means it helps to restrict the size of the tumor, and that also denotes that P16 helps in cellular senescence. And in carcinoma cases, there may be some cytoplasmic interactors which prevents the translocation of the P16 into the nucleus, and thus not able to suppress the malignancy. So as I've told before that once this study done by Mendez et al, they have shown that there are 16 cytoplasmic interactors present of P16 present in cytoplasm. So, but in spite of this, a considerable amount of P16 still escape to the nucleus, and this results in both nuclear and cytoplasmic P16 expression. In among 10 out of 16 hormone receptor negative cases, we showed this both nuclear and cytoplasmic P16 expression. That means in those triple negative cases, those cytoplasmic interactors are increased in and thus they have both thus they showed both nuclear and cytoplasmic P16 expression. So our study of few limitations, like their sample size was less, and we took only 4 fiber phyllodes cases. The study could have been better if we could have been taken that equal number of cases, like 30 cases of both fibroadenoma, carcinoma, and phyllodes cases. And there were unavailability of immunohistochemical markers like Ki67, EGFR, CK56, GETA3, basically the basal markers, and markers involved in retinoblastoma pathway like P53 retinoblastoma, and there was a lack of coordination with gene expression profile. So in a study I've cited later, they showed that recently a novel suicide gene therapy, which in animal models, which against which shows success in animal models, which is targeted against P16 higher P16 expression, and future studies on cytoplasmic interactors on P16 in base neoplasm would provide new insights. So these are 2 studies done by Kohli et al. And Lee et al., which I have mentioned. They have tried animal therapy against tumors of higher P16 expression in animal, in animal models. Thank you. Any questions?
Thank you very much, Dr. Sudipta Naskar, for sharing this valuable information with us and explaining it in detail. So, has any one of the participants got any questions, please? So I have one question. You mentioned about gene therapy. Can you explain or mention how it could be possible to treat the adenomas by using the gene therapy?
Actually, the study they have done on animal models. So the tumors which overexpressing P16.
Yeah.
So they what they did, this inhibits the P16 is a tumor suppressor gene. So they tried to overexpress the P16 in that model. So this P16 can subsequently can lead to cellular senescence and subsequently suppress the tumor growth.
All right, great. Thank you very much for the information. So now I am going to invite our next speaker, our keynote speaker, Dr. Michael Retzky from USA, to deliver his keynote speech, please. Thank you. Hi. We cannot hear you, please. Would you unmute in your settings, please? Still, I'm afraid we cannot hear you. If you could just click on the top right side on the view, and if the option of unmute is shown, please, or any red mic If you could see, just click that for unmute, please.
Unmute?
Yes.
Am I unmuted?
Yes, now you are audible. Thank you.
Sorry for the delay.
No worries, please. So at the bottom, would you like to share your screen with us? There is green arrowhead with some share screen option at the bottom.
Yes, okay, share screen.
Perfect.
Now I open up this
Thank you.
and slideshow. Start from the beginning. Okay, is that all right?
We
Can
are
you see
still
the screen?
unable to see your presentation.
You cannot see this presentation?
Now, unfortunately, we cannot see. If you could just click share screen, please, at the bottom, and then open your presentation on your desktop, please.
Sorry, I can't seem to get to that bottom of the screen. I don't see a bottom of the screen.
If you could just click.
If you just move your mouse arrow over your image, then the bottom line will appear. Maybe you can try that. You need to move and then
nothing's appearing down there. Sorry.
Oh.
If you could just move your cursor on your screen, so it will show up. If you could move them with the mouse, the cursor on your screen. So in the
I hear what you're saying, but it's not working. All I have is my presentation on my screen.
Great. Now we are able to see it. Perfect.
You can. Okay.
Thank you.
Okay.
Yes, perfect.
All right. Thanks. Sorry for the problems. Thanks for inviting me to this conference. I must warn you before we start that what I'm going to be discussing is going to sound wrong because it's not what is usually taught as cancer. We're presenting a revolutionary new view of cancer. So be skeptical, but pay attention. And I would expect questions at the end. A question like, I just don't understand what you're talking about. I'd be happy to go over certain things. Okay, I was at Harvard School of Public Health until last week, and our laboratory was closed down, so I resigned. I'm now looking for a new place to call home. Okay, this project was funded by NIH and Komen Foundation. What I'm going to be discussing is covered in very much level by two recent papers. I published these papers at the end of 2020. One of them is the major paper, Breast Cancer and the Black Swan. My co-authors, Ronald Demicheli from Milan, Bill Rashevsky, a medical oncologist, US, Ted James, a surgeon in Harvard, Rick Rogers, a scientist, Michael Baum, a retired breast surgeon, Jayant Vieta, a breast surgeon, Osaro Erhabor, he is a contact of mine in Nigeria. He is professor of laboratory science. Patrice Forget is an anesthesiologist, and he is in Scotland. Both these papers are available online. I'll go through this first one in the beginning. Okay, I edited a book on this subject that was published by Springer Nature, and I happened to very surprisingly see that it was posted on the front page of the New York Times a few months ago, just after the US election. This was the paper, and that's Michael Retzky and Romano Demicheli. So the topic is perioperative inflammation as a triggering origin of metastases. This project has been going on for a very long time. I can tell you when it started. It started in 1993. I was attending a breast cancer conference in Europe. I forgot what city it was. And out in the hallway, I saw a poster presented by Romano Demicheli of Milan. And this caught my eye because it showed a bimodal relapse pattern. There was an early relapse pattern. Well, I'll go through it in extensive detail, and then I walked into the regular lecture hall, and Michael Baum was speaking about a bimodal relapse pattern in data from UK. Well, the three of us got together afterwards and decided that they were both talking about the same thing. The Milan data are by far superior, and I will spend a lot of time on the Milan data. 1,173 early stage breast cancer patients with long-term follow-up. Just a second, please. And there was a sharp peak in relapse at about 18 months, a minimum at about 4 years. And then it started again with a broad, shallow peak at 60 or 70 months with a long tail extending to over 10 years. This general pattern has now been identified in 21 databases from US, Europe, and Asia. There are more than 21, but I stopped counting at 21. Okay, these are the Milan data presented in relapse hazard. Relapse hazard is the probability of a patient entering a period of time relapse-free and undergoing a relapse in this 3-month window. So if it's a 0.02, that means that 2% of the patients who were disease-free entered that particular window of time and had underwent a relapse. So what you see here is there's a sharp peak in relapses at about 18 months. And then there's a minimum about 48 months. And then there's a shallow peak after that, 60 or 70 months. It goes on to over 10 years. There is this subtle bump here about 100 months. We're not sure what that is. It could be important, or it could be noise. Okay, these are the same data, but for premenopausal patients. And the only difference here is that you can see structure in that first peak. Instead of one peak at 18 months, there's a peak at about 10 months and another one at about 30 months. And you still see, excuse me, that later peak and the bump out here at 100 months. These are data from Milan presented in New England Journal. Bonadonna, who was deceased, he was the clinician, and he's been working for 30 years on developing chemotherapy protocols for breast cancer. He was the first one to use multiple drug chemotherapy in breast cancer. And Panuccia Valagusa has been the database manager since this project started. I have a lot of experience with breast cancer databases, and I really trust these data. And much of that is due to the presence of the Panuccia Valagusa. So what you see here is there is a sharp peak, sharp decrease in relapse in the first 5 years, and it seems to reach a plateau. And then it starts up again 6, 7 years. It's not an artifact that corresponds to the double peaks. Excuse me. Okay, Demicheli and I decided to collaborate. I have an unusual background. My education is, I have a PhD in experimental physics, and I made a career change into cancer research in about 1982. My skills are, I know a lot about cancer, and I'm very good with calculating. I'm particularly handy at doing computer simulation of breast cancer data. So the idea was I was going to take the Milan database, the Bonadonna Valagusa database, and use a growth model that Demicheli proposed. Demicheli is an MD, PhD. He did a lot of work studying animal model growth. And he said the simplest growth model he can imagine was that cancer starts off as a single malignant cell, can stay at a dormant state for a variable time, and once it starts to divide, it can get to the size of a 1 millimeter or 1 million cells and stay dormant at that time until angiogenesis occurs, and then it can grow to be a detectable lesion or a lethal lesion. So this model is pretty much accepted now, but in 1997 was probably not well accepted. So
excuse my interruption.
Yes.
We are moving the slides for you. So could you just say very old school next slide? This would be cool.
Next slide.
Thank you very much.
Next slide, please. You're moving the slides, or should I move the slides? Hello?
Your slides will be moved. Just say so you can do it on your computer parallel, but we move the slides in the presentation for everyone.
Okay, good. Okay, this is the result of that computer simulation. I took the Milan data and Demicheli's growth model and tried to understand what these various peaks were. For example, this peak at 10 months after surgery corresponds to avascular micrometastases that were induced into angiogenesis at or about the time of surgery and showed up as relapses at 10 months. The 30-month peak were single cells that were dormant, they were not dividing, and something happened at the time of surgery to induce them to start dividing, and they underwent angiogenesis stochastically. This peak at 70 months, that's pretty much where you first to see the benefit of surgery to reduce metastases relapse. So all these events are not synchronized with surgery, but the ones from 48 months and earlier are synchronized with surgery. Those are iatrogenic. Something about the surgical intervention caused those first peaks. Okay, I'm a physicist, and physics is a quantitative science. Every chance I get, I will report information in quantitative level. You'll see that throughout the entire paper here. Okay, that 10-month peak, avascular micrometastases were induced to vascularize. That's mostly prominent for premenopausal node-positive patients. 20% of premenopausal node-positive patients undergo that relapse mode. It's 5 to 1 node positive to node negative, and 2 to 1 premenopausal compared to postmenopausal. The 30-month peak, previously inactive single cells that were induced into division and then stochastically vascularized. The combination of those first two relapse events are 50 to 80% of all relapses. Now remember, these are patients who were not given any therapy, just surgery only. That late peak after 50 months is more or less the natural history of breast cancer. And the benefit of surgery to reduce metastases first appears at 5 or 6 years. Okay, this is another database from Bernie Fisher. Fisher died at age 100 a year or so ago. He was professor at University of Pittsburgh, a very well-known person in the world of breast cancer. And I saw this figure and I said, this is exactly what I was seeing in the Milan data. Let me show you what I mean. These are patients treated only with surgery, and they're grouped by the number of nodes positive. 0 nodes on the top and more than 12 nodes on the bottom. Let's look at the 0 node population. First of all, surgery alone cures 80% of the patients. Of the 20% that relapse, 10% of them relapse in the first 3 years, and then there's a period with few relapses, and then after 60 months, they start to relapse again at a less strong rate, not as fast as the early ones. And So you get 10% of the relapses in the first 10 months, first 36 months, and then after that, the other 10% of the relapses. Now, looking at the more than 12 nodes positive, it's much the same as a 0 node pod in terms of the timing, but the quantity of the event, the magnitude of the event is much stronger. For example, all the patients relapse after surgery for patients with more than 12 nodes. The horrible prognosis, but of the 100% that relapse, 80 or 90 of them relapse in the first 3 years. It's pretty much about the same time as the 0 node population. So the timing here is the same. And then it's a period with few relapses, and then it starts up again. Pretty much the same thing as a 0 node population. So what we're thinking here is that nodes positive is an indication of the probability of a patient undergoing a surgery-induced tumor growth at a very high level, and it shows up in the first 3 years. This would say that 90% of the patients undergo this early relapse for more than 12 nodes, and 10% of the patients with 0 nodes undergo that early relapse. Went backwards there. Okay, I've looked at a lot of cancers, and I can find bimodal relapse patterns in all other cancers. I've looked at a lot of them, and these are either case reports or large databases, pancreatic, melanoma, lung cancer, on and on. I don't think there's any cancer that I have not seen a bimodal relapse pattern if you look carefully. Okay, this effect is so large, it should show up if we look at it from certain clinical observations. And I'm going to describe 4 situations here where it's highly probable that we can explain clinical events by what I just talked about before. First of all, adjuvant chemotherapy works particularly well for premenopausal node-positive patients. It cures about 10–12% in absolute terms of premenopausal node-positive patients, but in the smaller single digits for all other categories. Published a number of papers. One paper was 2004, and co-authors are Banadana, who has spent 30 years developing chemotherapy protocols for breast cancer patients, and Judah Folkman, who spent 30 years studying angiogenesis. He's the founder of angiogenesis. I was on Folkman's staff at the time. Delagusa, Rashevsky, and Ronald Demicheli are there. Second thing is mammography works better for women 50 to 59 than 40 to 49. When they first looked at mammography, they were sure it was an improvement, but they wanted to see what the benefit was. So they did clinical trials. Trials were done in Sweden, US, and UK. And when they looked at women age 50 to 59, there was an early appearing strong 20% survival advantage for patients who had a mammography in age 50 to 59. But when they looked at age 40 to 49, there was an anomaly. In the first number of years, first 4, 5, 6 years of the clinical trial, there were more breast cancer deaths among the intervention group than among the controls. This caused a big confusion. It's been called the mammography wars. People didn't believe the data because they were sure that mammography works. They couldn't explain it, and it got very ugly. There have been a lot of papers written on that. At any rate, one thing happened very interesting. I was studying this effect of the surgery-induced tumor growth, and I was publishing a paper in 2005, and I happened to be sitting at a Folkman lab meeting, and Folkman had invited a Pulitzer Prize-winning reporter from the Wall Street Journal to sit in his meeting, and by chance, she was sitting next to me. She was a premenopausal woman, a writer from Wall Street Journal, and she asked me what I was doing, and I talked to her. I said, I'm studying the impact of surgery on tumor growth and that it affects the benefit of mammography for women in the age 40 to 49. Well, she was in that age 40 to 49, and her editor was also a female, age 40 to 49. So they decided they wanted to write up something on what I was publishing. So we organized it. And that paper was published in 2005. I don't know the date. This paper came out in the Wall Street Journal. Harvard issued a press release. And so all those things happened at the same time. Got a lot of attention. One good thing that happened from all the attention, I got a letter to the editor from Isaac Gukas. Isaac died a few years ago from cancer. He was originally from Nigeria. He practiced oncology in Nigeria for about 10 years and then moved to UK. So he was a surgeon at one of the universities in UK. He said, what you're describing could explain what they see in Nigeria. He said in Nigeria, women are, when they find a lump in their breast, they do not go to see a surgeon. They go to an herbalist to get some satisfying, some soothing ointment. Then they go back to their village and die from untreated breast cancer because they know from previous women that the surgery makes things happen faster. The word that Isaac used was the surgery provokes it. That's what the people, the females especially in Nigeria, think. So in general, breast cancer in Nigeria is treated as untreated. People just die from untreated breast cancer. We've spent a lot of time on it. Another thing is that there is a racial disparity in outcome. In the US, African Americans have about a 1.5 excess mortality ratio compared to Caucasian Americans, European Americans. But there is an inversion at age 57. Women diagnosed, African American women diagnosed under age 57 have poorer outcome compared to European Americans, but diagnosed over age 57, they have superior outcome. So it's hard to trace this to lack of access to quality medical care. It has to be biological. Published a number of papers on that. I would say one of the best ones would be Demikelly, 2007. Another thing is that breast cancer in young women is often called aggressive. And I can understand that. They remove the primary tumor, and within a year, the patients relapse. And this seems to be an aggressive quality to the therapist. But from our perspective, it's clockwork relapse 10 months after surgery. And I happened to find this paper written by Irving Ariel. And I wasn't looking for it, but I happened to run across it, and I was fascinated by it. Irving Ariel looked at treatments of breast cancer in a very long time ago. We started 2,000 years ago discussing what Celsus and Galen, Greek and Roman scientists and surgeons and physicians were doing. And this is their writing. It's been translated several times, so the exact wording might not be perfect, but this is the best I can come up with. Celsus, first there's the cacoethes and carcinoma without ulceration, then the fungating ulcer. Cacoethes corresponds to a small, obvious tumor, but that has not penetrated through the skin. It's a small, obvious tumor. None can be removed but the cacoethes. The rest are irritated by every method of cure. The more violent the operation, the more angry they grow. You hear about surgeons talking about cancer being angry. After an excision, it recurs, bringing with it a cause of death, whereas at the same time, by using no extirpation, protract lives, notwithstanding the disorder to an extreme old age. Okay, you know, this sounds very much like what I was just showing you before. Remarkably, without the use of infection control or pain control, they're actually able to save patients. Galen, we have often cured this disease in the early stages, but after it has grown to a noticeable size, no one has cured it with surgery. It sounds very much like these surgeons 2,000 years ago knew all about this, what I was talking about, but it somehow got forgotten. The most important finding at this point, my colleagues and I came to the idea was that something happens at or about the time of surgery to cause early wave of relapses. It accounts for over half of all relapses in breast cancer. And surgery apparently induces angiogenesis of dormant avascular micromets and starts growth from single dormant cancer cells. And this may be a general effect, not just breast cancer, but all cancers. Okay, this is skipping ahead to 2010. A paper was published by Patrice Forget and colleagues. This was from a hospital in Brussels, Belgium. This is a teaching hospital where they have to expose all the residents in anesthesiology to all the drugs used in anesthesiology. So what they did a retrospective study. They took the last 230 consecutive treated patients operated on by one surgeon and given conventional chemotherapy and hormone therapy. And they looked at the outcome of these patients for the first 5 years and grouped them by what drug was given at anesthesia. And one drug was by far superior to all the others, was ketorolac. It was the only NSAID that they were using at that time that was IV available. There are a couple other NSAIDs that are IV available now, but at that time, ketorolac was the only one they had. There was a 5-fold reduction in relapses 9 through 18 in the ketorolac patients. Okay, so this was very interesting. We knew that some intervention at the time of surgery would be needed, but what mechanism could explain the Forget data? And I want to read this one sentence from a paper by Hillebrodner et al. The perioperative window can be considered a perfect storm of immunosuppression and inflammation in the presence of residual or circulating tumor cells. At this point, we decided to take a look at a number of very large subjects and try and find correlation among them. Looked at surgery, of course, surgery is involved, inflammation, to find out that IL-6, a conventional accepted marker for systemic inflammation, shows up in serum for about a week after surgery for breast cancer, colon cancer. Angiogenesis is a factor here. Platelets actively sequester angioactive factors, and they degranulate in the presence of inflammation. So there is a surge of about 10% increase in VEGF. That's the major driver of angiogenesis, and about a 10% drop in the number of platelets. There are circulating tumor cells. It's well known that cancer patients have circulating tumor cells. The immune system is compromised, and cancer dormancy is a well-known effect. So there are a number of possible interactions between those very large subjects. Okay, I'm just going to list a number of these things that seem to be very important. Virchow, 1863, chronic inflammation leads to tumor growth. Dvorak from Harvard, 1986, cancer as wound healing gone awry. Bob Weinberg, 2005, cancer usurps the wound healing process. By the way, I edited a book on this subject, and the book was, the preface was written by Bob Weinberg. He did a very good job on it. Balkwell, if genetic damage is the match that lights the fire of cancer, then inflammation is the fuel that feeds the flames. This is a pretty good simplistic description, but it's not too far from the truth. Krebs and C, well established that patients have circulating tumor cells, and this correlates with prognosis. And it is known that daily aspirin reduces risk of late relapse after 2 years of use. Okay, this was a paper I got involved in. There was a paper submitted for publication by El Sager from Lebanon. He submitted it to Biomed Central, Cancer. And I was asked to review this paper. This is a case report of a young gentleman who was diagnosed with inoperable lung cancer. They treated him with radiation and let him go. He was just released, let him live whatever kind of normal life he can have. Prognosis was terrible, but for a while he was doing okay. He was driving his car and hit a bump, and he bumped his head on the head visor of his car. And within a month, a 7-centimeter tumor grew at that spot. So El Sagar said, what could explain the sudden growth after minor trauma? And wondered if it was what Dema Kelly and I had been writing about surgery-induced growth. Well, we have this computer model. We have a quantitative understanding of tumor growth, and this cannot be explained by what we were reporting as surgery-induced growth. This is totally different. And I was walking around the lab in the Folkman lab, asking if anyone had any ideas, and someone said, look at this paper by Martins Green et al. This is Mina Bissel's group. And this was the case of a avian root sarcoma virus in circulation. And the interesting thing was that if they wounded the bird at any place, you would get the tumor would grow there. But they could control this with inflammation. If they prevented inflammation, they could wound the bird and nothing would happen. If they allowed inflammation, this wounding would cause the tumor growth. This is similar to what El Sagar was saying, but the size of a virus is 1/100th the size of a cancer cell. It's not a good correlation. Another paper shows that under inflammation, there's tissue damage, and this increases the permeability of adjacent capillaries, 30-fold increase in kilodaltons, Agawa 2013. This is a paper from 100 years ago, Jones and Roux, 1914. This is a quotation. The localization of secondary tumors at points of injury has been so often remarked upon that it's unnecessary to cite specific instances, cause unknown. This was at a time when people walked around with cancer far more often than today. Walter et al., 2011, they had 2 patients that had something very similar to that. The blood speed in capillaries is 0.5 millimeter per second compared to 40, 50 centimeters per second in larger arteries. So if you had leaky capillary venules, it would be an efficient way for circulating tumor cells to get trapped in a distant organ. And these are papers marking that IL-6, the systemic inflammation marker, is elevated in serum for about a week after surgery. Metastatic process is inefficient. A cancer cell injected into circulation has a very small probability to result in a growing metastatic site. And inflammation, in the presence of inflammation, because there is not an intact vessel wall, there might be easier way to have the cancer cell extravasate. This is a paper, it's an important paper. I'll be discussing this at the end. Telekas and Dema Kelly, they looked at patients from Norway, 300 patients, and they analyzed these patients who had delayed reconstruction, median of about 30 months. There were something like 300 patients in this data set. They looked at the relapse rate of those patients with time 0 set to the time of original primary surgery, and they found the standard bimodal relapse pattern that we've seen many times. I'll show you that later. They also set time 0 equal to the time of reconstruction, and they got a much bigger early relapse. The result from that experiment said that it's not just cancer surgery that causes this tumor growth, it's any surgery. Clement, we talked about that. Excuse me. This is chapter 4 in that Springer Nature book by Hiller et al. These were anesthesiologists. After reading this chapter, I would be surprised if surgery did not cause tumor growth. They discussed the development of the human immune system over the 2 million years we've been around as a way of helping our ancestors, our ancient ancestors, survive bites from animals or falling off a tree or whatever. After reading this paper, as I mentioned, I would be surprised if surgery didn't cause tumor growth. And one of the major things that they talked about was the fact that neutrophils are generated in large numbers. Generated after wounding, they generated about numbers of about 10 to the 11th. And they are red blood cells, and they circulate, and they release some DNA from their system that is called the neutrophil extracellular trap. It's like a web, it's like a butterfly net, that these neutrophils are going through the capillaries, dragging this butterfly net that can actually capture circulating cancer cells. And since neutrophils have the ability to extravasate, they escort these circulating cancer cells into the tissue. So this could be a very important way by which our immune system and neutrophils and nets can cause relapses in distant tissues. Okay, there were several animal models studied. One of them was by Krall et al. This was from Bob Weinberg's lab at MIT. It was reviewed in NEJM. You can look up this reference. This was an animal model they developed. They could inject cancer cells into this mouse. And if the immune system was competent, these cancer cells would go into dormant states. If the immune system was not competent, then this would not happen. But when they had dormant cancer cells in these animals, they could operate on one side of the animal and get tumor growth on the other side, and vice versa. MIT issued a press release, got a lot of attention, and they found they were able to control this with an NSAID. So the idea that by using an NSAID at the time of surgery, you could prevent these surgery-induced relapses made a big difference. And a lot of newspapers picked up that story. Another paper was published on another animal model, Panigrahi et al. From Harvard. I know maybe a third of the authors on this paper. This is the first sentence in their paper. Cancer treatment is a double-edged sword. Surgery, chemotherapy, or radiation can induce dormancy, escape, and subsequent metastatic outgrowth as a result of the intervention. So they talked about ways how all these can happen. Surgery and chemotherapy and radiation can they can reduce the tumor size. They can also cause exits of tumors from dormant states. A couple of papers I found recently that were pretty important. Lipitz and Harris, 2016. IL-6, the conventional marker for systemic inflammation, is a prognostic factor for many cancers. Kita, in 2011, they were looking at the effect, the relative importance of IL-6 on each day before surgery and after surgery. So they looked at 1 day before surgery, 2 days before surgery, the day before surgery, the day after surgery, and days after that. And they found that the most important time when IL-6 was a prognostic factor was on postoperative day 1. This is for lung cancer. This is a paper that was published in 2017, and I know in 2019 or 2020, it was one of the most highly cited paper in the Springer group. It got a lot of attention. And they looked at prognostic role of neutrophil to lymphocyte ratio, which is another measure of systemic inflammation in breast cancer. It's a major factor and shows up in maybe 10 different databases, breast cancer databases, that NLR has about a 2-fold effect on the risk of relapse and the risk of survival from breast cancer. Nothing else, just a measure of pre-surgical neutrophil to lymphocyte ratio. Okay, if I have 10 more minutes left, I hope I do. I want to go through this other paper. This is another paper that was published and also recently, December of last year. It's online, it's available, freely available. And at this point, I was pretty sure we knew how to prevent the early relapses, but it was puzzling to me, why can't we prevent the late relapses? What are we doing wrong? And I spent years thinking about this, and I ended up with an inspiration, and it was based on this paper I mentioned before, the Lecca where they measured the disease-free survival, recurrence post-reconstruction for 300 patients who had mastectomy and delayed reconstruction. The delay was about 3 months median delayed reconstruction. And when they set time zero equal to the time of surgery, that's the blue curve here, they found the bimodal relapse pattern, a small early relapse peak in the first 3 years, and then a strong late relapse. But when they set time zero equal to the time of reconstruction, they also got a bimodal relapse pattern, but it's a much stronger in the first 3 years than afterwards. So as I mentioned, the important thing to them was that this was not just an effect of surgery-induced surgery on cancer, but it's general surgery, because these patients supposedly had no cancer. I was thinking about this, and this is what I came up with. I respect they did the work, and I respect that it's quality done. Demicali did it, and I'm sure it's right. But if they did not analyze these data, if they did not look at these data for the patients who had the relapse, who were the same patients, but if they looked at the ones who had T0 at reconstruction, these patients would have late relapses, ordinary late relapses. Nothing special about them. However, we know that these patients had cancer cells sitting in dormant states, and the surgery caused these early relapses. The early relapses to them were in the first 3 years after the reconstruction, and if they did not analyze these data, these patients would be ordinary late relapses. But we know that these patients would do better if they had been given NSAID perioperative ketorolac at the time of reconstruction. So the conclusion out of this is that any breast cancer patient or survival who is at risk of late relapse could benefit from using NSAID ketorolac when any planned surgery is conducted for a cosmetic or health issue. So these patients had the surgery for a cosmetic issue, reconstruction, but I know a lot of cancer patients who have surgeries within a few years, 5, 10, 15 years after surgery, and they don't know about this. This paper is going to save lives. Conclusions: the early relapses in breast cancer, which comprise the majority of relapses, are surges of angiogenesis and single cell activation triggered by primary surgery and maybe the late relapses. The Forget data, retrospective data, that suggests ketorolac reduces early relapses 5-fold. This still needs to be confirmed, and we predict this can reduce breast cancer mortality by 25 to 50% at low cost and toxicity. The only side effect that's a problem is excessive bleeding by giving an NSAID at surgery. And a friend of mine, an orthopedic surgeon, said that they've been using tranexamic acid for years, and that reduces bleeding after breast cancer surgery by 39%. So that could be a way of reducing the problem with ketorolac. These data suggest that the transient systemic inflammation is what precipitates the early angiogenesis and single cell growth from dormancy. Breast cancer runs its course in over a decade, but most of the events that lead to relapse occur in that first week after surgery, and it looks like the metastatic progression is amplified 100-fold during that post-operative week. A protocol is published for that perioperative NSAID, and also a post-operative oral NSAID for 4 days. Second Belgian retrospective study was published in Journal of National Cancer Institute, Desmet Demicheli in 2018. It confirmed what Forget had. So at this time, we say after 2 retrospective studies, extensive analysis of clinical data in 2 mouse models, the Crail paper and the Penigrehy paper, we think it's time to conduct 1 or more clinical trials, prospective trials of triple negative breast cancer. We think that category should respond best to perioperative NSAID. The trials in the planning stage at Beth Israel Deaconess Medical Center. Ted James is the chief of breast surgical oncology there. The cost, this drug costs $5 per patient, and there are 2 million new breast cancer patients per year. So for $10 million in cost, we'd cut the breast cancer problem in half. Surgery-induced effects are apparently host responses to surgery with little to do with the cancer cell genotype, and it's not the fault of the surgeons. It's not sloppy surgery by the surgeons. And it seems to be a general effect based on retrospective studies. Perioperative NSAID ketorolac seems to work in ovarian and colon cancer, and it's been references here. And the late relapses seem to be preventable by controlling the perioperative window, and that was published in my paper in Censors. These are my colleagues, Rick Rogers, who was the lab director at Harvard. I was part of his lab. The lab was eliminated in the past few months, and I have resigned from Harvard. This is Pat Wood. She was the wife of Bill Rashevsky. Bill was the medical oncologist I used when I was treated with stage 3C colon cancer. I was the first one to use metronome chemotherapy. Pat Wood died of cancer a year or so ago. This is Romano Demicheli from Milan. Above Romano is Pinucci Valagusa. She's been a database manager in the Milan database. This is Gianna Bonadonna. He passed away a few years ago. He was the clinician in the Milan data. To the right is Patrice Forget. He's the anesthesiologist. He's now in Scotland. This is Vikas Sukatmi. He was at Harvard at the time. He's a dean of medicine at Emory in the US. In the middle picture here, I'm standing on the left as Romano Demicheli. This is Jayant Vieta, who is a surgeon from UK. This is Isaac Gukas, who, as I mentioned, he died of cancer, but he was a surgeon, breast surgeon. The lower left is Usaro Erhabor. I've been to Nigeria on 3 trips in the past few years, and Osaro is my main contact there. He's one of my very good friends. And this picture in the middle here is Michael Baum, a retired breast surgeon. There is Isaac Gukas and myself. We were having lunch at the Royal Medical Society in London. This is Ted James, the surgeon from Beth Israel Deaconess. And the lower right is Judah Folkman from Harvard. He's dead also. Thanks for your attention. I'll be happy to take any question.
Thank you very much, Dr. Michael Retzky, for this valuable information you have provided in the presentation. So anyone has got any questions, please?
I realize this is very unusual research to you, and I would not doubt that you're very skeptical. So a skeptical question would be perfect to ask here. If there's something you don't understand, it's the perfect time to ask. I've presented this many times, and I'm always getting questions that may sound stupid, but they're really good questions. If you don't understand something, maybe I didn't explain it well enough.
Yes, you're absolutely right. Yes, I do agree. So you mentioned something about interleukin as a prognostic marker for inflammation.
Yeah, the markers, the accepted, well, there's not one accepted way to measure systemic inflammation. Neutrophil to lymphocyte ratio is one good way because you can just look at a complete blood test and just read it off there. Many people have done that. It's a good prognostic factor. And also IL-6 is a good prognostic factor. And the dietitians use another marker, I forget the name of it exactly, but the dietitians also worry about inflammation and they measure inflammation by another marker altogether. But these markers don't all correlate, they're all valid, they're all useful.
All right, thank you. Thank you for informing. Anyone else has got any question, please?
Hey, thanks for your attention.
Thank you, Doctor. So now I am going to call upon our next keynote speaker, please. Dr. David J. Shulkin from USA to deliver his keynote speech, please. So we are just waiting for him to join us. If any one of you have got any questions related to the presentations you have just received, you can just leave the question in the chat box so we could answer your questions. We are just waiting for our keynote speaker to join us in a short while. So there's one comment for Dr. Retsky for such a wonderful presentation. Thank you, Dr. Retsky.
Welcome, thank you.
All right. So there is again one question for Dr. Retsky, please. How do we balance inflammation as a factor against cancer cells and contributing to the cancer, especially cytotoxic T cells, please?
Yeah, the way to, best way to prevent the inflammation is, well, from what we know, the inflammation at surgery is due to the wounding, the tissue wounding, which releases arachidonic acid, which causes a cascade of events, COX-1, COX-2, 5 locks, and it goes through the entire body. It causes inflammation in the entire body. It creates neutrophils. The only way to stop it is to use an NSAID just at the time of surgery. You can give an NSAID after surgery. That'll make some effect. But I don't know of any other way of preventing inflammation other than some use of NSAID. What was the remainder of the question?
How do we balance inflammation as a factor against cancer cells and contributing to the cancer, especially cytotoxic T cells?
Yeah, this is the situation with the inflammation is that it goes throughout the body. So you have to treat in the blood. You have to make it systemic. You can't just treat one little area and say it's under control. You have to have some intervention that goes into the blood. And we found that NSAID is very effective. It can be dangerous. You can overdo it. You can have problems with NSAID extremely by using it too much. But using it carefully, I think it can be done. And I think there are some drugs that are available. I think one of those clinical trials, one of those animal studies, that one from Harvard, Panigrahi et al., they talked about some other ways of controlling inflammation. I would refer to that paper as a way of controlling inflammation other than using an NSAID.
Thank you. I hope your question is settled now. So now we are going to call upon our next keynote speaker, please. Dr. David J. Shulkin from USA to deliver his keynote speech. Thank you.
Okay. Well, good morning, everybody. I am just trying to figure out how to share my screen, which I don't necessarily know how to do.
So if you move the mouse over the screen and see the share screen green part, if you could click that, and then on your desktop you can click on your presentation, please.
Okay, great. That would be okay. Very good. Thank you for your help. my first time doing this. Is my screen available to you?
Yes, perfect.
Okay, but I want to get it into the share screen mode.
Yeah, so here, yeah, perfect.
Is that right?
Yes, please.
Okay, very good. Well, I'm just waiting for the screen to come up. Are you able to see it yet? I'm not.
I think it's stuck here. If you could just click on the bottom right side on the screen where you kept the cursor earlier. If you could click it again, so it may become enlarged for the full screen view. Yes, I think something is going to happen.
Okay, I'm so sorry about that. Okay, it's always a speaker's nightmare when this happens, but I am going to just try once more.
Yes, please.
Share screen, and then, okay. I think I'm gonna leave it like this, and if that's okay, can you see okay?
Yes, we can see.
Oh, okay. So I apologize to everybody for all those technical issues. Hopefully it'll go better from here on. I always like to start with a disclaimer. I think it's a good practice. And basically what my disclaimer is that I am certainly not an expert like so many of you on the call in digital pathology. That I am not a pathologist, I'm actually an internist. But what I am an expert in is in understanding the healthcare delivery system. I have been, besides being a physician, I've been a CEO of several of the largest hospital systems in the United States, in New York City and the New York City geographic region. I've run large physician organizations. I've been the dean of a medical school. And as we're going to talk about, I've had some recent experience running the largest healthcare system in the United States. But one of the reasons why I call myself an expert in these areas is because no matter what job I've held, I've always kept my white coat and always taking care of patients so that I could understand how the healthcare system works. And so this is a picture of me when I was the secretary in the Department of Veteran Affairs, taking care of veterans that I would take care of both in person and via telehealth. And we're going to talk a little bit about that. And so I had mentioned that the Department of Veteran Affairs is the largest healthcare system in the United States. Many people don't realize that it's the second largest government agency. The Department of Defense is the largest, and number 2 is VA. VA employs about 425,000 employees. Just to give you a sense, the Department of State, which everybody has heard of, employs about 20,000 employees. So VA is a very, very large health system. It has facilities in almost every congressional district in the country, over 1,200 different facilities from coast to coast, many in very rural parts of the country. And so it's probably one of the only health systems in the United States that really has to deliver care no matter where they have facilities. The responsibility is to deliver care to every veteran in the country. There are 21 million American veterans, so it's a pretty large health system. Now, in terms of the area that we're discussing today, the Department of Veteran Affairs then, because of its scope, has a pretty large base of patients that have prostate cancer. Certainly, traditionally, the Department of Defense and the Department of Veteran Affairs have been overrepresented by males. So 489,000 prostate cancer patients currently are in the Department of Veteran Affairs healthcare system. About 16,000 of those have metastatic prostate cancer disease. So to give you a size and scope of what's happening. About 1 in 5 of US veterans will develop prostate cancer in their lifetime. It's the most common cancer diagnosis. Those that serve in the military are twice as likely as those in the general population to develop prostate cancer. And there are the numbers that you've already seen, the 489,000 and the 16,000. Now, for those of you, particularly those of you who are international, who may not have a sense about what differs between a VA hospital and a regular hospital in the private sector, they take care of generally the same types of conditions, from preventative care through chronic care through hospice and long-term care. But the culture of the organization is very different. It is a very mission-driven organization. And this is just one example of how I learned that. I'd been in the private sector all of my career when I went into government in 2015. And I went to a VA hospital and saw this, which is when a patient dies in a hospital, in a regular hospital, they usually cover the body with a white sheet. They wheel the stretcher with the white sheet over to the elevator and usually down to the basement where the morgue is. And that's how they deal with the body. In a VA hospital, instead of using a white sheet, they will drape the body in a flag. And you can see people line up on the hallways. And as the body is wheeled past, they salute in what's called the final salute, to say goodbye and to give their respect to somebody who has served their country. And so it just gives you a sense about how mission-driven this organization is and the sense of respect for duty and service that people give to our veterans in this country. Now, when it comes to taking care of our veterans, of course, not everything always is done perfectly. That's the same in private hospitals. And so there are many people out there that look for faults in the VA system, things that the VA system did wrong. And prostate cancer and misdiagnosis or mistreatment has been a chronic issue in the VA system, largely because of the amount of veterans that are cared for in so many different parts of the country. And so these are ads that are often seen on American television by lawyers looking to identify veterans who have been mistreated for prostate cancer. I think everybody on the phone understands that the issue of misdiagnosis, the issue of potentially getting the grade of a prostate cancer or any other cancer incorrect, is a significant patient safety issue. And the Department of Veteran Affairs has had some public issues. In fact, one of the differences between running private hospitals like I used to and running the Department of Veteran Affairs is that when mistakes happen in private hospitals, they often stay quiet and you can settle a lawsuit. In the Department of Veteran Affairs, everything is public, and it often will turn into a congressional hearing or a front page article in one of the major US newspapers. And so there have been some very highly publicized cases where veterans have been misdiagnosed, and that obviously is a big concern. So when we look at the broad issue of misdiagnosis as a patient safety issue, you can see that data that has been looked at across the country shows that 44% of some types of some type of cancers are diagnosed. Now, this is not always a pathologic misdiagnosis. This could be a clinical misdiagnosis where people are then given the wrong treatment styles, but or it could be radiologic, as you can see here on the third bullet. 51% of breast imaging second opinions are actually different. So it's almost like flipping a coin, that if you give the same image to two different radiologists, they can have two different interpretations almost half the time. So this is a big problem, not only in pathology, but in other areas of clinical diagnosis. When I first became secretary of the Department of Veteran Affairs, whenever you speak about things, you can get a lot of attention for what you're speaking about. These two pictures just sort of give you a sense of what that's like. When you sit down at a congressional hearing in the United States, as you can see me off on the left giving testimony, what you don't normally see are the cameras and the photographers and the journalists that are around you. But every time you're speaking, there generally is a press corps around you. And that's a very powerful position, because you can articulate and give information to the public about key issues if you're thoughtful about it. Off to the right, it's a little bit of a blurred picture, but this is actually the White House press briefing room. A lot of people only see the picture from looking at the speaker. You can see me at the very bottom of this picture where I am delivering a speech at the White House briefing room. But I took the picture looking out to see how small a room that is, but also how many reporters are in there covering what you're speaking. The reason I'm mentioning this is because within the first month of becoming secretary, I went to that White House briefing room that day to talk about this issue, to talk about the problems that have existed in the Department of Veteran Affairs for decades, and that if we didn't change our approach and we did not modernize our system, that we would continue to see these types of problems again and again and again. And it didn't matter if it was a Republican or a Democrat who was the president. What mattered is the systems of care that we had for caring for our veterans, and that we really had to modernize our approach. And part of that approach, which we're going to talk about, is using artificial intelligence and machine learning, and using technology in a way that we can change the way that we deliver care. One of the first things that I started to do then was to bring this technology into the Department of Veteran Affairs. Off on the left, you can see that this was actually, I forgot to mention for those that don't follow American politics that closely, I actually was the only one in the President Trump's cabinet that had been a presidential appointee to President Obama. Normally, a new president clears out all the old political appointees. I thought I'd be leaving at the end of the Obama administration, but President Trump asked me to be the sole person to stay on and to join his cabinet. In the Obama administration, I actually brought IBM using their artificial intelligence tool, Watson, to help us do a better job of caring for patients, veterans with cancer. And some of you may remember that at the time in the Obama administration, President Obama asked Vice President Biden, currently President Biden, to lead the Cancer Moonshot Initiative. And I was the representative on the moonshot from the Department of Veteran Affairs. We would meet with now President Biden every week in his office, and we would talk about what we were doing to improve the care for cancer care for everyone, and my job was to do that for veterans. So I brought artificial intelligence into the VA system and created a personalized medicine program to help veterans. Off to the right, when I worked with President Trump, I asked President Trump for help in expanding technology to better care for veterans, not only with cancer, but also with other diagnoses. And I asked for his help to allow us to use telehealth in a much broader way across the entire country. Now, today in the pandemic with COVID-19, I think everyone is used to using telehealth in a much more expanded way, but probably a year or two before the pandemic, at the Department of Veteran Affairs, I asked the president for help so that we could have veterans treated at any part of the country by clinicians in any part of the country. In the United States, licensing is done at the state level, and that prevented us from allowing a doctor in New York City to help a patient who was in rural Wyoming. But thanks to President Trump's help in this, we were able to get the expansion of telehealth to every part of the country for every veteran in the department. That really was a big help once COVID-19 started to appear, because VA already had a very effective telehealth system in place, the largest implementation of telehealth anywhere in the country. Now, we were using that then to expand our telepathology services. VISN 8 is a region of the country. That's all that means. But this is how telepathology was being used for consultations, for second opinions, and frankly, to reduce the geographic barriers. That means to allow pathologists with specialized expertise to be able to help patients with diagnosis of cancer anywhere in the country. And this was really a dramatic expansion in the capabilities of the Department of Veteran Affairs. So with the regulatory changes that we were able to get in place and now are in place for everyone in the country because of the COVID pandemic, we're seeing a dramatic expansion of telepathology services. Now, I do want to sort of step back just a few minutes and talk about why these technologies like artificial intelligence and machine learning and even some of the remote monitoring capabilities seem to be so slow in terms of getting disseminated throughout the US healthcare system. And there are three fundamental reasons that I always think about when we look at why are things not working better in the US healthcare system. And they really have to do with the fact that physicians and providers in general and payers are not incentivized in the same way. So that often what is good for a provider to do financially turns out to be bad for a payer, or vice versa. What's good for a payer turns out to be bad for a provider. And that just slows down the whole system. That clearly was the case using telehealth, and clearly is the case using artificial intelligence. If we replace physician interpretation, physician income will go down. And so there has to be better alignment of these incentives. The second problem in the US healthcare system is that the way that we have created our insurance coverage and our insurance product design is that consumers still generally have a very small share of cost. And so therefore there's a disconnect between what consumers think that they deserve and want and the payment system. And that doesn't exist in most other markets, and so therefore creates some unique problems. And the third issue is that if you were to create something that looked more like a traditional marketplace, consumers and providers and payers have very little ability to look at what true costs are, price transparency, and also what the outcomes of care are. So there's really no connection between what one's buying and paying for and the value that they're getting. So those are the three fundamental flaws of our system that I always look at when I try to explain why something is working or potentially not working or going slower or moving faster. The truth is that while we call the US healthcare system a system, it really is not a true system. It's just a bunch of individual components that aren't always connected. And I think the pandemic in COVID-19 has really exposed a lot of the fragmentation of the US healthcare system and shown the gaps where the system doesn't really yet work together. So we have government that now is paying about 50% of the healthcare bill. We have the providers, which are the doctors and hospitals. We have the payers, the insurance companies, we have patients. And then we have the capital markets and the healthcare industry themselves. And each one looks at the healthcare system somewhat differently and approaches care somewhat differently. Some people on the call may be interested in how the Biden administration may impact this. Are they going to change some of these incentives? Will there be an ability to speed innovation? Will there be more money that's put into the healthcare system? With a United States Senate that's divided 50 Republicans, 50 Democrats, I think that what we're looking at is a governance or legislation or the way that we're going to be looking at healthcare policy much more from the center rather than from either the left or the right political perspective. And I think most people feel it's very unlikely that we're going to see major changes in the way that healthcare is delivered in the United States. Rather, we're going to see incremental or marginal changes that, while they can be important, will not fundamentally change the way that healthcare is delivered. And much change in healthcare in the United States is actually done not so much by Congress, but through regulation. So regulation is done by the agency that's part of the executive branch. Healthcare is generally run by the Health and Human Services Agency, and they don't do that much through legislation. Obviously, if Congress wants to change the way that healthcare is delivered, they can pass a law. But what I'm saying is, in a 50-50 Senate, that's not likely. So you're going to see most of the changes done through writing different rules and changing regulation that does not require congressional approval. Now, President Biden, who many of us have known for a long time, and as I said, I worked with him in the Obama administration, has a fundamental belief that healthcare is a right of all citizens. And so what he really wants to do is expand access. He wants to see all Americans have access to healthcare. Right now, as you know, we have more than 40 million Americans without insurance in this country. And the way that he wants to do that is very much along the way that the Obama administration was doing this. He wants to strengthen the Affordable Care Act, which is going to include more subsidies for insurance exchanges. And you've already seen more executive orders signed by President Biden than any other president, because what he's really undoing, what he's doing in these executive orders is undoing the work of the Trump administration that was trying to limit the effectiveness of the Affordable Care Act. They couldn't get a congressional change and they couldn't get the Supreme Court to change the Affordable Care Act. So what they did was, through executive orders, the Trump administration really put barriers and limited the effectiveness of the Affordable Care Act. And you're now seeing President Biden roll all of those executive orders back to make the Affordable Care Act more robust and to be able to expand it. You're also going to see President Biden supporting some of the work that had been done in the Trump administration under cost and quality transparency, making it easier for people to understand what these outcomes of care are and the cost of care. And also, you're going to see continued support for the regulations to support the ability to use data interoperability, especially electronic data. And this is going to be important for digital pathology, to be able to make sure that pathology information that is digitized can be shared easily across different electronic health record platforms, along health insurance exchanges, and is interoperable in general. The other area that you will see President Biden and the administration continue to focus on is device and drug pricing reductions. This is something that President Trump had focused on, but had not really done it effectively. In fact, some of his executive orders, like tying drug and device prices to international indexes, were done so sloppily that no one really took them that seriously. I think you're going to see a much more comprehensive and thoughtful approach during these first couple years of the administration of the Biden team towards going back to make sure that they can get some results on decreasing these types of prices. And as a result, I think you're going to see dollars shifted and more dollars being invested into the healthcare delivery system to expand access, and into healthcare technology, because that's the way that you can expand access. That's the way that you can get more efficient and get better outcomes. So just a little bit about the Biden administration. 2020 was a year for all of us that I think none of us are going to forget quickly. It was a very tough year, but it was a big year of change for healthcare. I'm sorry, that keeps popping up. And it was probably the biggest year ever for artificial intelligence. More invested in it, more being done in terms of actually moving it into the clinical setting. This is a really important year in 2021 to see whether that momentum continues. I'm going to talk to you about why I think it probably is likely to continue. Oops. I'm sorry. Maybe we lost the video. I hope not. But I'm going to keep talking, hoping that you can still hear me, even if you can't see me. The impact of COVID-19 on hospitals is something that I think all of us need to pay attention to. What you're seeing in the United States on hospital finances, which will drive whether there is money to invest in these technologies like artificial intelligence, is going to be a big deal. And what you're seeing in the United States is very geographic differences between hospitals that are suffering tremendously because of COVID-19 and others that have actually done fairly well. So it's a story of the haves and have-nots. But overall, the industry has suffered considerably. You've seen a decrease in admissions, a decrease in emergency room use, a decrease in surgeries, in ambulatory procedures. All of that translates into a reduced hospital margin, reduced revenue, reduced ability for hospitals to invest in new capital projects. And so that's something that I think that we have to keep a very, very strong eye on. One of the things that may or may not be evident to those of you outside the United States is that, okay, I apologize. I'm getting messages on here that I hope that you can hear me. But one of the issues for those of you outside the United States that you may or may not be aware of is that the Medicare system, the government system for paying for healthcare largely for people 65 and older, is due to become insolvent, in other words, run out of money by 2024. That's a big deal that that's happening. One of the reasons it's happening is because the pandemic has accelerated the reduction of revenue into the Medicare system. So that is something that's going to have to be dealt with very soon at the national level. With that happening, one of the results might be that Medicare may have to reduce payments to providers. That will even add additional financial stress onto the provider system. So providers are going to now need to take costs out of the system with a focus on labor. The reason why I'm saying their cost reduction efforts will likely involve a reduction in labor is because 60% of all of hospital budgets are focused on people. It's a very people-intensive job. And the way to take costs out of the system is to find technology that may end up increasing productivity and reducing labor costs. Secondly, providers are going to be under much greater pressure to reduce the variability of quality. So if you are having a lot of misdiagnosis in your pathology readings or poor outcomes in cancer care, that is going to be something where there's going to be increased attention over this next year on those types of results. Scale is becoming really more important in the United States as big corporations are increasing their footprints. You're seeing increased merger and acquisition activity in every part of the healthcare sector. And that means that when you have scale, it's going to be a greater opportunity to put technology in place and to get value out of technology. On the payer side, this year coming up, it's a very interesting year. 2020, as you may know, even though the pandemic was in full rage, actually resulted in better financial results for payers. And so this is that mismatch that I was talking about in the US healthcare system. When payers do better, providers often do not, and vice versa. And so the medical loss ratio, how much payers spent on medical care, dropped to record levels during the pandemic because people were not seeking healthcare. They weren't getting healthcare services. And so the profits went up. But most payers are predicting a return, in fact, a backlog of procedures that weren't done in 2020 might happen in 2021. So they are very nervous about what's going to happen to their financial performance in 2021. And therefore, many are acting conservatively. Even though they have a lot of money in their capital reserves, they are scared to spend it unwisely because they're unsure whether they're going to have to pay for all of this deferred or backlogged healthcare. So it's going to be interesting to watch that. Payers are looking for opportunities to therefore take some of the profits that had occurred in 2020 and see whether there's a way to look for projects or technology or new partnerships in order to change the way that healthcare is being delivered. Many are partnering with provider groups, often physician groups, in new types of risk arrangements where each will benefit if care can be delivered more efficiently. And many payers are acquiring providers, physician groups largely, and companies so that they can expand their footprint both horizontally and vertically. In the capital markets, we are seeing more money flowing into healthcare investments than ever before. The numbers are absolutely extraordinary. And the focus is often on this value-based care, on how do we improve the delivery of care to get better costs, to get better outcomes. So digital pathology is one of the beneficiaries of all of these trends. And the global market, as you probably know better than I do, has been relatively increasing at pretty considerable rates. About 11.7% each year is predicted. And so therefore, you're going to see the digital pathology market cross the $1 billion level in the relatively next few years and just continue to grow. And the reason for this is because digital pathology really is one of those technologies that I think meets the criteria of value-based care, improving the efficiency of how care can be delivered, that is lowering the cost, and potentially, when combined with artificial intelligence, improving the outcomes and quality of care. So it really hits a lot of the criteria that you would expect would grow. Patients themselves are changing, and I think the pandemic has really accelerated this in ways that people didn't anticipate. We've certainly seen much less preventative care and much more conservatism on elective healthcare services. Patients have sort of said the things that I thought that I always had to do, I guess I don't have to do that much. And so that's changed the behavior. We've seen them embrace technology with telehealth, and that has disrupted traditional provider relationships. People can get on their computer and get immediate access to a provider, but not necessarily with their provider. And they found that that's okay. And the idea that people are going to have lifelong relationships with providers is beginning to be rethought. And clearly, I think they're becoming more tech-enabled in general, getting much more used to getting their medications at home, getting certain healthcare physiologic measurements taken at home. And you're seeing this whole tech-enabled economy now coming into the home for the provision of healthcare, but also the interaction with technology through electronic health records and other things that had been slower to adopt before the pandemic. Precision medicine is one of those areas that I think people now are beginning to see fits well into all of these changes that we've talked about. And so when you look at precision medicine as a tool, whether you call it artificial intelligence, whether you call it genomics, whether you call it just the ability to do large data analytics for the improvement in healthcare on an individualized level, all of this is coming into the play on how we think about digital pathology. One of the things that I did at the Department of Veteran Affairs is to use that data to help consumers understand the differences in quality of care. So I would publicly display all of our healthcare quality data on the internet for veterans to be able to see. This is an example in Tampa, Florida, where the Super Bowl was just held, where veterans can see exactly what the data in their VA says, what the quality data says, compared to all the private hospitals in the Tampa region, so they could make better informed choices. And I think helping consumers understand who is using technology to help them get better outcomes, which hospitals are using digital pathology, which hospitals are using artificial intelligence and getting better results, I think it's going to be the future of where we're going in the United States. So is digital pathology inevitable? I think that what I've been talking about so far really says that yes, the answer is it is inevitable. And the reason, again, not to be too repetitive, this digital pathology fits into the need for cost reduction, for quality and transparency, for the ability of technology to provide those solutions, and capital dollars are flowing in for those types of investments. Now, when it comes to artificial intelligence in digital pathology, we all know that there is an increased workload on our pathologists, that the cancer incidence is increasing at the same time that there has been not the same corresponding increase in the number of new pathologists entering the market. So that's getting to be a shortage of pathologists as we're seeing the age of pathologists increase, retirements, burnout that's happening, and this trend of increased workload with a shortage of pathologists is creating a need to implement artificial intelligence in digital pathology. We also know that pathologists can often disagree with cancer diagnoses about 9% of the time, and you can see a change in the Gleason grading by pathologists almost 1/3 of the time. So here again are those factors of their variability and quality differences, their economic reasons, and fundamental staff need issues for artificial intelligence. This pathology gap that I talked about, the shortage of pathologists, you can see the anticipated demand growing, the anticipated supply relatively declining, and so therefore this is not likely to get better anytime in the near future. We see an increase in digital workflow of about 21% when digital pathology systems are put in place. That's a pretty big increase in the ability to have diagnostic capacity to increase your productivity, essentially, 21%. I don't know of too many examples in healthcare where that can be done as readily and get those types of results. Now, the state of digital pathology and artificial intelligence in prostate cancer, in reviewing the literature, there's already about 185 articles that are looking and have reported on, many peer-reviewed, on image analytics with artificial intelligence and readings. Looking at reports from around the world, in France, but also in the United States, prostate cancer using artificial intelligence is being interpreted with a 98% sensitivity and a 97% specificity. That's pretty impressive. Investigators are able to detect the differences using artificial intelligence between low-grade and high-grade tumors and perineural invasions. And out of a review of 941 cases using AI with digital pathology, there were 17 misdiagnoses identified in the US population of these cases and 12 misdiagnoses in France. In August of 2020, an article was published in Lancet on the use of artificial intelligence for prostate cancer. It was a blinded clinical validation study done at the University of Pittsburgh in Pennsylvania. And to me, this was a really important study. What it showed was that even at a major academic center like the University of Pittsburgh, there were 6 cases that required a change in diagnosis using artificial intelligence compared to human reads, and that the prostate cancer detection using the AI system had a sensitivity of 98%, and there's your specificity of 97%, the area under the curve at 0.991. So this really demonstrated in a peer-reviewed journal very, very good outcomes associated with AI readings for prostate cancer. How about in breast cancer? There was an article in Nature in January of 2020 showing using AI that there were more accurate readings for mammograms than with human radiologists in the UK and the US. Reduction of 1.2% in false positive readings, a 2.7% reduction in false negatives. And look at that, the reduction in workload, 88%. So that's really significant. And as you know, there are shortages, at least in the United States, of mammographers. Very, very hard to find good qualified mammographers. Let's take a look at some of what these AI readings look like. This is from a company called IBEX that is looking at breast cancer. You can see the heat map, or the red, showing the area of pathology that's being identified and the way that the AI can identify those areas for a pathologist to review. IBEX has 3 ways that they work. They help just identifying a more efficient workflow for where a pathologist can focus their attention. There are second reads that take a look at what a pathologist has already read, putting it against a artificial intelligence algorithm to see whether any additional cases can be picked up or identified. And then in general, as a quality review program, to look for patterns and issues earlier in the process for a improvement process, an educational process, to make pathologists more aware of opportunities for improvement. So all 3 of these are applications today that are being used. As we've talked about before, even though these technologies are already showing that they can be quite effective and save workload, technology adoption is very, very slow, particularly in the United States. And I just want to really finish up here and then leave a little bit of time for questions, just talking about some of the work that that I've been involved in, if people are interested in learning more about it. Off to the left is a book that I've recently written called It Shouldn't Be This Hard to Serve Your Country. It's about my experience as the secretary and the undersecretary of the Department of Veteran Affairs in running the VA healthcare system, and the issues and the approaches that I took towards trying to improve it. A lot of this has to do with population health, with artificial intelligence, the use of technology, and it lays out a fundamental game plan for how we can make these improvements across big health systems and make them work better for our patients. The book to the right is a book that I wrote with others in the Department of Veteran Affairs that takes these approaches and learnings from parts of the VA system to spread them throughout the country, best practices that have been identified to allow us to implement even better improvements across the healthcare system. And a lot of this has to do with what we've been talking about here today. So those are 2 resources. And then finally, something that I've recently started and become involved in is trying to figure out ways that we can help countries share knowledge with one another, and how we can take this technology and really make it available to everybody across the world. And, you know, obviously I'm a US-based person, and so I tend to think about things from an American point of view, but recently I've begun to really appreciate how much innovation there is around the world that can be brought to the US, but also to different parts of the country. One of the companies that I mentioned in artificial intelligence in pathology is IBEX. IBEX turns out to be an Israeli company, and we're working with them to bring that Israeli technology to the United States, but there are certainly other opportunities. And one of those is a collaborative that I've started between Israel and the United Arab Emirates to share ideas and technology to bring this to different parts of the country. So this is israeluaehealth.com. If there's people from the Emiratis or from other parts of the world that are interested in learning more about that. Here is my contact information, my email, my Twitter. I'm also on LinkedIn if people are interested in connecting or finding out additional information. And with that, maybe I'll just leave a little bit of time should there be any questions. I know that there was an email link that people could send questions in for, but be glad to talk about any observations that people may have in artificial intelligence and digital pathology or other questions about the US healthcare market.
Thank you very much, Dr. Shulkin, for sharing this valuable information with us about digital pathology, artificial intelligence, and your work for veterinary affairs. We are pleased to have you with us, and it was an honor. So has anyone got any questions to ask, please?
Yes, I have one.
Yes.
Yeah, I'm Mike Retzky. I gave a talk prior to Dr. Shulkin. I respect your ability to negotiate the distances between the various players in the medical field. I've had a lot of problems trying to solve a problem that's going to take money out of the system. So what's worked out for me is to address this Nigerian breast cancer problem. There, no one objects. If we can solve that Nigerian problem, no one would suggest. But I really, I applaud your ability to negotiate these systems.
Well, Michael, I do not claim to have a secret sauce to get the system to work better together. But, you know, I do like your approach, which is that if you can demonstrate success in one area, that tells people that it's not impossible, and it shows them a way, and it creates a model and you know, a show one, do one, teach one is the way that medicine often advances. But, you know, right from the beginning of my career as a physician, I went and got training in behavioral economics. And so I always approach things that if you don't try to address what the right incentives are, and if you don't try to align those incentives, it's just a lot harder to get people on board. Most people in healthcare want to do the right thing. They want to help patients. That's why most of us went into this field. But when you're asking people to do things against their economic interests, it slows down. So I always look to try to get the right elements in place before you start a major change initiative. But, you know, I applaud you for trying to show that there is a way to do it, because that's the way you know, ultimately change people.
Thanks.
Excuse me, can I have one question?
Sure.
Yes, please, can give us about little experience about the misdiagnosis in pathology and how you react in this if this scenario happen in USA.
Yeah, well, it happens all the time in the USA, and so you know, I think that as opposed to clinical medicine, like I practice as an internist, there can often be different interpretations and, you know, judgment issues. But when it comes to pathology, you know, you have a specimen, and, you know, if it's diagnosed improperly, you're going to have an expert to be able to go back and point out exactly where you misdiagnosed it. So it's much clearer when these diagnostic errors happen in pathology. And that's why I think using a artificial intelligence system as a backup system, as a check of the work, as a way of helping a pathologist see where they should focus their attention so they don't miss something. I think this is what has to happen. I mean, because it's good for pathologists, it's good for patients, it's good for payers. And so I think that this is natural. What I was surprised about, again, you know, saying that unlike most of you, I'm not an expert in pathology. I was surprised at how often these misdiagnoses occur. 12% of the time, pathologists can disagree at looking at the same slide. They can, have a difference in the grading level in prostate or breast cancer. So this just says to me that this is the perfect place to try this type of new technology in pathology.
Because what I face it regarding this issue is very sensitive. You will find even personal resistance from others colleagues regarding changing diagnosis or give them another opinion. So the primary, usually he refuses it to take the experience of the other.
Yeah.
So did you have a solution or you face it? This problem?
Yeah. Look, I the good thing about getting older, as some of the people on the video can certainly probably relate to, is you've seen all this before. So I've been working with physicians my entire career, and this type of defensiveness and saying, I don't have a problem, it's always somebody else that makes the errors, and I don't want to change. As I get older, I honestly have less tolerance for that. I mean, it's just simply not true. Everybody makes mistakes. Everybody can be helped with a safety net if you really care about patients. And so, I would say to the person that was resisting that, would you want to fly on an airplane where the pilot says, I know how to get there, I don't need radar, I don't need to be told if I'm getting off track because I've flown this location, so many times. So I'm now, having led as many health systems as I have, when I hear those type of arguments, I try to understand, I try to be empathetic, I try to explain and show the data, but ultimately, I am willing to show that person the door and tell them, find another place to work if you don't believe that you want to be part of an environment to get safer care.
Yes. Okay, Doctor, I would ask you, how can I get your book?
On Amazon.
On Amazon. Okay. Thank you. Thank you for your.
Sure. Thank you. Yeah.
Thank you. Thank you very much for your time.
Thank you. Great.
So now I'm going to call upon our next speaker, Dr. Manal Assam from UK, to deliver her speech, please.
Is it possible to make a comment or a brief question?
Yes, please.
I try to keep as short as possible. But first of all, I'm a pathologist. I am human, and I do make mistakes. And I think that digital pathology is a great chance that can improve pathology very much. But those preliminary results for an specificity of about 97% is a very low percentage, because as a pathologist, I see it at about 10,000 specimens a year. And if I would have a specificity of 97%, I would make about 300 diagnoses completely messed up, which means one diagnosis a day. And of course, this is far too much. So a usual good educated pathologist has an error or mistake level of about 0.01%. And this can be supported by a good education system. So basically, my opinion is train your pathologist and train and put money in your pathological education, and try to invest in interaction between pathologists. Of course, on the long term, it's a good development, But in the present and in the near future, we cannot rely on artificial intelligence to prove our diagnosis. In my opinion, and that's my personal opinion, right now it's completely impossible. And we need cancer diagnosis every day, this year, next year, in the next 5, and the next 10 years. And if you want to improve the quality of pathology, train your pathologist and invest in education. That's all.
Thank you very much for this information. So let's continue with now Dr. Manal Atwan to give us a speech on her presentation. Thank you.
Good evening. I hope all is doing well and still holding on.
Yes, please. Good evening.
Good evening. Can you hear me?
Yes, we can hear you and we can see your presentation as well. If you could just enlarge it to the maximum, please. Yeah, perfect. Thank you.
Thank you. Good evening. What an interesting talk that was, with quite a lot of thought-provoking ideas. So my second talk for today is quite an interesting case that I have encountered through my review for cases through the colorectal MDT. And I would like to share it because I think it's quite unusual and there's new thought processes through the review of such a case. The order of the talk would be, I'll present the case history followed by discussion and conclusions. So the case belongs to a 40-year-old female patient who presented in May 2017. Yes, it's been that long for this case. She's presented with change in bowel habits and PR bleeding. She underwent a colonoscopy and the colonoscopy showed that there was an annular tumor, as you can see on the right-hand side inset, within the rectum. This was further biopsy proven to be an adenocarcinoma. The patient then progressed as per protocol and underwent an MRI rectum and pelvis, which did indeed confirm the presence of the annular tumor that is present within the rectum. It was 11 centimeters away from the anal verge, and that's quite an important distance to remember when we allude to the discussion later on. It was 3.5 centimeters in diameter, and it was radiologically staged as a T2 or possibly T3A, so that's an early T3 for a pathologist, M1 with lymph node involvement, and M node. So no liver metastasis, no lung metastasis, and I would like to emphasize this point. The patient then underwent a laparoscopic anterior resection. So I share with you on the right-hand side the laparoscopic anterior resection from this case. What I would like to highlight is the following. First of all, that the plane of mesorectal excision in this case was complete, and that there was no perforations, as you can see. So it's a nice, complete mesorectal facial plane of surgical excision. And on sectioning of the tumor, as you can see on the left-hand side, the large bowel wall showed a firm annular white tumor, which has occupied the full thickness of muscularis propria, and possibly there's superficial invasion into the subserosal fat, which we can see in this area. The tumor microscopically was diagnosed to be a well to moderately differentiated adenocarcinoma. It was staged as PT3, PN node, R node. We managed to retrieve 17 lymph nodes in this case, none of which showed any evidence of malignancy. There were no tumor deposits, and there were no perineural and no lymphatic invasion. So I share with you on the right-hand side the H&E section from the main resection showing normal large intestinal mucosa and invasive adenocarcinoma. Originally, when this case was reported, no immunohistochemistry was performed, but with a retroscope in line with what developed later on, I put the case and performed immunohistochemistry. And I share with you a CDX2 positivity, diffuse and strong with positive internal control on the left upper hand side, a negative CK7, and you have to take my word that CK20 was positive in the original resection. So all of which confirms the presence of invasive colorectal adenocarcinoma, phenotypically colorectal origin. The only adverse prognostic factor that this case had, this resection, was the presence of an extramural venous invasion. I share the H&E sections with you on the right-hand side with a tumor deposit within the vein adjacent to an artery within the subserosal fat. We further performed dual staining on the section. The dual staining is for AE13 and CD34. So as you can see, AE13, which is an epithelial marker, is red staining and it's highlighting the tumor cells. These are present, the tumor epithelial cells. These are present within a CD31 positive venous space, confirming the presence of extramural venous invasion. This patient then progressed to be discussed in the local colorectal MDT, and following discussion between the oncologist and the patient, it was agreed that the patient will progress and undergo adjuvant chemotherapy. In this case, it was a single agent chemotherapy, which the patient tolerated very well, apart from feeling fatigue throughout the course of the chemotherapy. The MDT also agreed a 3-monthly MRI scanning in the first year to monitor the area of the rectum. Unfortunately, 11 months later, from the index diagnosis, the patient represented, and this time she presented to the surgeon complaining that an anal skin tag, which was present throughout the course of the her diagnosis and treatment. So from day one, when the patient presented to the surgeon complaining of the PR bleeding and the change of bowel habits, this anal skin tag was present. At the time it was examined and felt that it was a benign skin tag. Why bother? Let's just leave it there. But since the patient complained of tenderness and PR bleeding, the surgeon decided to relieve the symptoms of the patient and excise the skin tag. And what we can see on the right-hand side, I apologize, the slide is a bit faded because it's from 2018, so I do apologize for that. We can see a skin excision lined by stratified squamous epithelium comprising the epidermis. And then the main finding lies within the dermis. We can see this tumor deposit, it's glandular, so an adenocarcinoma. The things to highlight is that there was no connection with the surface. So this is an isolated dermal deposit that lacks any connection to the surface epidermis. And then once we move on a higher magnification, it's a classical colorectal morphological feature with glandular formation and central dirty necrosis. Just note that there is no dual cell differentiation within the glands, something that you might find within skin epithelial tumors, which is one of the differential diagnoses in this case. So we then progressed to perform immunohistochemistry on this skin tag excision, which showed a strong and positive staining within the adenocarcinoma that is present within the dermis. It showed a negative CK7 staining with a nice positive internal control and a strong and diffuse CDX2 positivity. So this confirmed the presence of a metastatic, moderately differentiated adenocarcinoma of colorectal phenotype morphologically and immunohistochemically. Worth mentioning that within the main specimen, this tumor deposit was completely excised. And in line with the NICE guidance, we progressed and performed MMR immunohistochemistry, which showed normal expression for all four immunohistochemical stains, confirming a normal expression or a proficient mismatch repair expression, and therefore minimizing the risk of mismatch protein gene mutation in this lady who is at this time 41 years of age. So to recap, this is a 40-year-old female whom we diagnosed with a mild to moderately differentiated adenocarcinoma in a rectal tumor, stage as PT3 N-node, R-node with extramural venous invasion. She represented in under a year's time with an anal skin tag that contained metastatic colorectal adenocarcinoma. As I mentioned, it was completely excised. The thing to note is throughout the course of, we're talking about now nearly a year from the index diagnosis, CT scans showed no evidence of liver metastasis or lung metastasis. So what do we know about colorectal cancer? We know that within the UK, colorectal cancer constitutes the fourth most common cancer. Under 43,000 new cases of bowel cancer were diagnosed in the UK between 2015 and 2017. And that's the latest data that we have because we tend to run behind. It constitutes 12% of the total cancer cases in the UK, and it constitutes the third most common cancer within male and female patients in the UK. And this is a trend that we have seen change during the years. So fourth most common cancer, only preceded by breast cancer, lung cancer, and prostate cancer in males. But this is not only a UK problem, as we are all aware of. This is a global issue with almost 1.8 million new cases globally diagnosed per year, and sadly 861,000 deaths globally due to colorectal cancer. And we are all aware of common things are common. So the most common site for colorectal cancer metastasis would be the liver being the most common, followed by the lungs and to a lesser extent, albeit the brain. So this is quite an unusual presentation for colorectal carcinoma, which was 11 centimeters above the anal verge, to present with a metastasis within what appeared to be a benign skin tag that the patient had all through. So how did this happen? There are 3 and possibly 4 ways to explain the occurrence of such a rare and unusual metastasis. The first being a hematogenous spread. The second being that could there have been seeding of tumor cells during surgery. So as we know, laparoscopic surgery is quite technical, with trocars being introduced through the bottom end. And could this have triggered seeding of tumor cells in an anal skin tag that was just sat there all through the years? or could have there been circulating tumor cells that decided to seed into this benign anal skin tag and through the course of 11 months grow and develop a tumor deposit. The fourth theory that I could add to this is one that has been recently described of down-dropping of tumor cells due to the effect of gravity in that part of the GI tract, and that all of that remains a hypothesis that is difficult to prove, yet quite unusual. We know in general that cutaneous metastasis from all different types of cancer constitutes 1.3% of the skin excisions that are presented. And out of those, we know that cutaneous metastasis from a colorectal adenocarcinoma in the handful of case reports reported in the literature constitutes up to 6.5% of metastasis. And it seems that reviewing the literature and reviewing those case reports, that the most common site would be within the abdominal skin, and that it occurs in surgical scars. It is felt to infer a poor prognostic factor with an average survival of 18 months. Having said that, our patient is still well and alive, where in 2021 she had a most recent scan in December 2020, and she is cancer free. So I'd like to draw your attention to this case report, which talks in general about cutaneous metastasis, and then presents a kind of similar case, somewhat similar, with quite an elderly female who presented with PR bleeding and was found to have a PT4 in this case, so quite advanced N1 tumor within the rectum that was excised, and then within a month she developed skin nodules within the back that were biopsy proven to be metastatic adenocarcinoma. And sadly, the patient died within 3 months of her initial diagnosis. And what I would like to highlight in this case as well, despite the fact that this case had lymph node metastasis, it still showed no liver metastasis, no lung metastasis, and no brain metastasis. And the question that I would like to ask is, are we really seeing a new process of metastasis in colorectal cancers instead of what's been commonly published? So are we now seeing new patterns of metastasis in which there's no liver, lung, and brain metastasis, yet there is cutaneous metastasis from colorectal cancer? And if so, are we talking about new genetic pathways to contribute to this? Just questions to raise. And I know that in this case, I would like to highlight that the only adverse prognostic factor that this patient had was the presence of extramural venous invasion. And I would like to draw your attention to the systemic review of extramural venous invasion and its importance as a prognosticator in rectal cancers. And the authors of this paper have reviewed 14 studies, which were quite decent sized cohort studies. And 2 points I would like to highlight. The first is just see this, the wide range of variation among pathologists in reporting extramural venous invasion in colorectal cancer, between 9% to 61%. That is quite a huge gap in this, and consistency and reproducibility in the reporting of extramural venous invasion. And then the importance of this comes to the conclusion that most of those studies, 14 of them, and this systemic review highlighted that the presence of extramural venous invasion is indeed related to a worse oncological outcome. So unless we get better at consistently reporting this extramural venous invasion, it is really going to be difficult to use extramural venous invasion in risk stratification for oncological treatments for these patients. And on that topic, I'd like to again draw your attention to the publication by the Royal College of Pathologists, and this time it's the data sets for the histopathological reporting of colorectal cancer. And in this, I think in order for us to develop consistency in reporting extramural venous invasion, we ought really to agree on what constitutes extramural venous invasion. And by that, two definitions have been agreed in this minimum data set. The first being the Talbot's definition of venous invasion in colorectal cancer, and that being the presence of tumor cells within an endothelial lined space that has a thin layer of muscle. The second being the orphan arteries sign, which is when you see this longitudinal invasion of tumor just sat adjacent to an artery, quite disconnected from the main tumor itself, then that is enough for it to be labeled as venous invasion. And if it's invading into the fat, then that's extramural venous invasion. There has been quite a lot of developments when it comes to extramural venous invasion on top of the good old H&E slide, which still remains the gold standard, and that's the presence of elastic stains. And the advice from the Royal College of Pathologists states that should any department have a reporting rate, so a frequency of reporting the venous invasion of less than 30%, so we're using 30% as a threshold, then this department ought to consider adopting the elastic staining to improve the rate of detection of the extramural venous invasion. And in the literature, there has been quite significant research studies proving that the rate of extramural venous invasion can be increased through the introduction of this elastic stain to nearly 54%. In our research that I did with the Glasgow group about the elastic H&E stain, we managed to dramatically increase the rate of detection of extramural venous invasion through using an elastic H&E, which is really cheap. It costs like £2 per slide. And as you can see, it beautifully highlights the extramural venous invasion and its juxtaposition to the thick-walled muscular arteries. So in conclusion, one ought to have a high level of suspicion in patients who have been diagnosed with colorectal cancer once we see skin lesions popping up right, left and center. I would like to really emphasize the importance of having a detailed past medical history and past surgical history when grossing specimens and reporting these histological cases. And again, draw the attention to the importance of consistently reporting extramural venous invasion in these cases. And again, highlight that there are different methods nowadays to detect extramural venous invasion, especially to help non-specialist pathologists in reporting colorectal cancers, whether that be an elastic H&E stain, which is cheap, yet labor intense. And I think consistency is an issue with the Elastica H&E stains, certainly what I've seen in our lab. And the other method that we've come up with, which is the dual staining with AE13 and CD31 to improve the extramural venous invasion. Having said that, I cannot escape the fact that to mention that the dual staining is more expensive than the Elastica H&E stain. However, it is more consistent, more reproducible, and it is not as labor intense as the Elastica H&E stain. Thank you, and I am happy to take any questions.
Thank you very much, Dr. Manal Atwan, for this valuable information. Has anyone got any questions, please? It was very well explained about extramural venous invasion. Anyone would like to ask anything, please? So we don't have any questions at the moment. So thank you very much for this information.
Thank you.
You are welcome. Now we are going to invite our next speaker. I will call upon our next speaker, Dr. Pooja Dwivedi from India, to deliver her speech, please.
Am I audible?
Yes, please.
Good evening, everyone. Myself, Dr. Pooja Dwivedi. I'm post-graduation student, MD Pathology at King George Medical University, Lucknow, India. I'm going to present a very interesting case of primary fibrosarcoma of breast, which mimic invasive ductal carcinoma. As a part of introduction, breast fibrosarcoma is a rare tumor. It is one of breast sarcomas, which are rare and account only 0.1% of malignant breast tumors. Amongst the primary breast sarcoma, it is the most common subtype, accounting for 16% of all soft tissue sarcomas of the breast. Primary breast sarcoma is defined as malignancy originating from mesenchymal tissue of the breast and does not include those arising from skin, muscle, and adjacent bones. Sami Albana reviewed English literature and found that 98.5% of breast sarcoma occur in women and only 1.5% in men. So my today's objective is to study an interesting case of primary fibrosarcoma, breast mimicking invasive ductal carcinoma. As a part of clinical background, we received a right breast lumpectomy specimen. We processed sections and stained it with hematoxylin and eosin, and immunohistochemistry was also done. A 48-year-old female presented to us with complaint of painful, recurrent, progressive right breast lump for 3 years. She had a history of prior to lumpectomy in the same breast at an interval of 7 months. In histopathological examination, her first excision biopsy report was not available, and her second excision biopsy report was diagnosed. In her second excision biopsy report, she was diagnosed as spindle cell sarcomatous lesion consistent with fibrosarcoma. On CT scan, she has a right breast carcinoma showing enhancing soft tissue attenuation mass, lesion of size 39 into 31 millimeter. Small right axillary lymph node were also seen. In gross examination, we received a lumpectomy specimen with nipple areola complex, measuring 8.5 into 6.5 into 3 centimeter. It was a well-defined grayish-white tumor with a variegated appearance measuring 3.5 into 2.5 into 2 centimeter, and it was present retroareolary, and it has a fleshy appearance. On microscopy, the section from the breast and nipple areola complex show a malignant mesenchymal neoplasm disposed in seeds and intersecting fascicles, along with the focal area of myxoid degeneration. In high power view, individual tumor cells are mild to moderately pleomorphic, having oval to elongated nuclei with irregular nuclear chromatin, inconspicuous nucleoli, and abundant pale eosinophilic cytoplasm. There was 6 to 7 per 10 high power field mitosis was also present. On immunohistochemistry, tumor cells were strongly and diffusely positive for vimentin, and Ki67 index was 10% in tumor cells, and Desmin, S100, CD34, ER, PR, and HER2 were negative in tumor cells. Here we can see the vimentin, which is diffusely positive in all the tumor cells. Here tumor cells are arranged in fascicles, and vimentin is showing positivity for in tumor cells. CD34 was negative, and CD34 is positive in internal control in blood vessels. ER was negative in tumor cells. PR was also negative in tumor cell, and HER2 was also negative in tumor cells. So on the basis of this, our diagnosis on the basis of clinical history, radiological investigation, and histopathological and immunohistochemical examination was fibrosarcoma of breast. As a part of discussion, according to Sorov and et al. And their clinical data, breast sarcoma is rare malignancy that account for 0.1% of malignant breast tumors, and incidence of breast sarcoma is about a quarter of that. Radiologically, fibrosarcoma breast is partially circumscribed, uncircumscribed, high density mass on mammogram, and hypoechoic lesion on ultrasonography. Differential diagnosis of fibrosarcoma breast include invasive ductal carcinoma, malignant phyloid tumor, and synovial sarcomas. Fletcher believed that breast fibrosarcoma is a diagnosis of exclusion. So first, we were confused with malignant phyloid tumor, invasive ductal carcinoma, whether it is these or fibrosarcoma. So we will see malignant phyloid tumor and fibrosarcoma's feature. On gross examination, malignant phyloid tumor is having lobulated architecture, word vacillated cut surface in a leaf-like pattern, skin ulceration, hemorrhagic and cystic changes may present. While in fibrosarcoma, on gross examination, well circumscribed clear boundaries and tough texture was there. On microscopy, phyloidal epithelium formed by an exaggerated intracanalicular pattern, subepithelial condensation with increased stromal cellularity, stromal atopia, and stromal overgrowth in malignant phyloid tumor, and infiltrating tumor borders, and high mitotic count is also there. While in fibrosarcoma, the high cellularity is there, spindle cells arranged in fascicles lack epithelial component called herringbone pattern, and fusiform spindle-shaped cell having scant cytoplasm with distinct border are there. On immunohistochemistry, malignant phyloid tumor is positive for cytokeratin ER, vimentin, CD34, BCL2, and P53 is increased, and Ki67 is also increased in stromal cells. And P63 is focal positive in malignant phyloid tumor, and it may also negative for P63. In fibrosarcoma, almost same ISC we use for fibrosarcoma, but CD34 is negative in fibrosarcoma. So immunohistochemistry. So what were the features in our case in favor of invasive breast carcinoma? As the patient was younger age, less than 65, patient was 45-year-old, and patient is having large tumor. On CT scan finding were oval circumscribed mass, and increased risk of recurrence was there. it was 2-time recurrence, and higher node positivity was there. More likely to present with the metastatic disease at diagnosis, and ER/PR HER2 negativity was also there. Also there. So in invasive breast carcinoma, hormonal therapy does not work, and hormonal therapy of trastuzumab does not work if triple negative type invasive carcinoma of breast cancer is there. So to our patient, we found it difficult to be distinguished from invasive carcinoma of breast, malignant phyloid tumor, and synovial sarcoma of the breast. According to medical history, radiological investigation, and histopathological and immunohistochemical examinations, absence of epithelial component on extensive sectioning ruled out the possibility of cytosarcoma phyloid in our case. Immunohistochemically, positivity to vimentin and negativity to CD34 and desmin infer to the diagnosis of fibrosarcoma breast. Treatment for fibrosarcoma breast is extended surgical resection or mastectomy, and it is a preferred treatment. And these tumors are also known for hematogenous spread rather than lymphatic spread. Prognosis of the disease is related with tumor cell differentiation, tumor size, and surgical assessment. In conclusion, primary breast sarcoma constitute a specific clinico-pathological entity that carry different prognosis and therefore should be differentiated from malignant phyloid and metaplastic carcinomas. As this is a recurrent, distantly metastasizing tumor, so timely correct diagnosis, wide local excision with clear margins, and chemoradiotherapy treatment can prevent this tumor metastasis. These are my references. And I want to thank and express my gratitude to my professor, Dr. Madhu Kumar ma'am, for teaching and providing me such an interesting case. I thank her for giving me her valuable and constructive suggestions during planning and making of this project. Her willingness to give her time so generously has been very much appreciated. Thank you so much.
You are very welcome, Dr. Pooja Dwivedi, and thank you for sharing this valuable information with us. Has anyone got any questions from Dr. Pooja, please? Any questions? So if you have any question, you may leave it in chat box. So now I am going to call upon our next speaker, Dr. Jayashri HK from India, to deliver her speech, please. Thank you.
Am I audible?
Yes, please.
Yeah. Is my screen visible?
We are just waiting. Yes, now it's visible. Thank you.
Yeah. Good evening, everyone. Myself, Dr. Jayashri. My topic for poster presentation is manifold chromosomal abnormality with TP53 mutation in a case of AML-M2, a rare case report. Coming to the background, acute myeloid leukemia. Since I have a great interest in hematology, the reason for choosing this topic. Before coming to the topic per se, I would like to thank UCG platform for giving me this opportunity for my poster presentation. Acute myeloid leukemia is a tumor of hematopoietic progenitors caused by acquired oncogenic mutations that impede differentiation, leading to the accumulation of immature myeloid blast in the marrow. The replacement of marrow with blast produces marrow failure and complications related to marrow failure. Cytogenetics and flow cytometry are the valuable tools in the clinico-pathologic management of leukemias. Case report. A 55-year-old female, known diabetic and hypertensive, already immunocompromised, presented with recurrent UTI with frequent candidal infection and cystitis. The routine hematological test revealed anemia, which was hemoglobin of 7 gram per dl, and with leukocytosis. Total leukocyte count was 22,800, and moderate thrombocytopenia, it was 50,000 of platelets. Peripheral smear examination showed increased number of blasts, 31%. She was referred to a dedicated hematology team for further workup. Bone marrow aspiration and biopsy was conducted. Cytogenetic and molecular genetic studies were also done. Flow cytometry using FACS analysis on bone marrow aspirate showed abnormal blast population of about 22.5%. This is a bone marrow aspirate picture showing blast with maturation, and the arrow showing ore rods, which are acidophilic granules, which are present only in myeloblast and not in monocyte. This is a differentiation features because to describe myeloblast, it have delicate nuclear chromatin, 2 to 4 nucleoli, and more voluminous cytoplasm than lymphoblast. Here, presence of ore rods is the pathognomonic feature of AML-M2. Following fluorescent level antibody markers were used against CD antigen. The antibody panel included were CD34, CD19, CD10, CD20, CD22, CD38, CD2, CD3, CD4, CD5, CD7, CD56, HLA-DR, CD13, CD14, CD15, CD33, CD64, CD117, which is the AML marker, CD123, and cytoplasmic myeloperoxidase. In the above mentioned antibody panel, CD34, HLA-DR, CD33, and cytoplasmic myeloperoxidase were moderate positive, which all these CD markers expresses myeloid lineage cells, and CD117 moderate to bright positive, which is an AML marker. CD38 and 13 were dim to moderate positive. For myeloid blast, a combination of CD34 and CD117 can be used to define immaturity of the blast. Myeloid lineage is suggested by expansion of antigens including CD13, CD15, CD33, and myeloperoxidase. Myeloperoxidase is an important marker to differentiate myeloid lineage and lymphoid lineage. Myeloperoxidase is only positive in myeloid lineage. Monocytic lineage is suggested by expression of antigen including CD4, CD14, and bright CD33 and 64. Cytogenetic analysis. Karyotype abnormalities and clinical features were linked with abnormal antigen expression characterized in AML. Our patient presented with complex karyotype. Complex it is called because there is damage in more than 3 subsets of chromosomes. 45, 46, XX, deletion of 5q21, deletion of 7q22, -12, addition of 8p22, and addition of 16q22. Cytogenetic analysis. Complex karyotype. As I said before, there is abnormality in more than 3 subpairs of chromosomes, that is complex or monosomal karyotype, which always conveys high risk and relapse. Deletion of 5q21 results in loss of tumor suppression by adenomatous polyposis coli gene. Deletion of 7q22 results in loss of CUX1 gene, which is a low frequency mutation gene. Mutation in CUX1 gene results in dysregulation of PI3 kinase pathway. This is a flow cytometry of the first relapse, which showed MRD of 0.6% of all viable nucleated cells. Here, the third image, the orange indicates erythroids, the red indicates blast, and the blue color indicates lymphocyte, and the green color indicates granulocytes. So in this figure, abnormal blast events show dim to moderate CD45 with low to medium side scatter. Subset of blast show bright CD34 and CD117. CD13, CD33, and 15 and MPO are bright positive. Aberrant CD56 expression is noted. CD34 and 117 define immaturity. CD13, 15, 33 define myeloid lineage. CD4, 14, 33, and 64 define monocytic lineage. This is MPO positive. This is a dot plot of showing positive bright aberrant CD56. The later MRD after transplant showed abnormal blast events 1333, which downregulation with aberrant CD7 and CD56. Come to the result, the final diagnosis of AML-M2 with complex karyotype and TP53 mutation. To call AML, the blast percentage, the maturing percentage of blast should be more than 10%, and presence of TP53, which is an unfavorable prognosis, and MRD will always be positive with increase in relapse and expected with complex karyotype. So here, if there are more than 10% of maturating myeloid cells, there will be always CD45 dim positive with low to medium scattering in a blast window. Refractory AML-M2 with TP53 gene mutation is very rare and seen in only 10% of cases and leads to relapse even after effective cytotoxic chemotherapy with poor prognosis. Hypomethylating agents with BCL2 inhibitor were used, conditioned with triosulfan, fludarabine, and taken for allo-HCT. Predicting the prognosis, bone marrow transplantation can be considered over chemotherapy for better outcome in high-risk cases. Discussion. Flow cytometry is crucial for detection of leukemic blasts, blast lineage assignment, and identification of aberrant immunophenotypic features that allow distinction of abnormal blast population from normal progenitors. Leukemic blasts frequently show immunophenotypic deviation from the antigenic expression pattern seen on normal hematopoietic progenitors of similar lineage and maturation. This basic principle allows for the recognition of leukemic blast, determination of the immunophenotype, and subsequent classification in AML. Molecular genetics. Most patients have multiple gene mutations and dynamic pattern of disease. This is a challenge to deal with. This patient presented with TP53, a tumor suppressor gene mutation located on 17p13.1. TP53 encodes for the guardian of the genome. Its frequency of mutation is up to 10% in de novo cases, more than 20% in therapy-related myeloid leukemias. In AML, there is strong mitogenic signaling, and the cell cycle inhibitor genes such as TP53 are frequently lost. TP53 gene mutation. Most patients have multiple gene mutations and dynamic pattern of disease. Treatment protocol. Patient was given hypomethylating agent, that is 100 mg of azacitidine initially. Blast percentage was significantly dropped, but patient relapsed after 3 cycles. Even with the addition of BCL2 inhibitor, that is venetoclax, blast count increased to 33 and later increased to 50%. High-dose chemotherapy, which is HiDAC with cytarabine, failed to achieve the goal of remission. The last option considered was resort salvage therapy with fludarabine, triosulfan, and conditioning regimen for bone marrow transplant. After the transplant, the donor mapping was done and the recipient mapping was done, comparing the both post-transplant on day 21 of marrow showed 100% of donor stem cells. Post-engraftment blood workup showed 99.17% donor DNA and 0.83% recipient DNA on 50th day of transplant. Conclusion. Cytogenetics and flow cytometry are the paramount importance of clinician in tailoring and prognostication of disease treatment protocol. Unlike many other human cancers, a vast majority of acute myeloid leukemias display no genomic TP53 alterations, but in AML associated with TP53 mutations, chemoresistant and high-risk relapse is certain. After chemotherapy, the measurable residual disease positivity was shown of 0.6%. So, bone marrow transplant was done. After transplant, the later MRD showed up 0.16% of MRD, which is least expected in this unfavorable aberrant CD56 expression, which is NK cell marker, and also TP53 mutation, which is high indices for refractory and relapse. These are my references. Thank you.
Thank you very much, Dr. Jashri, for enlightening us with this information. Has anyone got any questions, please, related to AML or P53, please? If you have any question, please leave in the chat box. Otherwise, here we are coming to close this day one of the conference. So thank you, Dr. Jashri, for being with us. And I would like to thank everyone for enlightening us with their valuable work done in the field of pathology and sharing the outcome of their clinical expertise in 6th Emirates Pathology and Digital Pathology 2021. It was an opportunity to listen to the well-renowned speakers. Here we are closing the session for day one and looking forward to see you all at 8:50 a.m. London time by tomorrow. Thank you. Stay safe.